Good morning and welcome to Paediatric Emergencies 2025. My name is Ben McNaughten. I'm a consultant paediatrician with special interest in respiratory medicine based in the Royal Belfast Hospital for Sick Children. I'd like to welcome to our conference today. This is now the 7th time we've run this course and the 6th time online. And one of the beauties of running it online is it makes it freely accessible to people from all over the world. And it's great to see so many people already logged in and enjoying us, and we always love getting the feedback whenever we work to see how many people have joined, where you've joined from, and it's great to see such a diversity in the audience today. So we hope you're looking forward to it as much as we, the panel, are. We've got a really exciting program lined up today. Hopefully you've had a chance to check this out on the Paediatric Emergencies website. As you'll see, lots of great talks on really important topics from experienced clinicians, many of whom you'll recognise from previous paediatric emergency courses and initiatives. So looking forward to it. Hopefully there'll be something for everybody and there'll be actual pearls of wisdom that you take back that will really make a difference to your practice and help you to deliver the best possible care to the children and young people that we look after. Just want to flag up that although it's online, we do want this to be interactive. We will be running a series of polls and votes throughout the day. We'll also be encouraging you to post questions for the panel and for the speakers. And the way we're going to do this is through the YouTube chat. So to access this, you do need to sign into YouTube. This is probably worth doing at the start of the day so that it allows you to interact and engage with us as much as possible. In terms of the questions, we will have time at the end of each talk for a couple of questions. Unfortunately, we won't be able to get through them all. That's just the nature of the time limitations that we have today. But if there are any questions that come to mind as the speakers are talking, please put them into the YouTube chat. We have a panel working in the background to select a few questions, which I think will generate some discussion and some great learning. So as the question comes to your head, put it in the chat. Don't wait until the end, because if you wait until the end of the speaker, then actually we might have already chosen a couple of questions. So as they come into your head during the talk, put them into the chat and we'll keep an eye out and try to get through as many as possible. You will get some information throughout the day in terms of feedback. We're really keen to hear what you thought of the course today. And we reflect upon the feedback, and that allows us to change and structure future courses. So please do let us know what we've done well, what could work better, and this is important as well when it comes to getting the certificate at the end of the course. So please do provide feedback at the end of the day. As you will be aware, this course is free, and one of the things that allows us to do that is the support of our sponsors. And I'd like to, all of the sponsors available on the Paediatric Emergencies website. I'd like to give a special mention today to Healthcare 21, who have donated a McGrath Mac video laryngoscope as the prize for who wants to win a McGrath educational quiz, which will take place after lunch today. So special thanks to Healthcare 21 for this. I'd just like to give a special mention at this stage as well to Little Heroes. Some of you who've joined in previous years will have known them as Helping Hand. They've rebranded, but this is the charity of the Royal Belfast Hospital for Sick Children. As I mentioned, the course today is free, but if you find it informative and interesting and would be keen to donate something to acknowledge the work that's gone into today, we'd really encourage you to consider leaving a small donation for Little Heroes. QR code takes you to the Just Giving page for them. They're a great charity, and when they were Helping Hands in the very early days, they give a lot of support to the Paediatric Emergencies team as they were trying to get things up and running with equipment and support for courses, etc. So we're very grateful to them. They do a fantastic job raising money for important equipment and funds for the children who are here in Belfast. So if you do feel that you've learned something today and want to contribute, please do. There's no recommended donation. This isn't that we're not encouraging to leave a large amount, but if everybody who's present today could even leave a small donation, it would mean the world to the charity. Furthermore, if you've enjoyed today and would be keen to sort of engage more with the Paediatric Emergency team, and I'd be really grateful if you could join us for some of our future courses. Again, further details are available online. next at the end of April and start of May next year, and we have 2 courses running back to back. These are face-to-face, in-person courses running in Belfast. First day is the Paediatric Emergencies Intubation course, and the second day is the Paediatric Emergency Practical Workshop, where we run through common scenarios, pediatric emergency scenarios with some simulation and try to make it really interactive. Great courses, get lots of good feedback. And it'd be great if you haven't been on them before, if you could join us for those. So details are available via those QR codes. There might be some issues with traffic on the site today, but if you're having issues with that, go again over the next few days to the website and check out how you can register for those. That's all I have to say by way of introduction, other than that I hope you really enjoyed today. We're looking forward to it. There's a lot of hard work has gone into it. And we thank the panel later in the day, but I'd like to thank them at the start because I'm aware of the amount of work that's gone in even to get to this stage. Hopefully it's informative, useful. There'll be some learning that will change your practice going forward. And that's a really good day. So thank you for joining us. We look forward to what lies ahead today. And without further ado, I'm going to hand over for the first talk of the day to Dr. Gyula Tövisházi, who is a consultant in pediatric transport based in Hungary, who's contributed in the last few pediatric emergency conferences. It's great to have him on board today and to draw upon his expertise. And so I'm going to stop sharing my slides now and hand over to Gyula to take things forward. So Gyula, over to you.
Thank you so much, Ben. And very, very happy and very honored to be here again. So my name is Gyula Tövisházi. I'm from Budapest, Hungary. I work partly as a pediatric anesthetist at Semmelweis University, Hungary. And I'm also medical director of our specialized pediatric retrieval service called St. Martin's Ambulance. And today I'm here to talk to you about vascular access complications. And this is the 3 main topics I prepared. So first we are going to talk about peripheral IV lines in general. Then some interesting cases about extravasation and extravasation injuries due to IV lines. And third, maybe some news about intraosseous access. So I hope it's going to be useful, and I'm happy to have any questions during or after the talk. But first, could you please answer, with using the YouTube chat, could you please answer this question? My first interactive question is about first attempt success rate. So what is the first attempt success rate in pediatric peripheral IV access in general? Is it 24%? Is it 39%? Is it 50%? 65%? Or 83%? Obviously, this is a difficult question, and it depends on lots of things. I'm curious about your thoughts and hope this works well technically. I now wait for another 5 to 10 seconds so that everyone who wants to vote can submit their votes. And let's see what the poll looks like. So it's still working, but as I see, most of the people voted on C. Let's see what my answer is. Actually, I agree. So at least according to these 2 articles I found about this subject, only around 50% of our first attempt at peripheral IV cannulation is successful. I think it's quite a shocking number because if you take into account what first attempt success rate do we accept at airway management like intubation, 50% is quite poor, and obviously, as I mentioned, it depends on lots of reasons. One of the articles is something to do with ultrasound-assisted venous access, and we will later show that it can improve these results, but generally this 50% is unfortunately true. Obviously, there are difficult patient groups who are very difficult to cannulate, like these healthy, chubby infants. But there is a term in the literature called DIVA, so difficult IV access patients, who are even more difficult to cannulate. I think everyone knows them in their neighborhood, especially who works in tertiary pediatric centers. For example, premature babies, cystic fibrosis or short bowel syndrome patients belong to this group. Hemato-oncology, chronic renal failure, or babies after cardiac surgery can also pose a very significant risk of having difficult IV cannulation success. If you use an ultrasound, it's a very nice thing and very powerful thing to do, I think, but there are certain very important considerations. As in this picture, you see that the operator prepared a very easy ergonomics, which means that they only have to look down on the IV line or up to the screen, but no turning of the head is required. And I think it's the preparation and ergonomics is even more important in this topic than how skilled you are with your hands. Also, I found it important that it's no team sport, which means that the same person should hold the ultrasound transducer who are holding the cannula as well, because even with one person, this coordination is not so easy. So I think it's important for it to be in the hands of the operator. Maybe you will need a longer cannula than expected. For example, on this baby, he doesn't need a pink cannula from any clinical standpoint. We only chose this one because it's long enough, and we hope that it's going to not only reach the vein, which is lying quite deep underneath the adipose tissue, but there is also going to be some space for the cannula to be advanced. Also very important not to start on patients, but to use of ultrasound phantom first, and only if you are very comfortable and completely signed off about these procedures, then you can proceed to a real patient, I think. Let's see some cases about extravasation. My first case, which happened a few years ago, was a 12-year-old boy undergoing alveolar bone grafting, so a maxillofacial surgery due to cleft lip and palate. The surgery and the anesthesia was also quite uneventful, but after 1.5 hours, unfortunately, an extravasation of both the propofol and the crystalloid infusion was noted. If we take a look on the images, I think they are quite shocking and quite disturbing, but luckily, as you see, we put on a pulse oximeter probe on the finger. It showed a very good perfusion distally, and luckily no surgery was needed. This swelling and this painful discoloration resolved until the next day and improved quite significantly, and no surgical input was needed. Although I'm not really used to any of these conservative issues, I'm curious about your thoughts and what the panel can add, because on this Australian guideline, I found some interesting conservative management options, like this so-called washout procedure, and also 2 medications which can help, although phentolamine is more involved in cases where vasoactive substance like noradrenaline is extravasated. If someone is interested, I put in a QR code which leads to this Melbourne website. This is a very useful input, I think. But let's switch to case number 2, which is a 10-year-old girl. We managed recently. She has liver failure due to portal vein thrombosis, and she presented with a massive upper GI bleed, needed transfusion, needed octreotide infusion, and also underwent an acute upper endoscopy with endoscopic varix ligation. The next day, she was transferred for a CT angiography, and she also needed some inhalational sedation for this, even for this short CT scan. Unfortunately, the contrast material extravasated, and so by the time she was transferred back to our department, the dorsum of the left hand looked like this, which was very painful as well. And this process was quite heading into the wrong direction. So our plastics team was consulted, and compartment syndrome was diagnosed, and a very urgent fasciotomy and negative pressure wound therapy, so a vacuum therapy, was instituted. The wound could only be closed after 6 days, and luckily the complete function of the hand is restored, but the patient needed quite long physiotherapy and long-term follow-up. So this is really a long-term issue, and this is something we really have to pay attention to. The third case is unfortunately also a very bad thing from several years ago. This was a preterm baby receiving total parenteral nutrition because of having multiple abdominal surgeries. This day, his central venous line was malfunctioning, was dislodged, and for a temporary few hours, unfortunately, a decision was made to switch the whole parenteral solution to a peripheral line, which was unfortunately a bad decision, and ended up in such a significant extravasation of high osmolality glucose, amino acids, and lipid solution, which also needed surgery, exploration, and delayed wound closure. Luckily, this wound also managed to heal, but this was a quite awful time for the family, as you see. This table shows a very nice picture of the different solutions, different medications, putting into 3 categories. So as you see, in the green box, these medications have a lower risk of tissue injury in case they extravasate. The yellow table shows you an intermediate risk, and in the red box, inside the red box, you see very high risk solutions. I would emphasize cyclovir, calcium, and any high osmolality solutions like TPN, like in the third case. But as this green box highlights, unfortunately, no intravenous infusate is considered to be safe. Even normal saline can cause problems in case there is a too high pressure, and in case there is a compartment syndrome. It can cause significant injuries. So we really have to focus on prevention. And I found a very important and interesting input from UK's NIVAS, so National Infusion and Vascular Access Society, which on their posters and flyers, they highlight the importance of this topic about prevention, early recognition, and in case it's needed, so in case the so-called high-risk solutions, vesicants, are extravasated, an early plastics or surgical input and consultation can be needed. So if you notice a child who has a running infusion and develops pain, swelling, dark necrotic skin or blisters, and erythema, you want to make sure that there is no dislodgement or no tissuing happened around the cannula. Let's see the last topic, which is about intraosseous access. And maybe I'm going to tell you some news about the recent years. I borrowed this nice image from Don't Forget the Bubbles website, which shows you the locations where we, as pediatric emergency providers, can choose to put an IO in. So the IO cannulation sites. Probably you and our service also is most familiar with the proximal tibia, which has a very nice medial flat surface, and 1 to 2 centimeters from the tibial tuberosity below, you can put it in very easily. But there are also other sites. The distal femur is one of them. The distal tibia is another of them, and the humeral head is also a possibility. I think it's more used in adults, but in case the child is more than 6 years old, or in case there is trauma of the lower extremities and the pelvis, which would mean that the tibial IO line would not be appropriate, you can choose the humeral head as well. It's a bit different, and you have some certain aspects for palpation and the cannulation direction, but it can be very useful and very successful first aid. This short video shows you how effective and how successful correctly placed IO line can be, because the contrast material reaches the femoral vein very quickly, and actually it acts as a central line. But let's see what really matters. So what sizes and what locations you should use. The manufacturer of the most popular device, EasyIO, with which I have nothing conflicts of interest to have. So the manufacturer of this EasyIO device has 3 needles. The pink one is 15 millimeter long, and it's theoretically it's advised for patients between 3 and 39 kilograms, which I think is a quite broad range. The blue device is the blue cannula is 25 millimeters long. The yellow one is 45 millimeters long, and in the recent 5 to 10 years, we had a clinical experience and an impression. Several providers of our service had this impression that the typical 1-year-old baby who needs an IO line because of a cardiac arrest or a septic shock or something like that, in this patient, pink line is not enough, and we had lots of problems with dislodgement and extravasation, and maybe this was due to this needle being too short for this population. So what we did was do some literature research and found 2 very useful articles, which I'm going to present to you in the next slide. But the manufacturer also suggests that before starting to drill, at least 5 millimeters from this needle should be outside the skin, which would mean obviously that in case it's not appropriately sized, then you have to open another needle, which is quite expensive, I think. So what these 2 articles say, which were actually radiological observations about X-rays taken from several babies and children. This article shows, without going too much into detail, that more than 10% of the so-called appropriately sized needles didn't even reach the medullary cavity. This other article coming from Canada also shows us that if you change from a pink to a blue needle, which is longer, then you can save lots of extravasations because of the pre-tibial fat pad and the pre-tibial soft tissues. So because of these 2 articles and because of our own experience, we decided to do an arbitrary limit change. So what we do nowadays is only use a pink one for babies younger than 6 months. For every child older than 6 months, we use a blue one, and for adults or obese teenagers or humeral access, we tend to use a yellow one, although obviously we don't at every occasion put it to the full length, of course. Let's see what complications can an IO line have. As mentioned previously, an extravasation is quite a significant and quite frequent issue, unfortunately, and improper placement or improper size choice can be a very important cause of it. Infection and osteomyelitis is quite rare, but that's the thing why all of the guidelines suggest that an IO line should be removed as soon as possible. And there's two other questions I would like to mention. The first one is in case you have to put in an IO line, so an intraosseous line to a patient who is awake, then you have the issue of analgesia. This is obviously not a very frequent situation because most of IO lines are put in during cardiac arrest or unconscious patients, but there are some situations where you have to do this. And this German article and this German working group issued a statement about intraosseous lidocaine, because previously even the ERC has suggested intraosseous lidocaine infused slowly into this cannula to prevent the injection pain, which is quite significant. But these German colleagues published three cases. I'm not going to go into this German details, but they wrote down these 3 cases which were involved in the death of 3 children, which was every one of them was associated with local anesthetics getting into systemic circulation. Although I think it's a bit not so clear, because these causes involved even not only lidocaine but also mepivacaine, which is a highly cardiotoxic solution, and also there were some issues with medication safety with very high doses. But still, they actually banned intraosseous lidocaines for safety reasons. And if you take a look at the newest guidelines of ERC, they don't specifically ban, but also don't recommend intraosseous lidocaine anymore. They suggest that an alternative such as intranasal opiates or intranasal ketamine should be used. Obviously, this needs a stable enough child. You have to weigh the risks of providing analgesia over speed, of course. Okay, so let's see our last topic, and therefore I also have an interactive online question. Do you think that intraosseous needles are MRI compatible? So can you bring a child who only has an IO line in to the MRI scanner safely? A is yes, B is yes, but only in a 1.5 Tesla magnetic field, and C would be no. So these are the possible answers. I'm curious about what you will vote on. And now we wait a few seconds until we reveal the correct answer. All right, so let's see what people voted on. It seems that it was a very controversial issue. Actually, it's I'm not sure who won, but let's see what the current literature says. about IO and MRI. It's quite a new thing. So last year, the manufacturer of EasyIO managed to get FDA clearance and issues a statement about these needles. And according to them, and according to this PDF, which I highlighted here below this QR code, they say that EasyIO needles are so-called MRI conditional, which means that with certain conditions fulfilled, you can bring a child to or an adult to an MRI scanner. So if you have a child who only has an intraosseous needle in place, it's very well functioning and fixed, and this is and the MRI scan is urgent and is indicated, then you can bring this child to the MRI. You only have to take into account one consideration. You are obviously not allowed to put in a needle inside the MRI scanner because the device itself, it's not MRI compatible. But the needle itself is. So it's good to know that from now on it's a possibility. Although I would every time I would consult with the radiographer and the radiologist on call about this issue. All right, so these were the points I wanted to mention and wanted to discuss. I'm open to questions, and these were my take-home messages. Peripheral lines are the commonest invasive procedure in pediatric healthcare, and at the same time we have a very high failure rate, so we always have to consider the options and use ultrasound with good preparation. Extravasation injury is unfortunately quite common as well. Prevention and early management, early surgical input when needed is key. And at last, we also discussed IO sizes, analgesia options, and MRI compatibility. So this is the feedback QR code, and here you can see my email. Please feel free to ask a question in the YouTube chat or through email. And thank you so much for your attention.
Thank you very much, Gyula, for a great talk. And it's always important to remember that actually in trying to help with procedures such as getting IV access, we can also cause harm, and it's about doing that in the right way, particularly when scenarios are difficult and tricky. We had a couple of questions came through in the chat. One was around, you'd mentioned at the start about difficulties in IV cannulation in children with short bowel. Is that just because they've been unwell before and by definition of the condition have had lots of multiple previous venipuncture attempts, or is there any other particular reasons as to why that is?
No other particular reasons, just the fact that they need multiple and lots of IV cannulations, probably central lines as well during their lifetime, and it's unfortunately, as far as I know, it's a lifelong condition, so they don't need it only this time, but they are going to need healthy veins in the future as well, so that's why.
Yeah, perfect, thank you. And I suppose question to yourself or panel, you mentioned around intraosseous access, and obviously proximal tibia tends to be the most common site. Do yourself or any of the panel have any experience of using other sites or any preferences or change in that practice towards other sites at this stage?
Actually, what I found useful several times was the distal femur, but we only use alternative sites in case we run out of tibias, so to say. So our first choice is probably most of the time the proximal tibia. That's what we have the most experience with.
I have attempted to use the humeral site a couple of times, but there are limitations with its use, especially in a trauma patient, just due to the arm position. And we are very familiar with using tibial, so it's a lot quicker and a lot easier for us. But when thinking of central and an older child, that is something that is a teenager, that is something you could probably consider as well. But tibial is our go-to quick access due to familiarity. Costas?
Thanks, Tudor. Yeah, Costas.
A common challenge we have is, and we've used the phrase, I don't know which of the boys used the phrase running out of tibias, but a common mistake we find when we go to retrieve very sick kids from a hospital that's tried to stabilize them is they've had a failed IO, and then they've taken the old IO needle out. And if you think of the bone as a long hollow tube, once you've pulled that old needle out that's not working, you can't use that bone again because everything's just going to leak out. So you can use the same tibia twice, but you need to leave the previous needle in. In those situations, if IV access can be postponed and get an IO in for the interest of giving inotropes or anything else faster, we have used the anterior superior iliac spine, so just on the top of the pelvis, which is very easy to get in. That's where hematologists use to take bone marrow aspirates. It's safe, it's marrow rich, so and it hits the patient fast. So it's not in most books, but increasingly because it's so easy to hit that spot as a plan B or a plan C for IOs, it works really well.
Perfect. Thanks, Costas. I'm not sure any other questions from any of the panel at this stage. If not, we'll maybe move on. We're slightly ahead of time, a few minutes. We'll maybe move on to our next talk. Thanks again, Gyula, for that great talk. Our next topic is intubation in pediatric cardiac arrest, and Dr. Chris Flannigan is a pediatric intensivist here in Belfast, and many of you know him from the Paediatric Emergency courses and conferences, and he's going to talk on intubation in pediatric cardiac arrest. So over to you, Chris. Thank you.
Thanks, Ben. Can everybody hear me okay and see my slides?
Yep, perfect, Chris.
Yep, lovely, thanks. So I'm going to talk today about intubation in a pediatric cardiac arrest, and the idea for this talk came up when I was helping one of my juniors with this particular problem. And we sat down and talked about what the issues you were likely to encounter and what I thought the solutions to it were. I realised I actually had quite a bit to say about this. I've had intubated numerous children in cardiac arrest over the years, had a number of really bad experiences and things that have gone wrong, and like you do, you learn from each of them. So hopefully you will find this talk useful. And even if you're not the person who is expected to do this, as you'll see as the talk goes on, you may find yourself having to do this. So hopefully a lot of the points I'm going to give you will be helpful. So the first thing I want to do is look at why it's so important that we intubate children and why there's more emphasis on intubating children in the guidelines. And that is the reason is why they actually arrest. So the most common reason kids arrest is hypoxia. So when they arrest, they have blood that is depleted with oxygen. Adults, it's commonly an arrhythmia. So quite often they're arresting with blood that is already well oxygenated. And that's why it's so important in kids that we emphasize oxygenation. And to me, it just makes sense. The best way to provide oxygenation to that kid is with a cuffed endotracheal tube in the trachea. You're going to bypass all that source of upper airway obstruction that is really common in kids. The airways are much more difficult to maintain than they are in adults. You're highly likely to get lots of gastric content coming up. People are bouncing up and down in the chest, and the child didn't know they were going to arrest, so they quite often have a full stomach. And having that cuff tube in the trachea is just going to protect the lungs. It's going to allow you to use those high pressures that quite often you need to do to be able to move the chest in sick lungs. And it's going to allow you to do continuous chest compression. So for me, the perfect recipe to getting ROSC, but it's not the only option that we have available to us. So the bag valve mask is probably the one most people are going to start with, and probably one that most people are most familiar with. My major worry with it is that I think you could be doing this in a cardiac arrest and doing it badly and not realize that you're doing it badly because of lack of feedback. And I've explained why. I think you're losing a lot of the things that you would have if you were putting the kid off to sleep routinely. So the first one, if you don't have a great seal around the kid's face, you'll hear a leak. The problem in a cardiac arrest, it's absolute pandemonium going on around you. There's lots of noise. You might not hear that leak. What about movement of the chest? So if we're putting a kid off to sleep routinely, we'll have the chest exposed so we can see if it's going up and down nicely. The kid comes into cardiac arrest, they're not probably exposed. Somebody's bouncing up and down the chest. You're not going to see particularly how well you're moving that chest. What about the other things we look for? Well, end tidal is absolutely brilliant. It's one of the best markers of your face mask ventilation. But unless you were expecting that child in and you'd prepared in advance, you're probably not going to have that in the circuit right at the start. So there's another marker you're losing. So hopefully if we're struggling to ventilate a child, we'll have picked it up. But if we haven't picked it up, the one thing you'll notice then is your SATs are going to start to fall. And again, that's the final marker that you've lost in a cardiac arrest. You're not going to be able to use SATs as a reliable marker of your face mask ventilation. So actually you're doing this pretty much blind or with minimal feedback that is what you're doing is effective. Other problems with it, certainly the stomach is going to be full and there's a reasonable chance your child's going to regurgitate and aspirate. So this doesn't protect the airway. The other issue it's going to do is you're hoping to get gas to go down into the lungs, but a large amount of gas is going to go into the stomach. It can inflate the stomach and splint the diaphragm. So if you are doing face mask ventilation for more than a short period of time, I would strongly encourage you to get an NG tube in and continuously aspirate that stomach, because you're going to just decompress that stomach and hopefully make your face mask ventilation easier. The other option we have is a supraglottic airway, be it an LMA or an iGel. And again, I think my concerns with this is lack of feedback for the same reasons we've given with the face mask. If your LMA isn't properly positioned, again, hopefully you'll hear a leak around it, but again, in the noisy cardiac arrest environment, you mightn't pick that up. And likewise, you're going to have equal problems with spotting chest movement, end tidal, and saturations. You're going to have lost those other markers of how effective your LMA ventilation is. And my worry is you've got one of these in, you're thinking you're doing a good job when you're not oxygenating the patient. The other big problem is it's not a secure airway and there's a high risk of regurgitation. And the number of kids I've seen coming in with iGels in that are absolutely blocked with vomit, when we're taking them out to intubate the kids. And the other thing is you're fairly unlikely, even with a well-placed iGel, to get a good enough seal that you're going to be able to do continuous compressions when continuous ventilation. You're still going to have to stick to intermittent compressions and ventilation. So I'm a little bit biased here on endotracheal intubation, but that's not actually based on a lot of good evidence. The last major sort of systematic review that looked at this was back in 2019. They compared tracheal intubation, supraglottic airways, and bag valve mask ventilation for kids in cardiac arrest. And they found there was no advantage to endotracheal intubation over the other methods. They did acknowledge, however, that the quality of the evidence out there is really poor. I think that's what you would expect. It'd be really hard to do a randomized controlled trial on this. And if I was standing at the bottom of the bed and was told the child was randomized to face mask ventilation, I wouldn't do it. I would intubate them, because I think that is the best way of getting ROSC from the most common cause of cardiac arrest, hypoxia. So what do our current guidelines say? Well, they say you should start off with a face mask ventilation, and ideally this should be done with a two-person technique. And that just makes sense. The person using the bag valve mask, at least initially, is going to be somebody who probably doesn't do that on a regular basis each day. So if you're using a two-person technique, you're more likely to get a good seal. And because you don't have that feedback, it's going to give you the best chance of providing oxygen to that patient. What you do then depends on whether the face mask ventilation is successful or unsuccessful. If it's successful, makes sense, keep doing it. And you do that until somebody with advanced airway skills arrives. And then you should only then intubate the patient if you can do so with minimal interruption to chest compressions. So what if it's unsuccessful? Well, it depends whether you've got somebody there with advanced airway skills. If you do, you should intubate the patient. If you don't, you should put a supraglottic airway in. They don't go on to say what you should do if the supraglottic airway fails, but I think in this instance, you're probably going to be forced with somebody who is less familiar with endotracheal intubation, i.e. not that airway expert, probably having a go, given that the other two techniques have failed. So hopefully this talk will be relevant to everybody. If you are an airway expert, hopefully I will give you some tips and tricks that will help you take your intubation in a cardiac arrest to the next level and make it more successful. And if you're not, hopefully these skills will help you if you do find yourself in this position one day. because in a cardiac arrest, you're highly likely to have a difficult intubation. Everything is lined up against you to make this as difficult as possible. And there's a number of technical factors that are going to make it difficult, which I'm going to talk about. And there's a number of human factors that are going to make this an incredibly difficult intubation. But before we get on to that, I want to talk a little bit about the timing. When should you intubate the patient? And for me, it's pretty obvious. Hypoxia is the most common cause of cardiac arrest. Although there's not the evidence saying that intubation is the best way to combat that, to me, it just makes obvious sense. So once you have your equipment, once you have the right person with the airway expertise to do it, to me, it makes sense to do that without any delay, because obviously the longer the arrest goes on, the less likely you are to get ROSC. So in terms of the timing, I'm often asked, should I wait for a pulse check before I attempt intubation? And my answer to you is strongly no, for two reasons. The first is you will be delaying a potentially life-improving intervention if you decide you're going to wait to do it, and that doesn't make sense to me. You should do it as soon as possible. And the second is, I think if you wait for a pulse check, I think you're highly likely to cause the one thing the guidelines say you shouldn't do, and that is interrupt chest compressions. The pulse check's only going to take a matter of seconds, and if you are there getting your view and having a look, when people are ready to start up again, they'll not want to interrupt you, and there will be a little bit of hesitance about whether they should restart those chest compressions, and you're very unlikely to get your tube in those few seconds the pulse check takes place. I also don't think you need to have the patient completely still to do your laryngoscopy. You may want them still for passing your tube, but that should only be for a couple of seconds, and I'll talk about how to technically do that later on. Another really important thing here is you should not be doing a checklist before this. Hopefully to the majority of you this is obvious, but I have seen, and certainly a lot of the sims that I run, that people are taking timeouts to do checklists at times they should actually be looking after the patient. Patient's rapidly hurtling towards death. I expect them to arrest in the next minute, and people are standing over at the side doing a checklist, talking about the things that might happen rather than dealing with the things that are happening in front of them. So for me, a checklist is it's an absolutely brilliant tool. It's designed to be used in a period of stability when you're about to do an intervention to the patient that may make them unstable. And the idea is you talk about one, how to prevent that, and two, if it does happen, what you're going to do about it. But it's not a good tool for when a patient is ready in an emergency and you are actually delaying treating that patient to talk about things that might not actually happen. The other important thing here, you can see from this slide, there's an awful lot of kit that you're going to need to prepare for routine intubation. And you don't want to say to your airway assistant, get set up for intubation, because they may well go out and get all these bits of equipment that you're not necessarily going to need. So it's really important that you get just the bits that you're going to need to do the tube so you can get it done as quickly as possible. So what do you actually need? Well, you're going to need a laryngoscope with an appropriate size blade. You're going to need a cuffed endotracheal tube with a stylet in it, and I'll talk about why you need a stylet later on. You're going to need a syringe to inflate that cuff, and because you're highly likely to have a soiled airway, you're going to want to have suction to clear the airway out. So be really specific about what you want, and that's going to get you your equipment much quicker. So I would like a McGrath with a size 1 blade, a 3/0 cuff tube with a stylet in it, and that's going to get you intubating much more quickly than just saying to your airway assistant, get set up for intubation. In terms of the equipment, these events tend to happen in remote areas of the hospital, and I'm not a big believer in relying on the ward staff there to have all the advanced bits of kit that I'm going to want to do the intubation. To check that they're all kept in date, they've been replaced when something has gone missing. And I think it's much better if you're that airway expert going out to these remote areas to bring your own equipment with you. You can often get these bags that are laid out in an ergonomic way, so when you open them out, you've got everything that you want, and it just makes the whole process so much simpler. Probably the most important thing that you're going to want when intubating is a skilled airway assistant. And I say skilled in that you want somebody who does this role on a regular basis, because they are so valuable to you in getting this task done when it's difficult, and even when it's routine. Just anticipating what you're going to ask for next and having it ready for you. And when I started off as a consultant, I used to run out to the wards, run out to the emergency department as quick as I could to cardiac arrests. And I very quickly learned I was better to spend the extra 30 seconds going and bringing a skilled airway assistant with me, going down with the right bit of equipment, and us coming as a package was so much more valuable than me being there 20, 30 seconds quicker. So that would be my plan A, go out with a skilled airway assistant. But plan A doesn't always work in healthcare, and particularly with cardiac arrests, we sometimes have to improvise. And there's a few things that can go wrong if you're using an improvised airway assistant. The first thing for me is it will not at all be on the team leader's radar that they need to allocate an airway assistant to you. And you can't intubate without one. They'll be focused on, okay, I need somebody to do chest compressions, somebody for airway, somebody for vascular access, somebody for drugs. But the airway assistant is often forgotten about, so you're going to need to tell the team leader, I need somebody as an airway assistant. The other thing is, if that's somebody who doesn't do that on a regular basis, is they will tend to run off on you at some point during that procedure. They'll go ahead and get the equipment that you've asked them to get. What commonly happens is they plunk it down on the bed beside you, and because their own adrenaline is absolutely sky high, they can't possibly stand still. They've got you what you've asked for. There's loads of things need doing and things that they're much more familiar with. And I've had this happen to me before where I'm saying, give me the tube, and I look over and the airway assistant is no longer there. They've gone off drawing drugs up. So another thing I would say is tell that airway assistant, you need to stay with me until we're done. Another thing to think about is how do you get that equipment? So if you're going with a makeshift airway assistant, they'll be much less familiar with the advanced airway kit that you're looking for. So even if you've given them really good instructions, I want a Miller 1, a size 3 cuff tube with a stellate in it, that may be like another language to that person. And they'll go over to they'll not want to tell you that, they'll go over to the airway trolley, they'll have a look through it, trying to find the bits. If they do, they'll not be familiar with putting that stellate in the tube. And you'll maybe get a laryngoscope handed to you in 2 parts, which I've had a number of times. So in those situations, what I would do is coming down to the arrest, I would look and see if the person at the top looks like they're doing a good job with the face mask ventilation, and I don't have my skilled airway assistant with me, I'll often go over to the trolley, get my own kit. It's only going to take me 20, 30 seconds to get, and then I'll go straight over to the airway and do the intubation. And that's just a much more effective way of doing it. And obviously I'll have to revise that if I'm not happy with what's happening with the airway beforehand, because oxygenation takes priority over intubation. Final thing to mention under the airway assistant is you're going to want to avoid sources of delay in intubating the child, and there's 2 common sources that I often see. The first is the person has got all the airway equipment ready but hasn't told the intubator, and quite often the intubator is a senior person. They're looking to see what's going on with the arrest. They may be providing a bit of assistance to the team leader, and if you don't tell them as the airway assistant I've got everything ready, there's going to be a little bit of a delay in the intubation. So that's something, if you're the airway assistant, tell the intubator, I've got your equipment ready. The other thing that I see in less experienced people doing this is they're standing at the top of the bed waiting for the team leader to tell them to go ahead and intubate. And I don't think that's right either. I see the intubator and the airway assistant as a separate little team at the top of the bed. You don't need to know what's happening in the current state of the arrest, where they are, what they're working through. Your job is just to look after that airway and look after that tube. Once you've done the tube, of course, you can then get involved in the other bits, but you should be at that top of the bed just looking after that airway, and as soon as you're ready to intubate, go ahead and do it without delay. You don't need the team leader to tell you to do it. The other important thing is that you can't lead and intubate at the same time and do both effectively. And that's a problem, because quite often the person who's best to lead is also the person who's best to do the intubation. So if you do try to do that, the problem is you will neglect the team leadership role and miss things which could have an adverse outcome for the child. And the other thing is you're going to struggle with the intubation as well, because people will be telling you things as the team leader, and that's going to be distracting you from doing the procedure. So if you do find yourself in that position, what I would encourage you to do is hand that team leadership role over to somebody else while you do the intubation. You can go to the top, do the intubation. What I normally do is I'll put the tube down, I'll give it a couple of bags, I'll check it's happy, I've got my end tidal, the chest is moving, I'll take a look at where it is at the lips. I'll say 12 centimeters, hand that to the airway assistant, and then that frees me up to either go and do another critical intervention or take over the leadership role, because I'm not going to stay at the top of the bed once the intubation's done. But it's important that I hand that role over to somebody else while I'm doing that. So now we come on to the technical factors that are going to make intubation difficult. And for me, I think there's 4 major things that make intubation difficult in a cardiac arrest. The first is positioning. So normally when we were preparing a child for intubation, we have real focus on lining up our oral, pharyngeal and tracheal axes. So when we look in through that mouth, we're going to have the best view of the laryngeal opening. How we do it varies depending on the age of the child. So for a baby, quite often we'll put a little roll onto the shoulders. For an older child, it's maybe a pillow onto the head. But we're going to try and get the tragus of the ear and the sternal notch on the same horizontal level. We're also going to want to make sure the child is close enough to us so we're not going to have to stretch. And we're going to make sure the bed is at a nice comfortable height. So we've got everything perfect, giving ourselves the best chance of getting a good view of that laryngeal opening. The problem in a cardiac arrest is you can't do that. The kid's often halfway down the bed, they won't be straight. Somebody's bouncing up and down on their chest, and you can't say, would you mind stop doing that for a little second while I just get them positioned, pop a wee roll in, because you're going to have to go on ahead and intubate in less than perfect conditions. For me, the best way to deal with this is a video laryngoscope. And if you think what you have to do with direct laryngoscopy, you're trying to line all the axes up with the laryngeal opening and your eye, and there's quite a bit of a distance between them. So all these positional factors will have a major influence on the view that you get. With a video laryngoscope, the camera is not your eye. It's only with a matter of less than a couple of centimeters back from the tip of the laryngoscope. So you're actually going to bypass a lot of those positional problems. So for me, my first plan would always be to use a video laryngoscope when intubating these kids, because it's the best way to combat the inevitable positional problems that you're going to get. Second thing is, don't forget about external laryngeal manipulation. You're likely to get a more difficult view, and you see just how easy it is to improve it with a little bit of external pressure. And the advantage with the video laryngoscope is your airway assistant can see what you're seeing. So they're going to be able to do that pressure, leaving your hand free to deliver the tube. The key thing is just don't forget about it. It's so easy in a cardiac arrest not to think clearly, and you've got that difficult view, so don't forget about your external laryngeal manipulation. The other problem you're likely to get in a soiled airway, and while I've said the video laryngoscope is the best way to deal with a positionally difficult airway, its major enemy is anything in the airway in terms of blood, vomit, secretions. And unfortunately, in a cardiac arrest, you're highly likely to have this problem as well. You can pop your video laryngoscope in, and because of where the camera is all the way down near the tip, it's going to end up in that pool of vomit, which is highly likely to be there and obstruct your view. Don't worry, however, there is ways that you can use the video laryngoscope in the soiled airway. One thing I like to do, if I'm expecting the airway to be soiled, I'll spend a second just to put the anchor down and clear anything out before introducing that video laryngoscope at the start. Other things that you can do is you're going to want to take your time and work your way down slowly, staying high and dry. If you counter anything in the airway, use your suction to clear it as you're working your way down. Don't just shove the blade into it and contaminate it. And then you're hopefully going to be able to see past it. The other really important thing is use a good quality video laryngoscope. The McGrath Mac, which is, we're going to show you a little bit later on, is with prize for one of our courses. A couple of years ago, they upgraded the image quality, and it's made a massive difference. With the old grainy image quality, if you had anything obstructing the airway, you just couldn't see. With the new improved image quality that you have in it, you're able to see past those little areas of obstruction, pick out the normal structures, and it just makes all that difference in being able to do the intubation versus having to take another go. But inevitably, even if you use a good video laryngoscope, you take all the steps I've told you, at times you will go in and just get this view, and there's nothing that you can do about it. This is when you need to remember that the direct laryngoscope is your friend. And it's all to do with where that camera is. And with video laryngoscopy, as I mentioned, it's going to be right down in that pool of whatever's in the airway. With direct laryngoscopy, your camera's hopefully nice and safe all the way up here away from it. So hopefully you're going to be able to see better past that partial airway obstruction identify the normal structures, and deliver your tube. The other big problem that we're going to come on to then is movement. And I have told you that I think you should be getting your laryngoscopy view with the chest compressions ongoing. It can be difficult, one, getting that initial view, and then once you've got that view, keeping that view. But there is a technique that works really well for this. And if you can't see what the problem is here, I want to show you ultrasound, and I think you'll all be shouting at the screen why we're struggling to get a good view here with the movement ongoing. So like everybody's probably shouting at the screen, the issue here is we don't have contact with our patient. And if we add that contact in, you'll notice that with the same movement, we're able to keep our picture on the screen. The problem is people don't teach this with laryngoscopy, and for me, I think it is just so important. If you want to see that again, so same amount of movement, look at the difference with just having contact with the patient. You go down and you lock that view in, and then you don't lose that view on the screen, despite an awful lot of shaking, and certainly more shaking than you're probably going to get with chest compression. So just having that hand on contact with the patient's face and just locking that view in. It works just as well with direct laryngoscopy. With direct, I like to add a little finger just onto the chin and just holding that in place. And when I'm teaching this in the intubation courses, my party trick is I'll pick the model up at this stage, wave it around in the air, pop it back down and get somebody to have a look, and the view is still there. I think this is so important. I do this with every intubation. It really helps just hold that view there when you're swapping from an oral to a nasal tube so you're not losing it. But it's really important when you're intubating, when there's movement ongoing. It just gives you that stability. And once you've got that view, you don't lose it. So moving on to the final problem that I think you have, technically anyway, is difficulty with tube delivery. And I think this is probably one of the most common. And you're more likely to get it in a cardiac arrest, but we've talked about the reasons why. You're not going to be able to position the patient perfectly, so you're probably going to have less than an adequate view. And just having a stylet in the tube gives you that wee bit of extra control to deliver that tube into the trachea when there's a less than perfect view. I would strongly encourage you to use a stylet in your tube for all video laryngoscopy intubations. For me, I think it is an essential bit of kit. There's a couple of reasons for that. The first is with direct laryngoscopy, because your camera is all the way up at your eye, you need to actually really displace the tissues out of the way so you can directly see all the way down to the laryngeal opening. With a video laryngoscope, because your camera is only a tiny bit back from the tip, you'll pop it in and you'll get a beautiful view with very little lifting pressure. And because you've got a beautiful view, you won't displace the tissues quite as much as what you do with direct laryngoscopy. So you don't make as much space for your tube, and you don't make as straight a passage to the tube, so you're always working around a little corner. And having that stylet in just gives you that wee bit of extra control to combat it. The other problem you get with video laryngoscopy is there's no video laryngoscope on the market that is as thin as a direct laryngoscope. And you can see this McGrath Mac with a size 1 blade on it. It's obstructing quite a bit of this kid's mouth, both on a right to left plane, but you can see how far it blocks you up in an anterior to posterior plane as well. So there's only a tiny little corner left, and people love to work down this tiny little corner. The problem with it is you don't have movement to deliver that tube. It's catching on the device, and you just can't turn it the way that you need to get it to go into the laryngeal opening. Look what happens when you make space. It's so easy, you can't miss. And people forget to do this. Exactly the same with direct laryngoscopy. You can see here, lovely grade 1 view, no problems, but we haven't made space for our tube. So it's catching on the blade and it's difficult to deliver. Watch what happens when we make space. It's almost like cheating. How can you miss this? You've just got all that room to turn the tube no matter what way you have. And this is probably the biggest problem I see, is that people don't make space for their tube. They've rushed, so they haven't got the best view, and then they're working down a little corner, not making space for that tube. So what I would encourage you to do when you're struggling to deliver your tube, rather than taking it out and making it into a really hyperangulated bend, check 1, have I got a good enough view, can I optimize it? And 2, make some space for your tube by extending the blade either further forward or over to the left-hand side, and you'll probably find that you actually don't need to reshape your stylet and the tube will pass without any difficulty. The difficulty is doing that in a cardiac arrest, and people don't think clearly, and that's your own adrenaline been high. We talk about the fight or flight, but the big problem I think with cardiac arrest is the freeze response. It doesn't mean that you're standing in the corner doing nothing. It just means that you don't think as clearly as what you would do. And people often go, why didn't I think of that? And that's the reason. It's your own adrenaline being high. There is a way to combat it, and that is just more experience of cardiac arrest, more experience of intubating in stressful situations, that you're going to get that adrenaline response and potentially that freeze response. It's like driving a car. When you start off, you have to think about everything you're doing, and if somebody pulls out in front of you, you don't have the skills there to deal with the unexpected. The more that you do, the more experience you have, the better you are to deal with the problems that become. It's more like an autopilot that you're on and being able to deal with them. And I think simulation is the best way to deal with these problems. The big thing is if you just do simulation and don't make it stressful, you never test yourself when things are going wrong or when you've got that freeze response from the adrenaline. So the sims I like to do, I like to make them stressful. I like to make something unexpected happen to try and simulate that adrenaline production and give people experience of dealing with that stress response and seeing how they cope with it. Because if you cope with it under a sim scenario, you're better to cope with it when it happens for real. So I'll show you a little bit of footage from a sim that we set up where I'm trying to simulate that stress response with something unexpected happening. So the model you've got here is the one I've already shown you. It's the easiest model in the world to intubate with. It's easy to get a grade 1 view. The model doesn't regurgitate, but I've made it regurgitate for this scenario. So the people who are intubating have intubated many times before. They know it can't regurgitate, so they're going to be absolutely shocked when it does. So how I've done that, I've got 2 pressure bags of saline with white food colouring in them. They're going to a 3-way tap, so when one bag empties, I just need to flick the tap and we're on to our second bag. They're making their way down to an endotracheal tube, and that endotracheal tube is in the esophagus. And I've also blocked off the trachea with another endotracheal tube and a clamp so that anything that comes into this model ends up coming out the mouth. And this really creates a stressful situation, so it gives people a real chance to test their skills in dealing with something unexpected. And I'll show you a little bit of footage from the last time we ran this.
Someone to draw off the NG, please. I'm not going to be able to see very much until I've suctioned. So if you can do the suction for me, Claire, have to do the suction. Not yet. There's still lots of stuff on the tube at the moment. But we need airway first. We're not going to get it's Does somebody need getting the adrenaline push dose, please?
Yeah, we've given that there.
Great. Let us know when 2 minutes have gone.
That's 180 mils out of the stomach.
Okay, the tube is gone past.
So for me, simulation is an absolutely brilliant tool, but for me, you have to make it stressful. And that is the best way to improve without dealing with real patients. So in summary, what I think my key learning points are: intubation and cardiac arrest, you need to expect it to be difficult. Everything is lined up against you in terms of the human and technical factors, but there is ways to deal with them. In terms of who does the intubation, ideally that's somebody with advanced airway skills, but as we've mentioned, if your face mask ventilation and supraglottic airway fails, it might need to be somebody who isn't technically an airway expert that tries this. When do you do it? In my opinion, as soon as possible, as soon as you've got those advanced airway skills and equipment available to you. In terms of the equipment, be specific about what you want. Take your skilled airway assistant with you if you have one. If not, remember to tell the team leader to assign you one, and also tell them not to leave you. And as well, think about going to get the equipment yourself rather than sending somebody off to get equipment they're not familiar with. Remember, you can't lead and intubate. If you are the best person to do both, allow somebody to take over the leadership role while you do the intubation. In terms of the technical factors, positioning, the best way to deal with that is a video laryngoscope. The soiled airway, you can still use a video laryngoscope if you're careful, but remember, when it fails, direct laryngoscope is what's going to get you out of trouble. Movement, I think it's so important to have that contact with the patient's face, locking that view in. And in terms of tube delivery, the common reasons you're failing is, one, you've rushed and not got an adequate view. So think about improving that view. Think about making space, and that tends to work much better than reshaping your tube or doing anything with your right hand. Okay, so that's the end of my talk. Hopefully you have enjoyed it. If there's any questions, I'm happy to take them now. And you can go ahead and scan that QR code, leave me a bit of feedback, and you'll be able to get your certificate.
Thanks very much, Chris. Really useful talk around what is, as you say, a highly pressurized scenario, which is made technically difficult by many of the factors that you've discussed. Thought it was useful, just some practical tips around movement and making contact with the patient, but also the non-kind of procedural side of things, in making sure that you're happy with your airway system and how you manage equipment and assistance. So really useful. There's a couple of questions came through on the chat. One around, obviously you've talked about the benefits of the video laryngoscope, but there are times, for example, with secretions where view is limited, where you might have to revert to direct. Do you have any concerns that there's, with the move to video, that there's going to be a loss of skills, or how do you ensure that your trainees remain skilled in using the more traditional direct laryngoscopy as well as videos?
It's an incredibly difficult problem, Ben. Our trainees aren't being taught direct anymore. They're just being taught video, and as we know, when video fails, direct is what's going to save you. We in the intensive care are less lucky than our anaesthetic colleagues because we only intubate sick children. So the ideal thing would be, if you're doing routine intubations, that you would have the opportunity to do both in a controlled, calm environment. It's a big problem for us in the intensive care because we're only intubating sick kids. And even for myself, I'm doing one direct intubation every few years. So it's a big problem, and I think it's only going to get worse as people are losing those skills. I don't have a good solution for it.
Nope, that's okay, and I suppose that reflects, that's probably the reason for the question in the first instance. It's a common theme across centres.
The other thing though is it's the big advantage of what the video offers. You know, moderately difficult airways are normally easy if you with the skill of video laryngoscopy, where you would struggle so much. So there's advantages, even though there's disadvantages on the other side.
Perfect, thanks. The other question that came through on the YouTube chat was around, you had mentioned about the use of always using the stylet in these scenarios with the video laryngoscope. There was a question of when would you opt for a bougie rather than the stylet. Have you any thoughts or comments on that?
Yeah, so this question comes up. I think a lot of this is operator dependent. I can talk for a while on bougies. I'm not a fan of them. They're sharp, pointy objects that you ram down into fragile airways. When I talk about this in the intubation course, I show videos of people trying to hold them still, but they always end up getting pushed down into the airways. And I've seen, particularly in small neonates, a number of kids who've perforated airways from bougie use. So for me, I don't like them. There is other places that's their routine practice. So it's very rare that I'll use a bougie. I much prefer bougies in older patients with direct laryngoscopy, but with video, I'm very much into stylets. But there'll be a lot of variation from where you are in the world and what your practice is. But I think we can't just bring adult practice down into small patients, and I would have worries that people were using bougies routinely in small babies.
Thanks, Chris. We've just crept past 10 o'clock, so maybe in the interest of time we'll move on. But thank you again for really interesting and useful talk full of practical tips. For those of you who have seen the original program, there is a slight change. So you may be expecting Dr. Peter Donnelly. He's actually swapped with Dr. Peter Cosgrove. So Dr. Donnelly's going to join us after the morning coffee break to give his talk. But next up is Dr. Peter Cosgrove. He's a paediatric emergency consultant based in the Royal Belfast Hospital for Sick Children. And he's going to talk on physiological pearls you'll use tomorrow, interactive resuscitation cases. So Peter, thanks for joining us. We're going to hand over to you now if you'd like to share your slides. That's them. Brilliant. Thanks.
Thanks very much. Good morning, everyone. Thanks for having me again. Over the next 25 minutes, I'm going to share 3 patients 3 systems and 3 physiology concepts that will hopefully change how you manage the sickest kids in your ED or ICU or hospital tomorrow morning. These aren't theoretical physiology, these are Tuesday in the PICU. So let's get started. I want you to think about these 3 paradoxes: giving fluid to a patient with an already high CVP and saving their life, ventilators causing cardiac arrests, and 100% SATs, but still dying patient from hypoxia. They seem impossible, but by the end of this talk, each of you will make perfect physiologic sense of these. And more importantly, you'll know what to do about them when you see them clinically. So let me take you through our roadmap for the next 20 minutes. There are no tricks here. This is grounded case-based learning, so I hope you enjoy it. The first is cardiac, when traditional circulation runs backwards, and we'll talk about Fontan or single ventricle physiology. Respiratory case, when your ventilator becomes the enemy, and we'll talk about dynamic hyperinflation. And then, of course, a lot of people's favorite topic, we will talk about shock. I want you to commit to an answer based on physiology, not just pattern recognition. But with that said, and we'll do audience polling, where I hope you'll think like a physiologist instead of just an algorithm follower. So let's jump into our first case. This is about a circulation that really defies everything you learned in medical school. I'll give you a minute to read that. It's a 5-year-old with a completed Fontan who presents, basically, as you can see, with shock after 3 days of gastroenteritis. Looks fairly straightforward, right? Hypotensive, tachycardic, little hypoxemic, cool extremities, delayed cap refill. Volume depleted, give fluids. But there's something special about the circulation that makes this patient exquisitely sensitive to volume loss. Once, I can tell you, once the patient would get to the ICU and someone placed the right IJ, their SVC pressures may measure as low as 8 millimeters mercury. In a normal patient, this might be okay, but in a patient with this physiology, it's a disaster. So let's move into our first poll. I'll give you about the guts of a minute to read this and do the poll. So what is the primary physiologic derangement causing the patient shock in this case? Do we have pump failure? Is a myocardial problem? Do we have inadequate preload? It's just volume depletion. Is it that there's a high pulmonary vascular resistance, or have we a distributive shock from sepsis, secondary to gastro? No. Yeah. So indeed, most of you went with B, inadequate preload, but let me show you why you're right and why this matters so much in Fontan patients specifically. So normal versus single ventricle circulation. These are 2 diagrams on the left of your bidirectional Glenn and on the right of an intracardiac lateral Fontan. So at the top, you can see in a normal circulation, you have 2 sides. Your right atrium pumps to your RV, to your pulmonary artery, to your lungs, and back to your left. So the blood is pumped through the lungs. But in a Fontan or single ventricle, look what's missing. There's no right ventricle pumping blood through to the lungs, and the superior and inferior vena cava connect directly to the pulmonary arteries. So blood flows passively based off CVP, purely on pressure gradient. So this is circulation reimagined, and it really changes everything about how we manage these patients. So even though there are a series of palliative operations, all of these staging procedures aim to direct part of the systemic venous return to the pulmonary circulation, thereby offloading the ventricle. So what this means is that your pulmonary blood flow, so half the work of what a normal heart would do, but in a single ventricle connection, is entirely dependent on your CVP and this equation. So it is your CVP minus your left atrial pressure, what's sometimes called your transpulmonary gradient. So the pressure from the beginning to the end of the lungs divided by or opposed to your pulmonary vascular resistance. So for adequate flow, you need to have a high CVP, you need to have a high SVC pressure, a high driving pressure that's often higher than what you would see in a patient without the circulation, maybe 12 to 18 millimeters of mercury, with a low left atrial pressure, so a big driving gradient, and a low pulmonary vascular resistance. So even modest volume loss that a normal kid can compensate for easily becomes circulatory collapse in a single ventricle or a Fontan patient. And this is why the answer is inadequate preload. The original surgery involved direct anastomosis of the right atrium with the pulmonary artery and placement of valves in the SVC and or the IVC. But it was later recognized that these valves often resulted in obstruction and dilatation of the right atrium, clotting, stagnation of blood, and sometimes dysrhythmia, given the nature of the SA node and the RA. The surgery has been modified in the prior image to the either an intralateral tunnel, internal tunnel from the inferior vena cava through the right atrium, or you bypass the right atrium completely with an extracardiac conduit from the IVC to the pulmonary artery. The most common complication after, say, a Glenn, or where you increase the SVC or the vena cava drive to your pulmonary blood flow, is hypoxemia. And really where you're going to see this high transpulmonary gradient, so very high SVC pressure, likely due to the back pressure after this connection, minus your left atrial pressure, in the absence of a residual, anatomic difference, is highly suggestive of that elevated pulmonary vascular resistance, such as a TPG greater than 10 really suggests impaired blood flow into the pulmonary circulation. Now, remember, the most potent pulmonary vasodilator that we all have in a hospital is going to be oxygen, and that's going to be another big help. So the essential pearls for single ventricles is, pearl one, they're exquisitely volume sensitive because it drives cardiac output. What seems like minor dehydration is going to be a disaster. If a normal kid loses 10% volume, they can compensate fine, but a single ventricle may progress very quickly to shock, and so they need aggressive fluid management. The second is if you have to intubate or support respiratory, positive pressure is very dangerous, again, because it reduces that transpulmonary gradient. Keep those mean airway pressures low because it impedes that passive venous return. For those clinically very astute, you will not have a pulsus paradoxus in this physiology, even with tamponade. The classic teaching doesn't apply because there's no ventricular interdependence. There's just one ventricle, so that finding is going to be absent. And then Pearl 4, which is the one that really haunts those of us who've seen these in real life. CPR doesn't work well in these kids because, again, during compression, blood flows backwards because there's no compressible chamber. During compression, it has to passively cross the lung. And so, like a lot of kids, but especially with single ventricle, do everything to avoid this. So tomorrow's practice, your pearls, aggressive fluids for any volume, minimize mean airway pressures if intubated, don't wait for arrests, do everything to prevent it. And when in doubt, give fluids to keep these high CVPs to maintain cardiac output and to perfuse. So when you hear post-Fontan patient and any mention of volume loss, vomiting, diarrhea, poor PO intake, your immediate reflex should be IV access, fluid bolus, and call the ICU early and don't wait for them to compensate because they won't. The circulation can't compensate, and that's the cardiac pearl for you today. So let's move on to the respiratory one, and I'm going to show you how ventilators can become a problem. Slight mental break here just to separate the cases. For those of you who may or may not have seen this, this is a slight real lived experience for any of us on the front line dealing with kids. All right. After that, always good to shower the head. Little mental break. Case 2. I'll let you read that briefly. As you can see, an 8-year-old with asthma who has been intubated. The vital signs change there. Has become hypotensive, bradycardic, but the stats are still fine. And those are your ventilator settings at the bottom. Head volume, rate, PEEP, and tidal CO2, your peak pressures. So the story is she had been intubated about 2 hours ago and had been doing okay, and then suddenly became hypotensive, bradycardic. But look, her saturations are fine. So this isn't a hypoxemia problem. So what's happening? Let me show you 2 diagnostic clues before we poll. So your resident, your intern, your nurse shows you these 2 images. First, the capnography. You can see how it is rectangular. It's got this upsloping shark fin appearance. That's incomplete exhalation, obstruction. And secondly, look at the flow time curve from the ventilator. In normal ventilation, the flow returns to 0 during exhalation before the next breath starts. Here, it doesn't. The next breath starts while still trying to exhale. These are your clues. So let's poll. I'll let you read that. What is the primary problem causing hemodynamic collapse, hypotension, bradycardia? Tension, pneumo, dynamic hyperinflation, or autopeep, severe mucus plugging, inadequate sedation with ventilator desynchrony. I'll give you a few seconds. So what's causing this cardiovascular collapse? Think about what happens when you can't exhale completely, breath after breath after breath. Where does the air go? And what does it do to pressure in the chest? Super, let's move on. So, yes, as most of you went for, the answer B, dynamic hyperinflation, also called autopeep or breath stacking, is one of the most common and most dangerous ventilator emergencies. And here's what makes it tricky. It's actually iatrogenic. We do it. We're causing it with the ventilator. Now, let me walk you through the pathophysiology. So this is what's been termed the autopeep cascade. Here it is. Step 1, there's severe bronchospasm. You need at least 4 to 5 seconds to exhale, sometimes up to 10 as you get older or into adult ages. Reduced airflow, prolonged exhalation. Step 2, your ventilator is set at a rate of 15, giving only 3 seconds to exhale. So a rate of 16, 15 breaths per minute, 60 divided by 15. But there's not enough time. And this is a great line from, I think I got from Chris before, your ventilator doesn't care. You know, it's going to do what you tell it to do. And then step 3, each breath she exhales incompletely. You get 100 mils trapped. And then with the next breath, another 100 mils trapped. So now 200, and then another breath, and then 300. And you get this progressive hyperinflation. Step 4, all that trapped air creates massive intrathoracic pressure, like having a PEEP of 15 or 20, even though we set it at 6. And then finally, with that high pressure compromises the vena cava, blocks venous output, drops preload and your cardiac output, and in some vagal response, and you get bradycardia. And this is how the ventilator causes cardiac arrest. The diagnostic pearl on capnography, just quickly. So the shark fin tells you there's obstruction, but here's a bonus. If you notice, her end tidal CO2 is 48 millimeters of mercury, divided by 7.5 to convert to kPa. If you had an arterial blood gas, her actual PaCO2 would probably be a lot higher, maybe about 50% higher, 60, 65. And why? So the modified Bohr equation, which is written here, is really, really helpful about why you can be falsely reassured by an end tidal CO2. In obstructive disease, increased dead space means end tidal CO2 underestimates the true arterial carbon dioxide. So don't be falsely reassured by a normal end tidal CO2 in severe asthma. So be particularly aware with this clinical pearl, and as you can see with the equation, it is your dead space volume divided by your tidal volume, and then it's inverse multiplied by your PaCO2. So you can calculate what you would expect it to be. But what you would really see in ours is that these are the kPa's here, calculated, while it actually shows okay. And this is why sometimes some clinical guidelines will tell you to beware of a normal CO2 in asthma. And this is part of the reason, because most of the time you'll have your end tidal, and if there's severe obstruction and increased dead space, that CO2 is actually going to be higher. All right, how do you fix it though? So first thing is you just disconnect from the ventilator. This is both diagnostic and therapeutic, so it's a no-brainer. If the blood pressure improves when you disconnect, sometimes with a push on the chest to help exhalation, you've confirmed auto-PEEP. While disconnected, bag slowly, giving at least 4 or 5 seconds in young kids, up to 10 seconds between breaths in older ones. And then when you reconnect the ventilator, you make these changes. You decrease the rate. This is the biggest impact, taking a breath over 3 seconds, which means, 2.5 seconds maybe for exhalation, to having it to now over 6 seconds, where you've got 5.5 seconds for exhalation potentially, is the biggest single variable you're going to change, much more over your IDE ratio. But that being said, once you've changed the rate, you do drop the inspiratory time, maybe decrease the tidal volume. The goal is simple, just to give more time to exhale. You accept some permissive hypercapnia if you have to, and critically, obviously, you don't increase the PEEP and don't increase the rate, even with that high CO2, because it will make it work. This is not an issue of minute ventilation, minute volume. This is at times counterintuitive. You'll see a high CO2, you want to put up the rate, but these patients are completely different, and this intervention will be life-saving. So to take away from this one in your practice tomorrow, so suspect it when you've got obstructive respiratory physiology in an intubated patient who suddenly decompensates cardiovascularly. Look for that shark fin capnograph. Look at the flow time curve where the flow doesn't return to baseline, doesn't return to zero before the next breath happens. Look for those rising peak pressures and then your cardiovascular changes. First move is just disconnect. It is diagnostic and therapeutic. Give more time. Really drop your respiratory rate to as little as possible and just bag as slowly as you can, allowing the time for exhalation. And remember your end tidal CO2, which sometimes it's very easy to rely on, but the absolute number itself, more than its shark fin appearance or other morphology, the actual number will underestimate your real PaCO2 in obstruction, and you can use your modified Bohr equation to help you out. This is one of the most common ventilator emergencies and one of the most fixable if you recognize it. All right, next mental break, and then the last case, and we'll talk about the patient with perfect oxygen saturations who's still dying from hypoxia. I always love this the cartoon because it really frames the importance of context. You know, my kid doesn't want to get out of bed, you know, for school. Yeah. On the weekend, it's a very different matter. So framing is really important. All right, last one. So the septic paradox, 2-year-old with meningococcemia. Resuscitation so far, you can see the current state there, and then the recent labs. I'll let you read through that for a minute. So this is a classic septic shock picture. We've already given 60 mils per kilo. We started pressors, and blood pressure is coming up. And look, saturations are 99%. Happy days. So the oxygen delivery should be fine, right? But the lactate is 7. The tissues are not happy. They're not getting enough oxygen, and this hemoglobin is 6.5. Now the question is, does transfusion help, or is there something else that we should be doing? Next poll. I'll let you read this. What will most improve oxygen delivery to the tissues? Yes, sometimes a lot of these will happen at the same time, but what would you do next? Bump up the FiO2, more fluid. You know, some of these kids are very leaky and need a lot of fluid. Transfuse, packed red blood cells, or put up the norepidose. I'll give you 60 seconds. Sats are 99, blood pressure is acceptable, but the lactate's 7. Tissues aren't getting enough oxygen. What's the limiting factor? Great. So most of you said, see, transfuse. You're absolutely right. But I want to show you the actual physiology of why transfusion helps when saturations are already normal. This is about the oxygen delivery equation. And if you have your phone, you might want to do a little maths with this. So, absolutely. Here's the key insight. Oxygen saturation is not the same as oxygen delivery. You can have 100% sats and still have inadequate oxygen delivery if you don't have enough hemoglobin to carry that oxygen. But that's self-evident. But let's show you the maths and how this fits in. So the oxygen delivery equation is this, and this is one of the most important equations that you'll see in critical care or resuscitation. So your delivery of oxygen here is your DO2, which equals your cardiac output multiplied by your arterial oxygen content. And this is really what we want to dive down on. So your arterial oxygen content here is your hemoglobin, you know, where most of your hemoglobin, 99%, is bound to oxygen, multiplied by 1.36, which is called the Hofner constant. So your mole of oxygen per gram of hemoglobin, something that which you don't need to remember what it's called, which is 1.36. And then your oxygen sat plus your oxygen that's dissolved in your blood, which is really, really, really small, basically about 1%. And your normal arterial oxygen content, as you can see in the bottom right here, is about 20 mils of oxygen per deciliter. So we've just given fluids and pressors, but look at this second part, the CaO2, and it depends on hemoglobin here and minimal dissolved. So the hemoglobin is really critical. So let's go through it and calculate the patient's oxygen content. So let's do the maths. This current hemoglobin is 6.5. Your CaO2 equals 6.5 times 1.36 times 0.99, right? 99% sats, plus your oxygen dissolved. So that is 9 mils per deciliter. Now I said it for him, and you remember from the last slide, normal is about 20. So he's carrying less than half of your normal oxygen carrying capacity. Now, if we crank up the FiO2 to 100%, we might get the PaO2 up to 100. But that only adds 1 mil because dissolved oxygen is such a tiny fraction. But if we transfuse him with a hemoglobin to a hemoglobin of 10, the CiO2 goes to 13.8, as you can see here. And this is a massive difference. It's a 50% increase. And this is why transfusion matters even when saturations are normal in this context. But is it all FiO2 and blood? How else can we optimize oxygen delivery with this equation? Your delivery of O2 is your cardiac output and your oxygen carrying capacity. We always think of cardiac output and delivery with heart rate and stroke volume, but your CaO2 is critically important in resuscitation and ICU. So we optimize the cardiac output, fluids, pressors, as you can see here. Can't put much higher without complications. Then you optimize your oxygen sats. You give them more oxygen, which is not the limiting factor here with already 99%. And then you optimize the hemoglobin. You increase your CiO2 by 50% in this and improves tissue oxygen delivery. So transfusion, quick context about when to transfuse. So if your hemoglobin is below 7 and you have persistent lactate elevation during optimizing cardiac output, that's when you consider transfusion. You're limited by your oxygen content, not by your pump function. And as a quick aside, because this often gets confused, if you want to know whether the hypoxemia is from lungs or inadequate ventilation, this is where your AA gradient, your alveolar arterial oxygen gradient comes in, which is different. It's a ventilation problem. Elevated means it's a lung pathology rather than ventilation problem, but that's not diagnostic. Today, we're just talking about oxygen delivery, and that's all about the hemoglobin carrying oxygen to the tissues. So tomorrow practice, do know this equation. It will help your delivery of O2 and your CiO2 equation. Remember, your hemoglobin carries far more oxygen that is hemoglobin bound, and only 1% is dissolved. And you can see your septic shock transfusion thresholds, the false trap of apparently high sats, and to ask yourself. So to recap the Fontan physiology, no RV pump. It's all about passive circulation that's preload dependent, even minor volumes catastrophic. Your respiratory auto PEEP happens when you don't give enough time to exhale. Your ventilator becomes the enemy. Disconnect and give more expiratory time. Shock, your oxygen delivery depends on hemoglobin, not just saturations. You can have perfect sats and still be hypoxic if your hemoglobin's low. These three concepts will change what you do tomorrow. So my challenge is think physiology. Is the circulation abnormal or normal? Can my patient exhale completely? And is oxygen delivery adequate? Think physiology first and algorithm second, and understanding the why will make you a better clinician than just memorizing the what. Thanks for your questions. Thanks for your time. Open any questions. Ben, I'll hand it back over to you.
Thanks, Peter. Again, another really useful talk with good, clear take-home messages, which will hopefully influence practice. There's a couple of questions coming through in the chat for yourself or any of the panel. One with regards to children, young people with Fontan physiology, and are they more prone to venous thromboembolism or the sequelae of that? And if so, any particular measures that should be taken in this sort of scenario to protect against that?
Yeah, so it depends where, but it's day to day, not to a significant degree, but when they're sick, absolutely. Because you have that risk profile of multiple surgeries, of being volume dependent, and your flow will reduce. So it's not just your central pressure, but you will have that flow stagnation. So yeah, so you'll be a lot quicker if they're critically ill to keep an eye on their coagulation. It's one of the reasons from a plumbing and surgical perspective why they will go for the extracardiac lateral tunnel repairs now to remove the risk of clotting within the right atrium commonly, although sometimes they can baffle it.
Okay. Thank you. And then another question, I suppose, the kind of dreaded scenario that you talked about, where you've got an asthmatic who's intubated, ventilated, and the challenges of that. And basically asking around the fact that apart from being careful with inspiratory, expiratory time, how do you find the balance between ensuring oxygenation as well as clearing CO2? You've touched on some of that already, but maybe you just want to talk a little bit more about that.
It's a great question. I think we sometimes get stuck looking at the numbers a lot of the time. The rate limiting step, the thing that is causing all the problems for this patient, is their inability to exhale. And so you would address that first. So if you can get on top and allow sufficient time for exhaling, whether, you know, with your adjuncts, with your medications, with your ventilator strategy, dropping your rate to allow 5, 7, 10 seconds, if that is sufficient and you have tolerable SATs and CO2, then that's what you want, to give time for the other medications to work. And so you will have a little higher tolerating of your CO2 and your SATs if you can adjust for that obstructive physiology.
Thanks, Peter. I think in the interest of time, it's now 25 to 11. We're due to have a coffee break from 10:30 to 11, so we're maybe gonna take a break now. I hope everybody's enjoyed this morning's session. It's been great to have 3 different talks already. We've got more lined up after the break. We have a talk on transport and logistics and communication, and then we have an interactive simulation, which will be something a bit different. So really looking forward to that. Hope you can join us again after the break, and we'll be planning to recommence at about 11 o'clock. So thank you for joining, and we'll see you at 11. Welcome back to Paediatric Emergencies Conference 2025. Hopefully you've had a chance to get some refreshments, tea, coffee, and are ready to join us again for the next session. We have two talks between now and lunch. The first is Dr. Rory Sweeney, who'll be talking on transport logistics, and then Dr. Oman and Dr. Mullen will be running an interactive simulation. Without further ado, I'm going to hand over to Dr. Sweeney. He is a consultant intensivist in the Royal Belfast Hospital for Sick Children, and he's going to share some thoughts on transport logistics and communication. So Rory, over to you. Thanks.
Thanks very much, Ben. So yeah, I see Ben says I'm a Rory Sweeney, and I'm actually a paediatric critical care transport consultant working with the NISTAR team in Belfast. So maybe a little bit of a different flavour to this session than some of the other ones. We're going to be looking at if you're required to suddenly move some of these critically unwell children that we're talking about over the rest of the conference, either for reasons that a transport team isn't available or because it's time critical transfer. We'll talk about some of the other things that kind of need to be arranged, or some of the pitfalls to try and be avoided to hopefully make your transfer as smooth as possible. The areas we're sort of thinking about are sort of some specific patient considerations involved in transporting patients as compared to whenever they're in the hospital. Some things that need to be considered from a communication point of view around different teams, communicating with different teams, and also with the ambulance service, and then some things just specific to the travel, the way that you're traveling, and things to think about in terms of being in the back of an ambulance. So this area is going to be covered in a lot more depth for specific conditions in other parts of the course. I just want to touch upon it from the point of view of how stabilization affects your decision making around when you decide your patient is stable enough to be transferred. Obviously, this is condition specific, and in particular with time critical moves, you may decide that the normal things that you would do for certain conditions you have to limit, knowing that definitive treatment is available in another centre, and really your primary aim is to get the child there. That's not to say that you don't do anything that you must do in order to get them there safely, but you're trying to do things in a swift manner and avoid any unnecessary procedures. So it may be that you kind of make do with a couple of IV cannulas rather than putting in a central line. It might be that you avoid doing an arterial line if that'll delay you further, so long as you've got a good non-invasive blood pressure. And it's just to say that with transport, there's often a balance in terms of stabilization. You may be moving with a child who is slightly less than optimal, but if you feel that you're in a position where you're good enough to move, knowing that where you really need to get them to is a pediatric intensive care unit or somewhere that has, for example, neurosurgical intervention or cardiac intervention that you can't perform there, you sometimes have to make a decision to leave a place where you feel a little bit more safe and go into that ambulance and make that journey. Sometimes it's the amount of time that you've been there versus the amount of time that your journey is as well. So if you're making a 30-minute journey and you've been stabilizing a child for 4 hours, and you know that they've been pretty good for those, or not too bad for those 4 hours, stable enough, do you think that they're going to be stable for that other 30 minutes to get you to where you need to go? So that's all I'm going to say about from that point of view. Systematic approaches, checklists, all of those kind of things really help from that point of view. So onto your sort of equipment from a transporting viewpoint, most DGHs, regional centres will have a critical care transport trolley. Oftentimes this is something that's shared between paediatric teams and adult teams. And it might be, I think it's something that's probably becoming increasingly less familiar to people as the paediatric specialist transport services have really picked up over the last sort of 10 or 15 years across the UK and Ireland. But these trolleys are there, and the point is that if you have to use them in a sudden emergency situation, it's much better to be familiar with what's on it and how to use it beforehand, rather than trying to familiarize yourself with these things just as you're about to set off with a critically unwell child. The trolleys themselves are all a bit variable in terms of their layout, in terms of how they function. Many of them, especially if they're critical care trolleys, are at fixed height. So you need to know that you can't move the height of the bed. You've got to get, if you need to get your patient across to the trolley, you need to move your bed that they're on currently up or down. So your theatre or your ED bed, for example. You need to know whether you can prop the head up, whether you can tilt it, things like that. So if you're moving a neurosurgical emergency, you know, can you do a head tilt with the bed? You need to know where your equipment is situated on it and how it's powered. Lots of frontline ambulances don't have 240 volt electric plugs. Many of them are still operating off kind of 12 volt cigarette type chargers, and your critical care transport trolleys are often have an inverter as part of them so that you can power your equipment. Oftentimes those are a little bit more prone to sort of falling out, so you need to be aware of that as well. Knowing what your battery life is on all of the different things. So actually transport equipment in general is pretty good in terms of battery life, but if somebody hasn't actually plugged your trolley in, or it doesn't sit plugged in all the time, then your equipment might not be charged when you're setting off. So all things to kind of consider in your place of work. I highly recommend if you ever think you might be entrusted to undertake a transfer, I would go and find your trolley and familiarize yourself with all of the bits of it, so that you're not kind of in a fluster whenever you're being asked to do something in an emergency. The monitors that are on the transport trolleys are, again, highly variable. There's some that are transport specific. There are other ones that might be something that you're familiar with in your unit that's been slightly modified in order to be able to be used on transport. But again, important to know what your monitoring is. Do the monitors, are they compatible? So whatever you're on an ED, is it going to be compatible with your trolley, or are you going to have to chop and change everything? The other thing is that if not all places have a critical care trolley, you may well be asked to move a patient on a frontline ambulance trolley and to use their monitoring. So it's slightly harder to familiarize yourself with that. But if paramedic teams do come in, and again, if you feel like you might be asked to do a critical care move at some stage, you can always ask the paramedic team in their area to have a look at what their standard monitor is. It often doubles up as your defib for transport as well. So again, have a look at it, see what the monitoring is like on it. And if you're not sure about it and you are being moved with a frontline monitor and a frontline crew, you can ask them to kind of keep an eye on it and keep your eye on it, because obviously they'll be very familiar with it. Moving on to ventilators then, again, there's a variety of things that have been used over the years. Historically, kind of the baby pack, so it was an old kind of conventional ventilator, gas driven. limited in terms of its functions. We're often on transport trolleys. These were sort of replaced by the Oxylog, the Draeger Oxylog 3000s, and now I think more and more places have access to the Hamilton T1 transport ventilator, and certainly that's what we use in our team and across the paediatric critical care transport teams in the UK and Ireland. That's what everybody's moving to. Again, familiarize yourself with it at a time whenever you're not using it in an emergency. Things to recognize about it are there's a couple of different tubings that you can use for it. So there's one that's described as neonatal and one that's described as adult and pediatric. Our cutoff and the cutoff that's used by a lot of transport teams is 10 kilos. So under 10 kilos, you use the neonatal kind of double limb circuit, and over 10 kilos, you use the adult and pediatric coaxial circuit. The manufacturers tell you that there's a much bigger range that they can cover, but I've found that whenever you're starting to use the tubing at the extremes of what it says it's able to perform at, it doesn't ventilate as well. So 10 kilos is a pretty clear marker. It's right in the middle of the ranges for both of them. And again, familiarize yourself with how to set up the two different types of tubing and how to do the checks with the ventilator before you set off. Last bit of your equipment that you should kind of be aware of and familiar with before you set off would be your transport bags. So oftentimes certainly in DGHs in Northern Ireland, these are combined bags between pediatrics and adults. There's a lot of equipment that crosses over. There's a lot of things that are useful, kind of across the board. But I would kind of recommend if you're setting off with a patient, I would have my own little sort of grab bag of things that I would want to have to hand. So patient-specific bag with ET tubes, laryngoscopes, blades, suction catheters, some syringes that you might need to use in a hurry, those kinds of things, just to make sure that you've got something to hand you're familiar with, because it can be a bit of a flap if there's an emergency in the back of the ambulance to try and open up a huge big transport bag and pull all the stuff out of it. You're limited by space. Often people are not quite familiar with them and can't just put their hand on things. So if you know that you've got things that you might need in a hurry in a little pouch beside you, it can make you feel a bit happier. And hopefully you'll never be setting off with a patient on the trolley with all of this sort of amount of stuff around them. The other thing that will be on your trolley is infusion pumps. And at a transport conference a couple of years ago, one of the teams there presented some work that they've been doing around the impact of physical forces on your infusion rates on your transport pumps. So one of the consultants there from Nottingham had presented this work, looking at changing the height of your pumps relative to your patient and the impact that had on drug delivery. Now they also put them in the back of an ambulance and applied sort of acceleration, deceleration forces to it and looked at what happened to it. But we thought it was interesting and decided to set up a little experiment ourselves in our intensive care unit. So basically we had 3 pumps all running at a fixed rate of 1 mil an hour. We had managed to insert an air bubble into the middle of this line. And then once the pumps were running and the clock was started, we moved the pumps either up and down relative to the height of the patient, which is the fixed height of this trolley. So one of the pumps dropped down to the ground. One of the pumps was raised right up to above all these pumps up here, and the other one stayed at the level, and we watched what happens to the bubbles in the line whenever we did that. So this is just to sort of demonstrate as we were moving them. So initially there was a slightly lesser drop. We kind of moved them only down by about 30 centimeters. I felt that probably wasn't reflective of the kind of changes that would happen. So what we're thinking about is a pump that's sitting on a drip stand, for example, and then you have some inotropes running through it and you decide you're about to set off. You take it off the drip stand and you place it down underneath your transport trolley. And we figured the average drop there would probably be about 80 centimeters to a meter. So we took them out the first time. You can see that the alarms go at this stage, but that's just to demonstrate that the power supply has gone on to battery power. So there's been no effect on the infusions at that stage. The infusions are still running. And then we watch what happened to the bubble. So we've got another video here where we're focused in a lot more on the bubbles themselves. So you can see this line is the infusion pump that's going to be raised by a meter. This line is the one that's going to stay static. And this line, the pump is going to be dropped down by a meter. And I just want you to watch, there's a bit of a time lapse on it, what happens to the different bubbles. I'll stop it at various points just to highlight that. So it takes us a few seconds to get the pumps moved into position. So I think it's about 10 seconds before we kind of get things moving. Keep your eye on the top line whenever we lift it up. So there we are, 13 seconds in. That line's just been moved, and you can see there's a sudden surge of drug from that pump being moved up relative to your patient. This is the one that's static, so hasn't really moved much. And this is the one we moved down, and actually it's backed off slightly on that line. So keep an eye. This top one's going to go pretty quick, but keep an eye on what happens to the bottom one. So we time lapse from about now, and we can see now, so we are a minute and a half in. This top line is sort of surged on, so it's already roughly a third, or maybe just between a third and a halfway along the line. This one's kind of going along at your steady rate, so 3 boxes, and you can see that this one that was moved down by a meter hasn't moved at all. So we're a minute and a half there where your drug hasn't been delivered at all. So let's keep going. Here we are at 3 minutes. So we're nearly over halfway with this top line. It's really surged along. We're kind of about a quarter of the way through, a quarter to a third of the way through on the one that stayed steady, but still we're 3 minutes in and this bottom pump hasn't delivered any drug. Let's go a little bit further, and we can kind of see here about 3 minutes 20 is where it starts to kind of pick up. And then from then on, they do kind of move at a steadier rate. They keep up with where they've been at, but you had 3 minutes there where you dropped your pump down and no drug was delivered. So in order to complete that sort of 20 centimeters along the line, the top pump took 7.5 minutes. We've got the bottom pump coming in at 9.5 minutes. And the one that was moved down, we're still going. So it took 12 minutes 40 to deliver the same amount of drug as the other one took. So 3 minutes slower. So basically that whole time that it was stopped, nothing was happening. So why is that important? So many of the things you've got in your infusion pumps, things like your sedation, will have a reasonably long half-life, and it probably won't really matter. If you've got an unstable child and you've got them in vasoactive support, so adrenaline half-life roughly between 3 to 10 minutes. So if you've got somebody who's requiring 0.1 mic per kilo of adrenaline running at 1 mil an hour through your pump, would you like it if your pump stopped for 3 minutes? Probably not. I don't think your patient would like it much either. But even more importantly, your noradrenaline half-life is even shorter again. It's really 2 to 3 minutes. So essentially what we're saying is if you were to suddenly take your pump from a drip stand and drop it down underneath your bed, you could stop any inotrope delivery for at least 3 minutes. So basically you've switched your pump off for 3 minutes whenever your patient was needing that much drug. So the physics of this, we've been trying our best to kind of work out what happens, and haven't quite been able to work out with the guys who run the pumps exactly what the process is, but it's demonstrable from what we've seen. So the idea is just mitigate this wherever you can. If you know that you're going to be putting somebody on a transport trolley and you need to start an infusion, start your pump at pretty much the same level as wherever you're going to be moving it into, rather than having these big jumps up and down, because you will get surges and you will get drops. And we do know that patients often can suddenly become more unstable when we're moving them across from bed to trolley. And if this is having some impact on that because we're moving the pumps around, then taking some measures to make sure that your drug delivery is steady is definitely something that's worth doing. There's lots of other physical forces that are applied during transport that probably are less applicable whenever you're sitting in a bed in a hospital. The impact of acceleration and deceleration forces. So if you've got a patient whose head's facing up towards the front of an ambulance and you brake suddenly, you'll get a kind of surge of blood going upwards. And equally, if you accelerate suddenly, you'll have a surge of blood going down. So kinds of things that you might be moving in a bit of a hurry, either concerns about raised intracranial pressure with a neurosurgical emergency. So you can imagine the effects of braking suddenly wouldn't be very good for your ICP if suddenly you've got a rush of blood going up to your head. And equally, if you've got a patient who's fairly cardiovascularly unstable and you're suddenly accelerating and leaving a load of blood down at their feet, you could have real issues with their cardiac output and then potentially destabilize them. So mitigating these things by driving as smoothly and steadily as you can are really important. Vibrational forces, again, around handling, particularly small babies. If you're going over really bumpy roads or hitting speed bumps really fast, We know that babies don't really like being shaken around the place. So again, smooth and steady, try and mitigate any issues with vibrational forces. Making sure that your patients stay normothermic is vital. And we know the cold weather is coming in at the minute, and the back of an ambulance at 2 o'clock in the morning in the dead of winter is a cold place. Oftentimes these patients have been sitting out for quite a while in theatres or in resus areas, exposed while people are doing procedures to them. And if your patient begins cold, it's impossible to warm them up on transfer. But again, thinking about this before you set off. So if you know you're going out into the back of an ambulance, ask the driver to go out beforehand, turn the engine on, put the heaters up as far as you can, bring things like transwarmer pads along with you, which will warm to kind of 40 degrees for a couple of hours, and have those placed around your patients to try and keep them warm. Noise has an impact on your patients. Certainly, you know, your smaller babies, your kind of late pretermers, you know, we know that noise has an impact on your developmental outcomes, but also it has a real impact on your ability to communicate as a team. It has an impact on how easy it is to recognize your alarms and things like that going off. So just be aware that noise can have a big impact on the transfer itself, and not just on the patient, on the team as well. Lots of communication that you need to do whenever you're setting off on a transfer. And if this stuff doesn't get done right, it can really be frustrating and can impact the effectiveness of the transport and take up a lot of time. There's conversations that need to be happening with the receiving unit and receiving teams, conversations with the transport team, and conversations to be had with the ambulance service if it's a transfer you have to do yourselves. I think historically there would have been a lot of back and forth phone calls that kind of went on, and it became a bit of a jumble trying to get numbers of who was on call and yada yada. Thankfully these days around the UK and Ireland, we've got really good coverage from Paediatric Critical Care Transport Services, and most of these services will also offer sort of conference calling and clinical advice through a single point of contact. So even if it's a time critical transfer, it's always worth getting in touch with the transport teams, getting advice, and they are able to then facilitate some of the calls that are coming into the potentially to the receiving teams, and are also able to coordinate things at the receiving end, which would free you up a little bit to do the important business at your end of stabilizing your patient and gathering up equipment. The other people you might have to speak to will be ambulance dispatch. So if you're being tasked to carry out a transfer yourselves, there is a process across all the ambulance services for this interfacility transfer. So this is the NIAS one, the Northern Ireland Ambulance Service, but there's a very similar document from the Yorkshire Ambulance Service. In fact, it's so similar you'd think they copied each other, and the NHS England website also has a pretty similar piece of work which directs the sort of interfacility transfers that need to be carried out and the response times that are being aimed for. Oftentimes, if you phone ambulance dispatch, especially through 999, you're just going to get it through to a call handler who has a performer that they're going to go through, and they're going to be asking you questions about whether your patient's breathing and are they conscious. It can be a little bit frustrating going through this process because they're not always aware that interfacility transfers happen or need to happen as quickly as you're going to want it to happen. But try not to get annoyed at the process. Go through the questions, try and explain your position. And if there are difficulties with getting it across, in all the control rooms now, there's a paramedic who is available to speak to. So if you feel like you're not getting somewhere with a call handler, you can ask to speak to the paramedic, give them the clinical situation, and hopefully they'll be able to prioritize your call. The sort of ones we're talking about really are the level 2 interfacility transfer calls. So that's for going to theatre for immediate interventions, neurosurgical emergencies, that sort of thing. And you can see that the response time that they're aiming for is 18 minutes. This is the latest data from NHS England about the current response times. So the January performance, we were seeing average response times of 35 minutes. So roughly double what you would hope for. And on the outer edges, we're talking about, you know, well over an hour for a frontline ambulance to get somewhere for what would be a time critical call. I'm only saying this, we know that ambulance services are under pressure, but if you know that you've got a time critical call and you're going to have to phone the ambulance early, give them enough time to get there, because we know that the response times are slower than we would like at the minute. and it's better to have them sort of phoned and be there at the end of the bed when you're ready to set off, rather than only ringing them whenever you're ready to go. Other people who can be helpful to get you an ambulance if you're struggling is your hospital ambulance liaison officers, or your HALO. So they sit in most emergency departments across the UK and Ireland, and they're a paramedic who has oversight of all the ambulances that are sort of parked around your emergency department. And often they will know maybe some crew that can potentially offload to free you up a vehicle that can go. So always worth thinking about your HALO as well. Again, most of the transport teams around the UK and Ireland have some version of this STOP tool, so your safe transfer of paediatric patients tool. I'm mentioning this, we're not only talking about critical care transfers that people are asked to do. I think it's usually clearer if it's a critical care transfer who should be asked to go on it. I think gone are the days where you kind of sent along your most junior member of staff in the back of an ambulance with the sickest child in your region to move them to a paediatric intensive care unit. And in general, if you're a sort of level 3 patient, or you're a time critical patient, there is an understanding that it's generally your senior anaesthetist, senior pediatrician, combination of those who need to go with them. I'm putting this up just to flag up that this is a tool available for those patients who maybe don't meet the criteria for a critical care team transfer. And oftentimes people on the wards are still being asked to suddenly get in the back of an ambulance and move kids who are a little bit unwell but not sick enough for a critical care team. Just know that these tools are out there. There's recommendations for who should be moving patients with different levels of critical care based on different triggers. And if you feel you're being asked to move somebody who's outside your level of competence, it can be useful to kind of go through this and use it as a bit of backup to say, I don't think I'm the appropriate person here, or maybe we should speak to the transport service to kind of get their feel on it. Would they do this as a nurse-led transfer, or would they do this with only a registrar, or whatever it happens to be? Just know that those tools are out there and can hopefully provide you with a little bit of either reassurance that you're doing the right thing, or a little bit of backup if you feel like you're being asked to do something you're uncomfortable with. On that topic, it can be difficult to get your team together and decide who goes on a transfer. It does come down to who's available, but very importantly, it's about who's qualified as well. As stated on the STOP tool there, there's no point in sending somebody along on a transfer with somebody who's an airway emergency who has no intubation skills or no equipment, which has happened on a couple of occasions. We've had transfers kind of coming in here who weren't critical care transfers. So it's really vitally important, if you're the person going, that you're qualified to intervene in whatever way that patient might need. Otherwise, there's probably not much point in you being there, and you don't think you'd be covered, just like you wouldn't be covered in a hospital for doing something that you had no skills to do. The other big question is who then covers for you or whoever goes on the transfer, and that's very complicated. There can be different arrangements within different trusts, but it's always important to remember that somebody needs to backfill, particularly as the move is more and more that you're sending your most senior people along on the transfer, which is appropriate. And also then what time is it? So these things are often happening around shift changeovers. Is it better that the people who have known the kid well because they've been resuscitating them for a few hours go on the transfer? Or is it better to hand over to a fresh team who are coming in but who don't know the patient so well? And again, difficult to answer. There isn't necessarily a right answer. The other person just to remember in the middle of all this as well is your ambulance crew. So asking if they've been on shift and they've been driving around for 12 hours and you're asking them to make a long journey just outside of their hours, can you actually delay it for maybe half an hour to get a fresh driver in? Because you really don't want somebody sleepy to be taking your patient and your team on a long journey just at the end of their shift. And then often asking them to bring you back as well. Other things just to consider whenever you're setting off. So do you know exactly where you're going? Do you know how you're going to get in there? So if you're going with a time critical transfer into theatres, do you actually know how to get into the theatre block? Is it through ED? Is there some other better door you can go in? Can you get in at the time of night or the time of day that you're going to? And if not, do you have somebody to contact from the receiving unit who can come and let you in? Because more and more obviously swipes are needed to get in even through doors within the hospital, so it can be very frustrating if you turn up somewhere and you get stuck in some area where you've got no phone signal and you haven't alerted the team that you're nearly there. Do you know who you're going to call in an emergency? So it might be the unit that you've just left. It might be the receiving team, or it might be the transport team, or it could be somebody in the ICU that you're going to. But making sure that you've made contact with whoever you're going to speak to in an emergency beforehand, so you've got their number kind of saved and on speed dial is really helpful. Do the receiving team know when you're going to get there? Have you alerted them that you've set off? Have you let them know what you're going to need whenever you get there? Nothing more frustrating than arriving in, running out of infusions, and you haven't told the team to prep more for whenever you come in. Other things, then, once you've dropped your patient off, do you know how you're going to get back? Frontline ambulances might be able to take you back, but they might not. If you've brought your own transport trolley, you'll need to get it back in some way. But once you don't have a patient on board, if you're in a frontline ambulance, you kind of become fair game again for emergency calls. So you could easily end up out and about on multiple different calls. And if that's the case, have you got some money? Have you got some warm clothes? If you break down as well, you might need a coat. Have you got snacks, and have you got some way to communicate with your local team and potentially your folks at home to let them know that what's happened to you? Last thing I want to just mention is around blue lights and driving on lights and sirens. So this is definitely something we've moved away from a lot in recent years from a critical care retrieval point of view. And part of the reason for this is that whenever there's been bigger meta-analyses and things that have looked at the amount of time saved, on average, driving on lights and sirens, and this is sort of aggressive driving on lights and sirens where you're going as fast as you can. We were talking about sort of time savings of about 6 minutes across rural and urban areas. Now, where we think lights and sirens do have value would be for progressive driving. So that's if you're getting stuck in heavy traffic within an urban area, to be able to move at a steady, slow pace through traffic can be very useful. But driving really fast is not good for the amount of time that you save compared to the risk that it involves and the impacts on your patient. So I'm talking about the risks to you. So you can see here, so this is another study which looked at crash-related delays when using lights and sirens. And you can see not only is there an increased risk of crashes with driving on lights and sirens, it's not huge whenever you're responding, but it's really interesting to see what the difference is. So whenever your driver has a patient on board and they're transporting somebody, the risks of a crash driving on lights and sirens go up massively. So there's something around the responsibility, the distraction of having a sick patient on board and driving really quickly, which makes your chances of crashing go up really like 3 times more, which is obviously going to delay you further. The other big thing is all of the physiological impacts that I talked about earlier on will all be worsened if you're trying to drive really quickly. Your acceleration and deceleration, your cornering, if you hit a bump in the road, it'll be amplified by driving quickly as well. So really something that isn't, we know that these things are time critical, but if it destabilizes your patient while you're doing it, you want to drive smooth and steady. Use lights and sirens a little bit to move through traffic, but not as standard. And the last thing just to show is just to talk about safety. So this is a video of so this is a stationary ambulance, and it's about to be struck side on by a car moving at 30 miles an hour. It's just to highlight so what happens to you in the back if you're not strapped in, but also just to consider if you do need to make a stop. So if you're traveling along in an ambulance and you have to perform an intervention and it can wait for 1.5 minutes or even 3 to 5 minutes until you pull in somewhere safe out of the way off the side of the motorway, it's really beneficial to do so. So good communication with your driver to make sure that they know if you need to stop, you've got time rather than needing to pull over immediately. If you need to pull over immediately, you do, but this is just to flag up what the risks are. So as I say, side-on collision at 30 miles an hour with people and equipment not strapped in. Everybody's still going. So not just people in the back need to be strapped down, but every bit of equipment that you bring with you needs to be strapped onto something properly. All your bags need to be packed away because everything becomes a missile. You can also imagine, so if you were to suddenly get up before your vehicle had stopped and there was a crash, you suddenly become that missile for your patient, for your colleagues. So if you do need to stop to perform some interventions, it's really important. That's a time when you're most likely to have an accident, when you're suddenly pulling across lanes of traffic. So you really have to be careful at that time. Sit in your hands, wait for the vehicle to stop, and then get up and do whatever you need to do. Work out, is there anything you can do in the meantime from your seat? And that might just be planning, but it can be dangerous out there in the ambulance. So look after yourselves. And that's me. Thank you.
Thanks very much, Rory. Again, some really useful practical advice. I think there's definitely something around the time critical transfers, and you don't always have time to prepare in those scenarios. So it is important, if you're not used to doing transport, that you take a moment when you get a chance over the next few days to look around your department, know what equipment you have, where it's kept, how you would access it in that emergency scenario. I think the other thing that's, I suppose, is key is that even in time critical transfer, where you're going to have to organize the transfer yourself, you're not going to have time to wait for a transport team. There is value in ringing, depending on your local regional setup, either your regional PICU or transport team for advice. And I think, I'm sure you agree, Rory, most of the time they're more than happy to take those calls and offer that advice.
100%. Really helpful just in terms of getting reassurance. If it's not something you're doing all the time, having somebody there who's saying you're doing all the right things or giving you a little bit of advice around other like things like apps you can access to try and just smooth things along, using the checklist that the transport team would use. All of those sorts of things just help to kind of reduce the bandwidth that you're using up whenever you're doing something that you're not used to doing. So absolutely get in touch with your teams.
Perfect. Thanks, Rory. In the interest of time, I think we'll move on to the next talk. So thanks again, Rory. Next up, we've got an interactive simulation, which is going to be led by Dr. Tudor Oman and Dr. Stephen Mullen. They're consultants in Paediatric Emergency Medicine, both based in the Royal Belfast Hospital for Sick Children. So Tudor, Stephen, I'll hand over to you. And apologies if there's anyone else involved in this that I've neglected to mention. Apologies.
Thank you very much, Ben. Just doing that lovely check. Can everybody hear me? Yeah. Excellent.
Yes, yeah, all good, Steve.
So I'm going to do a brief intro into what we're going to hopefully aim to achieve in the next 50, 60 minutes, and then allow the rest of the team to introduce themselves. So we're going to do an interactive simulation. One of those cases that is complex will require you to think, and a variety of points during this simulation we're going to stop. We're going to ask the participants, which is you guys, in order to answer some of the questions. And then as a group, we're going to meet to discuss what we think is the best treatment options or the right answer from the selection that we have. I want to say first and foremost that this is a made-up case. It's not based on any actual child or young person that was injured. Second thing it's important to clarify is this is based on our interpretation of the current evidence base. And as with any journal, it can be interpreted in different ways. So we would strongly encourage you to go back to the literature, have a read for yourself, and to see what your interpretation might be. So before we start, we're going to do a brief round of introductions. So as mentioned, my name is Stephen Mullen, a consultant in the Paediatric Emergency Department, and I'll allow everybody a few seconds to introduce themselves.
I'm Tudor Oman, I'm a Paediatric Emergency Medicine consultant.
I'm Mary Beth. I am an ST5 in paediatrics. I'm currently the simulation fellow in the Children's Hospital, and I am applying for Peds Emergency Medicine.
Damien.
I'm Damien. I'm currently ST6 in pediatrics. I'm the NIMTA simulation fellow for the year, and I'm also applying for Paediatric Emergency Medicine.
And I'm Peter McAlister. I'm a Paediatric Emergency Medicine registrar in Belfast.
So for the video we're about to show, the faculty or the participants have been all taken from ED. In real life, we would have a trauma team or a larger group of people involved. And this is mere reflection on just how we can access people in order to record this video. But we would expect if this case came through that we'd have our surgeons, our anesthetic team, our orthopods, and other members of the MDT. So let's get started. So it's over to Tudor now to hit the play button.
Stephen, Tudor, sorry to interrupt. I'm having difficulty hearing the sound in the video. I don't know if that's anyone else having the same issue.
There's no sound on it.
Yeah.
It might be in the sharing options. Have you turned the sound on as the option?
Sorry, guys, just bear with us.
Yeah.
Okay, I'm going to play the video just directly from the computer rather than from the screen here. Sorry, just screen. Oh, there we go. Sorry. Okay. Okay. Okay, can you see my screen now?
Yep,
okay,
yep,
can you see my screen now?
Yep,
okay,
yep,
can you see my screen now?
Yep,
okay,
yep,
can you see my screen now?
Yep,
okay,
yep,
can you see
yep.
my screen now?
Tudor, there's a lot of feedback and it's kind of on repeat.
Okay, thank you. That's great. Thanks, bye. Julianne, we've just had a chat.
Yes, Emma. Okay, so I'm Julianne. I'm the consultant on today. I'm going to maybe put out a trauma call and assemble the team then for Emma, and you'll maybe give us the handover.
No problem.
Okay, great. So we've done that. Okay, guys, we've got a trauma standby. If everybody could just listen up, Emma is going to give us the handover, okay, and then we'll allocate roles.
So HEMS are at the scene. The incident occurred about 20 minutes ago. It's a 13-year-old boy who's been assaulted. He sustained 2 stab wounds, one to his left anterior neck, as well as the left anterior chest wall. His heart rate at the minute is 130, blood pressure 110/70, saturation's 95. There's increased work of breathing with some subcostal recession. GCS is 15. HEMS have got IV access. There's 2 cannulas. He's already had his loading dose of TXA. There's 1 unit of packed red cells currently running. He's also had ketamine, and there's dressings applied to the wounds. And the estimated time of arrival is 5 minutes.
Okay, guys, so thanks, Emma. So we've basically got a 13-year-old coming who's got penetrating chest trauma and also a neck wound. We've already got some hemodynamic instability there, and there's blood being given at the scene. So, guys, we'll run through introductions and your designation, first of all, and we'll go from there.
My name is Damien, Paediatric Reg, and I'll manage the airway.
Okay, Damien, so obviously we're really worried this child's critically unwell. We may need to proceed to early intubation. Are you comfortable and competent to do that?
Happy and confident.
Great.
Hi, I'm Peter, PM Reg. I'm going to be managing breathing.
Okay, Peter, so again, penetrating chest trauma here, we're going to need to think about early chest drain insertion. Are you comfortable and competent to do that?
Yeah, I am.
Great.
Hi, I'm Jane. I'm one of the earlier ED consultants and I am C doctor today.
Okay, Jane, so obviously, again, we are worried about the circulation already. We do have vascular access already, but we might require vascular access already, but we might require vascular access already, but we might require intraosseous access. Access already, but we might require intraosseous access.
Yep.
Great.
Chloe, PhD nurse, I'm happy to assist with airway.
Thanks, Chloe.
I'm Claire. I'm one of the PEDS EMPs and I'm breathing nurse today.
Thanks, Claire.
Hi, I'm Lucy. I'm one of the PhD nurses and I'm happy to assist with circulation.
Thank you.
Hi, I'm Colin, paediatric nurse, and I'll be doing the run.
Thank you.
I'm Emma, AMP. I'm happy, whatever you need me to do.
Great. Emma, if you're able to maybe check the electronic care record for us for any previous attendances or any other history we can get. And we're going to need to do a stab check on this patient as part of our primary survey. So I'm going to give you responsibility for that, if that's okay, and feed that back to me. Thank you.
And hi, I'm Alex. I'm a PhD nurse and I'm going to be the scribe.
Okay, great, guys. So talking about those priorities then, I think we just get a few minutes to get organised and then I think the patient's going to arrive.
Yeah, Gillian, actually, I think we should activate the major transfusion protocol.
We've got blood in the department. Sorry, Jane.
You've got a wee bit of blood, but sure, it takes ages for the rest of the blood to come.
Yeah, but blood's kind of precious, so I don't think we should initiate the major hemorrhage protocol.
Okay, but is this not exactly when we should? He's been stabbed, he's had blood in the way. I don't know, Gillian, what do you think?
So now we've reached the first intermission. So the first question we have is, when would you activate the major hemorrhage protocol for paediatric trauma? And we're giving you 5 options to pick from. So option A, after 2 units of O negative administered. Option B, only if the patient is hypotensive. Option C, we don't need to activate in pediatrics. Option D, I activate it in all trauma patients. Option E, a patient with normal OBS with concerns of significant blood loss, I would consider activating it. So if you can put your answers up in the live chat, we'll give you approximately 30 to 60 seconds to respond, and then we'll start discussing some of the answers. Excellent. We'll give another 10 seconds just to see if there's any more updates. So it seems to be in agreement what we would stipulate, which would be option E, and we'll talk about the pros and cons of all the other options as we go through. First thing we need to discuss about is what actually is a major hemorrhage, as that would prelude us to activating the major hemorrhage protocol. And it's important to acknowledge that in ED, when we see the patients, it's often difficult to appreciate how much blood has been lost. There might be some lost at scene, there might be some cavities in the abdominal cavity or pelvis that we're not able to actually see, or retroperitoneal, so even if you used your other adjuncts. But when we look at definitions worldwide, we've got, in terms of volume, 80 mils per kilo over a 24-hour period, 40 mils per kilo over a 3-hour period, or 3 mils per kilo per minute. And those definitions are very difficult for me to envisage in my head when the patients come through. So I don't think they're particularly useful for ED, but they're definitely worthwhile actually having a little bit of knowledge. The patient, what I see, will be in a journey. I don't know how much blood they've lost, and I don't know how much blood they're going to lose. So you almost need to anticipate what's coming through. And there's a balance that we're trying to acquire. So we want blood products available for resuscitation versus not wasting blood products. So we know blood is a finite resource. O negative in particular, the stocks, I think, are low, certainly UK-wide for a period of time. And if you call your major hemorrhage protocol and you waste those products, you're depriving other people from getting access to those. On the other hand, if you have delay in blood products, we know there's an increase in mortality. So a single center study from the US was able to identify that for every 1 minute delay in you getting your hands on your major hemorrhage protocol, or PACS, there was a 5% increase in mortality. Now, this was a single center adult study, and there's no comparable pediatric data, but it certainly should give you a little bit of information to empower you to think, what time frame do I want? You need to think about your unit and how long it takes these packs to arrive to your ED. Factor in the activation time, defrost time, and transport time. So we know FFP takes approximately 20 minutes to be defrosted. Transport time can vary anywhere between 2, 3, and 20 minutes as well. So if you want your pack and you're waiting to activate it, by the time you activate it till it arrives in your hand, can be as high as 40 minutes. And I would strongly encourage you to go back to your department and run simulations in order to have a look at this. And why do we want the blood packs for? Well, we know the balanced resuscitation is much better for trauma patients rather than just giving them either salty water or packed red cells. When you bleed, you don't just lose red blood cells. You use plasma, clotting factors, and platelets. And by doing this balanced resuscitation, we're able to improve outcomes. And certainly it's gone from balanced resuscitation 1-to-1-to-1 to starting to look at whole blood transfusion, which is something that is definitely coming in through the research. If we're thinking about our parameters and how to activate our major hemorrhage protocol, we were very fortunate to be involved in a piece of work that we published a year or two ago, looking at pediatric trauma patients and their vital signs when they were getting transfused, either pre-hospitally or in the ED. The vast majority of these patients had normal blood pressures and a slightly elevated heart rate. And we often think of our hemorrhagic trauma patients as displaying hemorrhagic shock. So they're all tachycardic, they're all hypotensive, and that's not the case for pediatric patients. And they're very different in how they manage blood loss. So some of the evidence would say that for an adult, myself, if I lose 10% of my circulating volume, I will drop my blood pressure, I will get tachy, I will look unwell. Pediatric patients, before they display those signs, is up to 40% blood loss, which is incredible. And when you think of the small baby in front of you that might be 10 kilos, their circulating volume might only be 800 mils. So if there's 100 mils on the floor, 100 mils in the abdominal cavity, you certainly mightn't appreciate it as much as you would do. It's also how kids are able to respond differently, in that they're able to put their heart rate up to rates that we can't get as adults, but also increase their systemic vascular resistance in order to maintain a blood pressure. So therefore, we don't tend to see the hemorrhagic shock that we would see in the adults come through. So what is driving us to administer blood products? Well, sometimes it's the history that comes through and in terms of activating. So if I know I've got penetrating injury, I know if there's blood been given at scene, if there's flannic cardiac arrest, I will certainly lower my threshold for activating it. I'm not completely reassured by having normal OBS in a patient who maybe looks a little bit unwell in that clinical gestalt that we use in order to try and help transfuser population. We're probably potentially under-recognizing it as well. If we look at the survival outcomes coming from some US data, we know that for hemorrhagic shock in the adult population, the mortality rate's about 25%, whereas in pediatrics is between 35 and 50%. So my take home from this is just basically the answer that you give, is that you need to anticipate the time it takes for your blood products to arrive. Even if you have packed red cells in your department, you want to do balanced resuscitation. So you need your FFP, you need your platelets, you need to consider your cryoprecipitate. You need to be aware of the timing and how long it takes for them to get into your department, and also not be completely reassured just because you've got a child who's got normal observations. So I'm going to hand over to the panel and see if there's anybody else wants to add anything else in from their point of view about when they would consider activating, or any deviation from my humble opinion. And I think that's been a long enough uncomfortable silence. So we will crack on back to the video and see what this team decided to do.
Okay, Jane. So basically what we know at this stage is we've got a hemodynamically unstable patient who's receiving blood at the scene. There may be some blood loss at the scene. So I think go ahead and activate the major hemorrhage protocol at this stage. And if you can just confirm back to me when you've done that, thank you.
Yeah, okay, let's do that.
All right, how's it going?
Hi, Davey, how are you?
You boss?
Yes, I'm Julianne Collins. I'm the trauma team lead today.
This is Tommy.
Okay.
He's 13. Pretty much he got the op missed. His obs have stayed unchanged. He's got a couple of stab wounds, neck and chest that we found. We've dressed him,
Great,
given him
thank
his TXA, and we have blood going.
Okay.
I managed to get a picture of the knife.
Oh, great, thank you.
So I'll let you see that. And other than that, he's as you find him.
And any blood at the scene, really, David?
Yes, a fair bit of blood loss at the scene.
Okay, great.
All right.
Okay, guys, so we're going to jump in and quickly do our primary survey of the C, A, B, C, D, E approach. So looking for any obvious catastrophic hemorrhage initially. Don't think there's any ongoing active bleeding. I'm going to give you a few minutes just to assess your areas, and then I'm going to get you to feed back to me what you found. Okay, starting with you, Damien, up there at the top end.
Julian, waist plate, and he's bleeding on his own. He's got an anterior neck chest wound, anterior neck wound that doesn't seem to be actively bleeding. It looks superficial. There's no tracheal deviation. I'm happy with his airway at the moment.
Okay, so you mentioned there obviously we have a neck wound. We don't think from the history that there's really risk of cervical spine injury. However, we don't have further information at this time. The wound that we see there we think is superficial, but we'll need to explore it further. I think we'll perform manual inline stabilisation at this stage, Damien, until we know more. Okay, Peter, breathing?
So our sats are 92, 93 on 15 litres. We've got good energy on the right side. Left side, reduced energy at the base, and you've got looks like a stab wound, kind of left anterior chest, that's dressed at the minute. So a bit worried about the chest.
Okay, so we're not happy with the chest. Yes, Jane?
I'm not happy at all. He's freezing. Okay. He's really shut down peripherally. He's tachycardic, real thready pulse, about 140. Cap rifles 4. Not a lot of blood to be seen. The dressings are on. He's got good IV access, but I'm not happy at all.
Okay, so at this stage, we're worried about chest, we're worried about circulation. We'll maybe just do the stab check just to make sure we found all injuries. So if we can do a gentle log roll, guys, 15 degrees on your account, Damien.
1, 2, 3, roll.
Julianne, there's actually a chest wound now to his right posterior chest wall as well.
Okay.
No long bone injuries, and tummy is soft.
Okay, so as part of that, we've checked the axilla, we've checked the buttocks and the groin and the back, so we found a further stab wound. So we've got 3 stab wounds, which we've now dressed at this stage. Okay, so we're really concerned about the chest. There could be hemopneumothorax. We're worried, obviously, that we're still very tachycardic. Blood pressure is definitely borderline, that we've got hemorrhagic shock, possibly.
Claire, do you have a POCUS or an ultrasound in this department? I think we need to ultrasound him.
Sorry, Jane, I know you work in adult DD and ultrasound, anything that moves, but we don't use POCUS in paediatric trauma.
Okay, but I can do it, so I'm just going to do it, yeah.
No, because I think it'll distract from what we need to do for this kid, so I think we should focus on other things. Is that okay?
Okay, no, it's not okay. What do you think, Julian?
Okay, so we're going to move on to our second question then. So this question is about the use of POCUS, so point of care ultrasound in the severely injured child, and you've got 5 options which we'll go through, and you'll vote in the same way as you did in the first question. So option A is that a sensitivity of a fast scan is over 80%. If a POCUS is negative, it means that you do not need to do a CT scan. C, POCUS is poor at ruling out or in pneumothorax in paediatrics, given the elasticity of the ribs of the child and the high chest compliance. D, that POCUS is very user dependent, and E, should never be used in paediatric trauma as it just delays cross-sectional imaging. So if you vote now, we'll have a look at what your answers are, and then we'll have a bit of a chat about things. All right. Okay, so option D seems to be the most common one for now. We'll bounce back to the questions in a second, just so we can go through the options, and then we'll have a bit of a chat with the panel and discuss things. So option D seems to be the most popular now. We'll go back. So the most popular answer is that POCUS in the severely injured child is very user dependent, which I think is very, very true. A lot of obviously what we do in paediatric trauma comes from the adult population, and in adults, often people who come in severely injured get a fast scan done. So for those who don't know, it's a quick ultrasound in 6 areas, both lungs, heart, and then 3 right upper colon, left upper colon, and the pelvis. And adult emergency medicine physicians become experts really in this, and they're very, very good and capable of finding pathology, so free fluid in the abdomen, pneumothoraces, hemothoraces, pericardial effusions, etc., etc. So, do we then just extend that knowledge and expertise to the paediatric population? And that's I suppose the question, isn't it? Do we just fast scan all patients? And the data for this is limited. There aren't any RCTs looking at the diagnostics or survival characteristics of POCUS versus CT on its own. However, there is emergent evidence that POCUS has a role in the primary surgery in detecting significant injuries in patients presenting with blunt or penetrating trauma, especially chest trauma, so pneumothoraces, hemothoraces, etc. And also, as a side note of that, has a role with the insertion of a chest drain. New European Resource Council guidelines for paediatric trauma and the unwell child mentions POCUS a lot, so it's mentioned for as part of the primary survey for chest injuries and chest and cardiac arrest and the assessment of shock, IV access. So there's definitely a movement in paediatrics to the use of point of care ultrasound a little bit more, but it's definitely very user dependent. Obviously, we as emergency medicine doctors can do courses, practice courses, for example, but pediatric trauma is still rare, and picking up those things because it doesn't happen very often, and there's limited kind of pick up rate with regards to that. There is a 2021 study by Liang, which is a systematic review which looked at over 2,000 patients presenting with blunt abdominal trauma, and it showed that there's a high specificity. So if there was evidence of an intra-abdominal injury on the ultrasound, free fluid, for example, then there was a high chance that they would have something on their CT subsequently, but there was a low sensitivity. So if the scan was negative, then you were still having to do cross-sectional imaging, and it doesn't preclude the need for a CT. So that does kind of bring the question up. So should we fast scan all children? Should we do a more focused POCUS, for example, on the chest to assess both lungs and the heart with regards to the specifics for them? And that's something we'll bring to the panel in a little second. And also, I think it's important to mention that as hopefully you've learned through your careers in paediatrics, that children are not small adults, and there's different mechanisms of injuries. Intra-abdominal organs are proportionally larger, and there's less abdominal protection. The spleen and liver are lower and more anterior. There's less protection from the ribs, as mentioned in the questions as well. Diaphragm is more horizontal, and sometimes a little bit of free fluid can be normal. So again, brings in that huge user dependence issue whenever it comes to the management of a severely injured child, and the stress that brings within the team as well. So I suppose just wanted to bring that question to the rest of the panel with regard to this question. Is a chest POCUS reasonable and avoid the tummy? Is that kind of where we think things are moving to?
I'd probably agree with you. I think there is a benefit in being able to take out your probe, particularly for those critically unwell children. So for trauma, which is the emphasis of this talk, I think being able to decipher whether there's pericardial infusion, a tamponade, how the heart is working, and then also be able to rule out a pneumothorax or a hemothorax, or confirm or help confirm is useful information to have whenever the patient is too unstable to go somewhere else. So I don't know what anyone else think. I was a big advocate for POCUS, really thought it was going to change the world based on the fact that it was bedside test, there was no radiation, it would be relatively easy to do. But as I've got a little bit older in the tooth, I'm still on the fence of its role really in peds emergency. I think with chest there's definitely a role, but it'll be interesting to see what other people's thoughts are.
I think it's playing an increasing role in what we do. I'm definitely using it more in the resuscitation, often for cardiac standstill, tamponade, chest. That's the area that is used the most. This one was about a fast scan, and I think in that circumstance, maybe using it for a sequential follow-up rather than having to run to CT every time you think that there is something else going on. CT is a static image in time. This offers you a chance to sort of monitor the patient as well, and I think that's something we can look at, but the evidence isn't necessarily there yet. Definitely useful.
I'm a big fan of POCUS. I think it's silly to ignore information that you can get fairly easily as long as it doesn't distract from other things, and as long as you're aware of the limitations of what it can and can't do. I think it would be silly to ignore it. You know, certainly I've used it to stop people ready to put a chest drain in, and was scanned and said actually there's no pneumothorax there, and there's no hemothorax, so you can avoid doing harm to your patients, but as you say, as long as it doesn't distract from important things and you're aware of the limitations.
Great stuff. So yeah, I think the consensus is that POCUS, especially for chest pathology, can be very helpful, and as long as it's in the right hands, and as long as it doesn't distract away from patient management directly, and it's very helpful at giving a dynamic picture of the patient's pathology, and that's that study that we're talking about already. So I think we're ready to move on to the next section, Tudor.
Okay, Jane. So I think actually if you could focus on the chest ultrasound for me, so I want you to look at the lung and the cardiac views, and if you could just report back to me, that would be great. Thank you.
Okay, so there's absence of lung sliding on the left. I think there's probably pneumothorax there as well. Nothing really too exciting in the heart, and the right looks okay. So I think you've got a left pneumothorax.
Okay, so left pneumothorax. Okay, I think at this point, guys, we'll maybe just take a little pause just to recap where we are and where we're going to next. So obviously we've got a critically unwell 13-year-old here who's got penetrating chest trauma and another 2 stab wounds as well. We've identified we've got a left pneumothorax, so I think we need to urgently proceed to a left side of thoracostomy followed by chest drain, Peter, if you can organise for that. We do need to optimise our oxygenation as well, Damien, so we may need to start thinking about prepping for intubation. Obviously really worried that we're very hemodynamically unstable here, we're very tachycardic, we're hypotensive, so we need to get rapid volume replacement in. Did we hear back about our major hemorrhage protocol?
That's right.
So we've got all of our blood products. Okay, great. So if we can push those, our packed red cells, our FFP and platelets at a ratio of 1 to 1 to 1. And again, just keep me updated as to what we've got through, and Alex is keeping a note as well. We're going to proceed. We've had a tranexamic acid bolus at the pre-hospital scene, so if we can proceed with tranexamic acid infusion. Great. Emma, have you managed to find anything out on electronic care record at all that might help us?
Yes, I looked on Epic and also spoke to his parents. There's no significant medical history. He's no allergies, not on any medication, but he was in a couple of months ago with intoxication and also an e-scooter injury last month.
Okay, so there's been some previous attendance. Okay. Okay, guys, I guess anybody else in the team, anything else to add at this point?
Blood gas is here, Julianne.
Okay, great. What have we got?
He's not well at all. Lactate's up, profound metabolic acidosis, hemoglobin's a wee bit down. That's about it.
Here is calcium's also a bit low.
Oh yeah, it's calcium's low, yeah.
He's also really cold. His temperature's 33.4.
Okay, so a low calcium and hypothermic as well as severely acidotic.
We need to treat those, do we?
So that brings us nicely into question 3. So what is the most appropriate immediate management? So A, actively rewarm and administer IV calcium. B, aim for hypothermia 32 to 34 to reduce the risk of brain injury. C, delay calcium replacement until hypocalcemia is less than 0.6 millimoles per litre. Or D, focus solely on volume resuscitation, calcium and temperature correction are not priorities in the first hour. So if you want to vote now, I will give you sort of 36 to 60 seconds for that. We have a look at the results and see where we are. Yeah, so most people are voting for option A there, so actively rewarm and give IV calcium. So we'll just give a little bit more time just to see votes coming through. Okay, so I think the first thing to say is that actually how that information came about in the scenario is actually lovely demonstration of the flattening of the hierarchy there, allowing information from any team member, which actually can have a huge impact to the care. So what we gained there was information on our temperature and our calcium, both important considerations, but not easily revealed when we're initially going through our ABC and focusing on our breathing, circulation, chest drains, etc. So we'll talk about both now in a little bit, and we'll start off with hypothermia. So part of our lethal triad alongside our acidosis and coagulopathy, and we know that they all feed into each other, making our resuscitation a bit more difficult. So how common is hypothermia? So if we think about it, if we think about the environment when we usually find our trauma patients, so we live in Northern Ireland, wet, drizzly, cold, as is today's November day. Ambulances, helicopters, we don't really see them as warm places. We often strip our children down to find out what their injuries are, and we might not cover them back up. We also bring them into resuscitation bays, doors opening and closing all the time as we need to add and teams, etc. So it can happen quickly, and there is a big evidence base there to say that it can have negative impacts on our patients. So a systematic review and meta-analysis from 2020, actually in the adult population, looked at mortality, and it was 5 times higher in all trauma patients in the hypothermic patient compared to the normothermic patient, and 2 times higher in those with traumatic brain injury specifically. In pediatrics, there's less information available, but a single center study in the American Journal of Emergency Medicine showed that actually in just under 3 years in their department, pediatric patients who were hypothermic showed a 9 times increase in mortality. So not a small risk, and it's quite a small thing to check a temperature, but it might be down our list of priorities. But it is a huge impact to patients, and I suppose it's important to recognise that A, it can happen, and B, that there's actually simple things that we can do. So removing wet clothes, covering patients back up, giving them warm blood and fluids, or bear huggers are sort of simple things that we can make. And if we can have a think about how that comes into our practice and how we designate that at the start so it's not forgotten about is actually a really useful thing. So maybe having someone who knows their role in the situation is to make sure we get a temperature is important. I'll go to the panel first to see if anyone has anything they want to add on hypothermia, and then we'll move on to hypocalcemia. Anything you think of, anyone?
No, I think you're very right there, and that it's something that when you're the trauma team lead, you're often so fixated on getting the airway secured, thinking about a chest drain, getting your volume replacement, that temperature, because it features so low down your list of priorities, is often forgotten. And I think the evidence base is increasing our awareness of the importance of hypothermia. And you're right, easily identified and easily fixed. And that flattening of the hierarchy that this simulation showed isn't easy to achieve. In some departments, there is a clear hierarchy. And what you really want is that piece of vital information to be passed on to the team. So when you're teaching or educating or setting up your team, then I think it's really important that that's put out there quite early.
Thank you, Stephen. Okay, well, we'll move on to hypocalcemia then. So I suppose it's been increasingly recognised as being important, and actually people have proposed the lethal diamond in adding hypocalcemia to that triad that we've already discussed. A systematic review and meta-analysis from 2021 showed that 50% of adult trauma patients were hypocalcemic on arrival, and the evidence is that there's about 2 times increase in mortality in those patients. So what's its importance in paediatrics? I suppose there's less evidence out there for paediatrics. There's less evidence on its incidence. A meta-analysis had showed that there was about a 1 in 6 incidence, or 15% of patients, paediatric patients with trauma, were hypocalcemic. So not insignificant. Stephen and I did a systematic review trying to find out some more information about this. And actually we were only able to identify 2 studies who looked at hypocalcemia and paediatric patients. And the studies had relatively small numbers. They weren't well powered to achieve statistical significance, but they did show trends towards increased mortality and the increased need for blood transfusions in these patients. I suppose it's somewhere that we need to look for more information, and Pruki are currently carrying out a study looking at the effect of hypocalcemia on patients' hemodynamic stability and their outcomes, which is going on at the minute. I suppose it's important to recognise that in addition to whether hypocalcemia is present initially or whether it's something that develops during a resuscitation as we administer blood products. In this case, we've got the massive hemorrhage protocol. It's important to recognise the role that giving citric containing blood products has on reducing our ionized calcium. So having that awareness in your head while you're administering those things, keeping a check on your blood gas, looking at the calcium is really important. And I think that although there's less evidence in children, I hope we've managed to convince you that there's enough evidence there to consider hypothermia and hypocalcemia and actively intervene in the early stages of resuscitation, because sometimes it takes us a while to realise those things. Does anyone have anything to add or any evidence you think I've missed or anything? No. Okay. Oh, sorry, Stephen, were you going to say something?
No, I was about to say nothing. Actually, we just kick on and see what the next, what people decided to do during the resuscitation.
Thank you both. I think they're great questions. So yes, I think we're going to actively rewarm this patient so we can put the bear hugger on, and I think we should treat the hypocalcemia. So if we can go ahead and draw up 10 mils of 10% calcium gluconate and let me know when that's been done, that would be great. So really worried about this patient. Looking at the monitor there, guys, I think we need to sort of think, are we going to be able to stabilise this patient enough to get to CT scan, or are we going to have to go straight to theatre at this point? So,
did you get your drain in, Peter?
Yeah, drain's in.
Well
there's
done.
about 200 mils, thanks. There's about 200 mils of blood draining, and it's swinging and bubbling.
Well, I'm not surprised because he looks absolutely awful.
Okay,
we're not winning here at all, Julianne. That
okay,
pulse is
Jane,
very
can you
thready.
keep your finger on that pulse then? I'm worried that this patient could arrest any second on us here.
Yeah. It's gone. He's arrested.
Sorry, Emma. I think we need to stop chest compressions. If that's okay. This is a traumatic cardiac arrest, and there's other priorities. So can we stop chest compressions?
But sure, for cardiac arrest, you give chest compressions. I've done my AP arrest.
Yeah, no, you're right. But in this kind of specific situation, we need to focus on other things. There's a bundle that we need to focus on. So can we stop chest compressions and we'll look at other things?
Are you sure, Julianne? What do you think?
And yeah, that brings us to our next question. So we have a patient who's arrested in front of us. Do we compress the chest or do we stop chest compressions? And as we voted before, just pop your answer into the chat. So option A would be chest compressions must be done. B, I would consider stopping chest compressions, but in truth, I would find this hard to do. C, I would temporarily stop chest compressions until thoracostomies are performed. D, I would stop chest compressions until the life-saving bundle has been initiated and then restart. So we'll give you about 60 seconds to put your answers in, and then we'll have a chat. So I think most of us have gone for C. We'll just give a few more seconds to get more answers in, and then we'll go to the discussion. Okay. So on to the discussion. So I think everyone here would appreciate that having a patient in arrest in front of us and not doing chest compressions is something that feels unreal, because it's been drilled into us all from very early on. If a patient is in arrest, you have to do chest compressions. But we have to think along the lines of what are we trying to achieve when we actually deliver chest compressions? So we think back to the physiology. Now we have a patient who is in arrest and we're delivering mechanical pressure to the chest. And what we're aiming to achieve is to generate enough pressure to deliver an ejection fraction, perfuse the heart, and also perfuse vital organs. Now, if we think in the context of a patient who's in traumatic cardiac arrest, and we're conscious of the fact that one of the things that will be happening in the background is loss of circulating volume. If we do not have volume circulating and we're delivering mechanical pressure to the chest, what are we actually circulating in this case? So if we think about what we know about children, and that one of the primary things that happens when they're in arrest is loss of volume, especially going back to what Stephen has said earlier about loss, how much loss of volume affects children. We then have to pull back and think, what are the things I have to actually do to ensure when I want to resuscitate this child to have the most benefit? When it comes to evidence of what we do and why we do what we do, there's not a lot, but there's a general consensus, be it with your ATLS, your APLS, or ETC, that we have to prioritize the life-saving bundle before we actually proceed down the line of resuscitation. What are the things we're thinking of in the life-saving bundle? We have to focus on our reversible causes, and we have to think of our HOTT. Again, I take us back to what we're all very used to. We're used to our 4 H's and 4 T's, but in trauma, we tend to veer off that and focus on the main 4 things we're thinking of. Your first H, we're thinking of volume. We have to think of actually rapidly replacing the volume. We have to think of oxygenation, and we have to think of tension pneumothorax and tamponade, which are the things we have to prioritize. In this case, there is, I think it was by Vassallo and the others in about 2018, there was a consensus that was reached at the time using, I think it was a Delphi study, where they had a room full of professionals who sat and, you're thinking along the lines of, what are the thoughts you have? How do we best deliver care in this scenario? And one of the things they had come up with, which is what we base our approach on in pediatrics, is when we think of cardiac arrest in the context of trauma, we've lost our output. We have to prioritize a few things. First things is we have to think of hemorrhage. Have we arrested any visible hemorrhage we can't see? Then we have to think of oxygenation and ventilating our patients. Do we have a secure airway? Are we ventilating okay? And we have to think of thoracostomies, which also fits into the early part of the scenario when Peter, advocated for, let's get the chest drains in. And we also have to think of rapid volume replacement, which is why we talked about the major hemorrhage protocol activation early enough. Because if we don't have volume, then our chest compressions are going to be futile. And then when we think of replacement as well, we have to then think in the context of, if this is blunt trauma, because we're talking about trauma in this scenario in the context of penetrating trauma. If it's blunt, you can't see any active bleeding, but we still have to be thinking along the lines of, is there some hidden bleeding inside? And our pelvic blinder comes useful in this scenario. So I'm also going to open up that to discussion about, there is a study as well that was done. It's an animal study that talked about a study done on animals, and then they thought about looking at different interventions in different groups. They found that the group that received chest compressions alone or chest compressions with other interventions actually had poorer outcomes. The interventions actually had poorer outcomes. Now, we also know there's a thought that when we're delivering chest compressions to a patient who has no circulating volume, we're actually at risk of increasing intrathoracic pressure, which might actually even worsen the bleeding and worsen outcome for these patients. I'll open it up to other members of the panel to see what other thoughts they have and what's been happening in practice for us as well.
So I suppose we'd be interested to see in the panel what people do in real life. So what my practice would usually be is, I think if you're going to do bilateral thoracostomies, you have a scalpel in your hand. If somebody's doing chest compressions, you're putting the patient at injury and also your staff from sharp injury. So my practice is to temporarily pause chest compressions while we get these interventions done. What does the rest of the group do? I know these are rare scenarios, but in your head, if you got a mental model, what are you thinking?
So from some of the traumas that we've had, my thought is that, when you have a medical cardiac arrest, you're trying to limit the time off the chest. So you're trying to get your ultrasound in there in between during the pulse check. In a traumatic cardiac arrest, I have less concern about saying, let's get off so that we can get a few tasks done, because the evidence shows that we need to sort of try and fill this patient back up again, deal with the pneumothoraces, the hemothorax. So I have less concern about that, but I still think it's very hard for the team for you to stop chest compressions altogether. So I think in between those activities happening, chest compressions back on again.
I think as well, like, as a trauma team leader, it's helpful as part of your pre-brief for your team to mention that if this is a traumatic cardiac arrest, that you say that if there is a traumatic cardiac arrest, then we might stop chest compressions until we do X, Y, and Z. So it's a good thing to bring up, I think, as a trauma team leader, so the team are prepared, so there's less of a moral injury as a result of that, because it's very difficult, especially if there's less experienced staff within the room, to have a cardiac arrest but no ongoing chest compressions. So something to consider.
Anybody do anything differently? I think really want to emphasize this is our interpretation. So for your departments, you should discuss with your team to see what you would do. And we don't advocate not doing chest compressions, but if it's going to put the patient or somebody else at harm, then I personally stop it. Using POCUS, does that change what you would do? Because taking on Chris's point about you put an ultrasound on the chest, you're able to ascertain if there's a pneumothorax or a hemothorax there. And if you'd done one and it was negative, would you continue to do chest compressions because you're not going to do your thoracostomies, or would you still do your thoracostomies and stop? What do you think?
I've had a little bit of experience in that there's a couple of times in which we've done prolonged resuscitation and thought of discontinuing, and the ultrasound has changed it, because as we put the ultrasound on, we can still see a heart beating. That's a different scenario to what you're asking, but what I'm saying is POCUS does have an influence on what you do. And just because you might not feel pulse because of low volume, it doesn't mean that the heart is not beating. As for whether I do it, I think if we are in a situation in which we are not getting anywhere, then yes, I probably would consider still doing it, but it's case by case, I think, depending on what kind of trauma you're dealing with as well.
I think
what would you do, Stephen?
So I was going to say I'd probably be in agreement with you. So I think the low sensitivities for your pneumothorax and hemothorax would mean that even a negative ultrasound doesn't say there's not one there. And I think the updated guidance from the Resus Council has advocated for the use of bilateral thoracostomy even in the absence of signs of pneumothorax or hemothorax. Now, they don't specifically say on ultrasound, they just say it's a general term on the absence. So I think this is particularly a question, it's a grey area where it's open to interpretation, your resources and your expertise. But what I would advocate is that you think about these before the case actually comes in, because this discussion can go on for a little bit of time. And if you've got a case in front of you, you want to really have thought of your answer beforehand.
Yeah.
So will we go on to see what the team has decided to do?
Okay, guys, so this is a traumatic cardiac arrest. So I think we're going to deprioritize chest compressions at the moment, Emma. We're going to focus on our life-saving bundle. So we really want to address oxygenation and optimize. We talked about getting ready for intubation, Dammy. So if we can proceed to get further organized for that. We've got our left-sided chest in situ. We need a right-sided thoracostomy.
Yeah, that's done.
With that, Jane, great. We obviously need to continue with our rapid volume replacement. So how are we getting on there so far? Still ongoing.
Second unit blood's going up now.
Okay. So we need to continue with that. We've addressed our So that's our hypovolemia. We've addressed our oxygenation. We've addressed any obstruction from attention pneumothorax by putting in the drain on the left side. I suppose we need to think about a tamponade.
Well, POCUS, the heart looked okay.
Julian, tubes in.
Okay, so perfect. Okay, great.
Right, guys, how long are we doing this for? With still no pulse?
I think that's 6 minutes now.
What do you think? Should we crack test?
Should we? Okay.
So I'm going to talk to you a bit about cracking the chest. And we have a question for you, but I thought just in case there are a few in the audience who are maybe not familiar with this, I just wanted to highlight what we're talking about. So we've talked about the bundle of life-saving interventions, and one of those interventions is putting in a bilateral thoracostomy. A thoracostomy is basically doing what you do with a chest drain, but not putting the tube in, just leaving a gap in the side of the chest into the lungs to allow for blood and air to come out, to release the pressure around the lungs, allow the lungs to reinflate, but also to allow the heart to beat without restraint. So the next step onto this, you see a big arrow pointing down, would be to consider you've got ongoing cardiac arrest and you've maybe got no real response to this life-saving bundle. So what a thoracotomy is you're extending that line along between the ribs, joining the two thoracostomies up, and then that allows you access to the heart, to the lungs and the thoracic cavity, allowing you to do a few procedures. There are a number of different procedures that are identified that could possibly be done, but the ones that sort of stick out and the ones that some places would agree to more readily is that first you're wanting to potentially identify whether there is a tamponade, and if there is, release the pericardial sac, let the blood out and allow the heart to beat again. So could your cardiac arrest be due to something compressing the heart, not allowing it to beat? The other thing is, if you've got a hole in your lung, a hole in your heart, you can put a finger on it or suture it until you get some cardiothoracic support to try and deal with that, try and prevent further bleed. And then you may even want to put some pressure on the descending aorta in the thoracic region just above the diaphragm to try and restrict the blood flow to the peripheries and allow the brain and the heart to be perfused better. So those are the potential options they are. This has been, over the years, a very controversial decision to make, and it's quite a difficult decision to make, and one that we've had to wrestle with. So the first question to you now, let me just start the poll before I put it up. Okay, would you proceed in your department, in your practice, would you proceed to a thoracotomy? And there is no right answer to this, but it's something that needs to be considered. I'll give you a few seconds to answer that. So getting some results coming in there, just give you a few more seconds to continue to ask the question, answer the question. Okay. So most people are saying yes, and I think this reflects a big change in what is currently what was previous advice or thought to be best practice. So I think it's a very interesting thing. And remember I said there's no right or wrong answer to it, and we're going to get to that at the end, talking about your department, knowing your situation, what you have available to you, who you have available to support you if you do make this decision. So there's a number of considerations that we need to have answered. It's not right to say yes for every department. It's dependent on each department, each situation. So we're going to talk about that. But before I come in with anything more, I'll be quite keen to understand if the panel have had any experience dealing with this, if any of the retrieval guys have had to do any of this type of procedure, if they've done pre-hospital, and see if there's any expertise from that point of view or opinion from that point of view. So why don't we open it up to the panel? If there's nothing, we'll plow on.
So I think we've considered it a few times in our department for a variety of cases, and on reflection, what I'll probably say is what Peter's mentioned before, is that pre-brief beforehand. If you're able to mention it, say that this is a potential intervention we're going to do, I think you allow people the head space and bandwidth in order to take that on. When you bring it up in the middle of a resuscitation, it can sometimes throw people. So I think getting it early is important. But also as a trauma team lead, you need to keep the indications clearly in your head. You can get completely cognitively overloaded in these scenarios. So sometimes having a discussion with another colleague to say, this is what I'm considering, so you're kind of voicing it together. But as a TTL, you have the end decision. So from my experience, it's that pre-brief is really important for any sort of intervention or an intervention like this that we're considering in the emergency department.
To specifically put you on the spot, guys, what about Scotland and England? In your hospitals that you're serving, have thoracotomies been done? Are they in place for your traumas considered? If Peter and Costas are still on there, would you have any feedback in relation to that? Maybe not present at the minute. So what I'd like to say is that a number of years ago, this was something that you would have probably been hugely criticized for doing, especially in a pediatric patient. And time has moved on. The discussion over pediatric trauma and the management of pediatric trauma has changed significantly. And Stephen, he's part of this talk, so obviously we're sort of singing off the same hymn sheet here. But these considerations that Stephen has mentioned are legitimate. I mean, we have to have this conversation. There is evidence out there. It's not overly strong evidence, as any pediatric study in this kind of area. It will be small numbers. But there's two studies that have systematic studies that have shown that for patients who have penetrating trauma, there is about a 10 to 13% chance of survival. Some of those have looked at whether there is signs of life at the time of presentation or initially, and then there's loss of circulation, and those show a higher percentage that potentially survive, but the overall numbers are still sort of 13.4 to 10.2%. If you have a look at the blunt trauma, so they've come in with a blunt trauma to the chest, but they've had bleeds. The survival rates are very low, and in some studies most studies have deemed that it's unlikely to be of any benefit to do a thoracotomy on a trauma patient that has got a blunt trauma. So there is some evidence coming in there. We have seen it. I've worked in Birmingham previously where these have been done in children. And as Stephen has said, in our ED, we have considered it on a number of patients who've come through, but not actually done one. I think that's a key thing, is that it needs to be part of your your consideration. It needs to be part of your team's discussion and your simulation training, so that when you have a trauma coming in, you can say to your team prior to arrival, if this is a penetrating trauma and they've had signs of life and the downtime is less than X, which we'll get to in a second, then we will consider opening the chest. That prepares the team for the potential trauma of opening a chest, because this is not an insignificant procedure to do, so your team need to be ready for it. And there's a thought process behind it. As I've said, you've already tried all your life-saving bundles and you've been unresponsive to further resuscitation. This child's still in cardiac arrest. And the algorithm for the consensus study on pediatric traumatic cardiac arrest would go on to the arrow points on down to consider thoracotomy. Now, it doesn't exclude non-penetrating or blunt trauma. It just says especially in penetrating trauma. So there is still a consideration that can be had there, but the evidence is mostly for penetrating injury. There are a number of things that you have to take into consideration when deciding to step into this. Firstly, do you have the expertise within your environment? That's the people to do it, all right? To make that decision, having the plan there, so that you know what you're going to do if you make this decision, because you've got a very short window to try and make this decision and do it before the effect of this can be benefited from. But you also have to have the expertise. Who's going to take over this care? So you say you open up this chest and you put a finger on a hole. Who's going to take over and close that wound for you? Do you have the expertise within the hospital to deal with what you find after you've opened this chest? Or do you have the ability to get them in? Do you have the equipment available to you in your department? And if not, and you're considering this, then this is one of the key areas that you need to consider. Now, this is a procedure that pre-hospital teams can do and have done, and we've known people who have done this in the community. But again, equipment is essential. What's your environment? Are you in a place that with people that can support you in this? Will your team go along with you? As Stephen said, this is often a discussion that doesn't come down to one person. It comes down to discussing with the team that's there. By the time in a hospital, you have got to the stage of wanting to open the chest. You should have other people there that you can ask. There's a resuscitation team, so you're making a decision together. The elapsed time is one that is important. So some guidelines would say if they've had a cardiac arrest within 15 minutes of you cracking the chest, then that is the kind of time frame you need. In our department, we've decided for 10 minutes. So if the child has a cardiac arrest within 10 minutes of us deciding to crack the chest, then that is something that we would consider. And that's if there's a penetrating injury. So the child has to had a traumatic cardiac arrest with a penetrating chest injury and cardiac arrest within 10 minutes, no longer than 10 minutes before we would open that chest. You got to remember that you're at a state where this child is not surviving the resuscitation at this point. And I think this has helped a lot of people sort of swing around to start considering, yes, we will consider this procedure, is because this child is going to die without an intervention. You're on your last straw here. You haven't responded to anything else. So are you going to crack the chest? And that is a question that then needs to, because you're going to have to justify this response at a latest time. Some people will criticize you for doing it, no matter what the situation. So you're going to want to have your guidelines written out. You're going to want to have a clear understanding that if I don't do this, the child is dead anyway. And therefore, cracking the chest is giving them that little bit of extra time or potential chance of survival. And that's what you're going to be explaining to the parents when they come in to see their child with their chest open as well. So these are the things that you need to consider when you're thinking of doing a thoracotomy. Communication is key with your team. Being prepared, having an agreed process of who you're going to do a thoracotomy on, having an understanding and simulating this with your team, so that the communication is clear, that the expectation is there, and that your resus is set up for it. There's no, as I said, no right or wrong. We're not telling you that you have to do this. We're telling you that this is what we've decided with the limited evidence that we've had, as this is a last step for a child to potentially get a life-saving treatment. But it takes a lot of courage to make that decision, and the courage comes from repeated practice, repeated discussions, having something that will back you up from that decision, and having your team support. Anybody else want to say anything before we shut off on that and summarize this talk?
Costas has got a hand up.
Oh, Costas, yes.
Sorry, my Zoom was down when you asked the question. I would say part of it is getting over the hump of, I'm going to saw someone's sternum open and open it up, especially in cases of penetrating trauma where it's found to be more useful. And we do say, do sim, make sure your team is set up for it, but very few people make the leap and say, well, actually, what does that translate into my emergency department? How does it translate? What came out of the events of the Manchester bombing, and in smaller part after the Southport stabbings in the UK, is that actually we are thinking about doing clamshells more and more, but we don't know where the kit is in our ED. It's locked up. There's codes to be pushed through. There's not enough people who have, are brave enough to take the bag and roll with it once it's done. So it's vital, much like we have a difficult airway trolley increasingly, and we all know where it is and what each drawer includes, that we have a clamshell kit in our EDs. We all know where it is, and we run a sim about it on a regular basis so that people know where it is, and take that side of practical issues in terms of human factors management out of the equation. And we all do it because it's such a rare occasion, unless you live somewhere with major trauma, lots of trauma, such as Johannesburg and stuff like that, that we in the UK we don't do enough of them. So just a bit of advice to set up your departments. HEMS, so pre-hospital teams, are set up much better for it because they expect to see it on the roadside. But once in ED, it's such a chaotic workspace that we rarely set up for it. They would know where the kit is.
I think the evidence base for its use is definitely increasing. It's still scant, but that Salinger paper, when you looked at, you break it down into some specific ones. So penetrating trauma with signs of life, either at ED or pre-hospital, have a survival rate of 31%. I thought that was phenomenal. We've looked at the actual raw data, and we're trying to update the systematic review, and that's the actual figure. So for me, if it was my son that was stabbed who came in and had loss of output in the ED, what would I want done? And I would probably say give him the best chance, because survival is pretty poor if you don't do it. So I think you're advocating based on the evidence base that's out there versus the fact that this is a true halo procedure, in that who has the expertise and the kit to do this in the time it takes, because this shouldn't take 10-15 minutes. You're talking minutes to get into the chest to do your intervention. So it's complex, and that's why I don't think there's any overriding push to do it. But certainly the Manchester Arena bombing made me think about it, as I don't think you'd probably get away if the indications were met by saying you're not doing it because you're not comfortable with it. We're trained physicians, and you need to have your team set up, or somebody in the department that is able to do it. So there's lots of things to think about for these cases, which is why we bring them up. So I think in the interest of time, Dr. Collins is who expertly led that resuscitation, is going to take some key messages, and then we will end this session.
Thanks, Stephen. Yes, apologies I wasn't able to join the start of the session. Thank you to the team for presenting. I am looking after a little one in the background. If you hear any noises, it's not just that I didn't want to watch myself on video. But I'm Julianne Collins, also a consultant in paediatric emergency medicine in the Children's Hospital with Stephen and Tudor.
So I suppose, yes, just a few quick take-homes. Thanks for the team for sharing. It was the best available evidence and their experience on what are really contentious and topical issues relating to trauma, but through a paediatric lens. And there's plenty of food for thought, I think, there to take back to your own departments and teams and look at your contexts. I think the other key thing to take away from it is how important it is to promote that psychological safety within the trauma teams, and that's the flattening of the hierarchy and creating those safe space to allow and enable discussion to ensure the best outcomes for the patients. And also, I think we've talked about a little bit there at the end about HALO procedures, which is those high acuity, low occurrence procedures and what we do. And I suppose it's that day that we're maybe all preparing for, that we hope never comes, but it may well do. And I think as Costas mentioned there, it's sometimes about making that leap, and the guys mentioned all the preparation you can do. And I think the other key is, as was mentioned as well, about getting your help present early. So I think those of us who maybe aren't used to dealing with open chests on a daily basis would certainly feel more comfortable proceeding if we know we have our paediatric surgeons by our sides or our cardiothoracic friends to sometimes just help build that confidence, even though you may have the competence from practicing the skills. But it's about that psychological leap sometimes, and making the decision to go ahead and what we're going to do once we've done that. So I know in the interest of time, I'll leave it there. But thanks again to all the team and to Chris for the opportunity for sharing this learning, which was recorded at the Northern Ireland Paediatric and Adolescent Trauma Symposium Conference in September. So thank you all for listening. If there are any final questions.
Listen, thanks guys, that's really good. Something very different. Good to keep it interactive, the use of the simulated video, and just something a bit novel. So really enjoyed that. We are going to draw to a close, but just before we do, again, thanks to Tudor, Stephen, Mary Beth, Damien, Peter and Julianne. I know we've run slightly over there before lunch. I think in the interest of trying to keep the afternoon moving, we're going to plan to meet again at 1:15 as per the original programme. So don't worry if you haven't finished your lunch, you can bring it back to the computer and join us at 1:15. So let's see you then. Thanks. Bye. Good afternoon and welcome back to Paediatric Emergencies 2025 conference. Hopefully you've had a chance to stretch your legs, get some lunch, and are looking forward to the next session. We have 3 different talks this session. The first is going to be focusing on sepsis with a bit of an interactive panel discussion. We're going to then have a talk from Dr. Donnelly around when your baby needs ICU, a personal reflection. And then we're going to finish the session with an interactive Who Wants to Win a McGrath educational quiz. So that's something different to look forward to at the end before the afternoon coffee break. Other than that, I think we're just waiting a few panel members come back, but I think we can make a start with this session. And I'm going to hand over to Dr. Chris Flannigan again, who's going to outline a case on sepsis, and then, as I say, there'll be a bit of panel discussion around management. So, Chris, over to you. I think you're muted, Chris, sorry.
Yeah, sorry, that's the audio back. I'll share that again. Okay, so how's that now? Can you see and hear me okay?
Yep, perfect.
Perfect. So forgive a slightly unrehearsed presentation. I've sort of picked this talk up at late notice. It's not one I haven't prepared, but I prepared it about 6 years ago, so I might have forgot a few bits. And we're going to modify it slightly, and rather than me doing all the talking, I'm going to try and do this as sort of an interactive case-based discussion with the panel. So we've got a case of a 1-year-old girl who presents to the emergency department with meningococcal sepsis. So a very short history of being unwell, pyrexia, out of form, and then this puperic rash, which is spreading in front of your eyes. So initial assessment on presentation to the emergency department, the airway's patent. She's tachypneic with a respiratory rate of 55 per minute, but the chest sounds clear and saturating nicely at 100% on a non-rebreather. Circulation is a bit of a worry. Tachycardic at 198, capreathal centrally 6 seconds, and a really quite worrying sign, a peri-arrest sign, hypotension of 55/28. She's really shut down, cool peripheries all the way up to the trunk, and you can't feel any of the peripheral pulses. Still responsive to voice, pupils are equal and reactive, and blood sugar's a little bit high as she's stressed. And she is pyrexic, and you've got this spreading puperic rash in front of your eyes. So in terms of the initial management, you're going to want to call for help because this patient has quite a high mortality rate if you don't do things right. You go ahead and get 2 ports of access. You manage to get 1 IV line. Access is proving difficulty, so you go ahead and put an IO in. So you've got 1 IV and 1 IO, and you send off your standard meningococcal pack of bloods. One slight modification, rather than just sending in a group and save, you actually decide you're going to go and cross-match products. Because you've done quite a bit, you've looked after a few of these kids before, and you know you're almost certainly going to give them products, and that would be something I would encourage you to do. Get blood products ready, because the last thing you want to do is keep filling these patients full of clear, useless fluid when actually you can give them something helpful later on. You go ahead and you resuscitate them, so they get 2 10 ml per kilo fluid boluses over the first 10 minutes. You give them some appropriate antibiotics, so that would either be ceftriaxone or cefotaxime. And I suppose the first question for the guys in the panel, any preference about what you would give?
With regards to clear fluid, is that?
Sorry, the antibiotics, cefotaxime or ceftriaxone.
Ceftriaxone is probably what I would go for, personally.
Yeah, and I think that's very common in Northern Ireland because it's their standard knee-jerk response. The difficulty is that ceftriaxone is going to have to be given over 30 minutes as an infusion, and you've worked so hard to get those 2 precious IV lines. And for me, I would much rather give a bolus of cefotaxime and free that line up for the other important drugs that you're going to want to give. The other potential problem you might have is with calcium administration. Quite often you're going to want to give these kids calcium earlier on, and you can't give them calcium while you're running ceftriaxone. So personally, I would give cefotaxime for those reasons. The advantages of ceftriaxone are really just once daily administration. And I think a bolus of cefotaxime 6 hours later, start the ceftriaxone. You've got all your lines to get the advantages from it. And then we go on ahead and reassess our patient. So you've got your gas back by this stage, and it's not pretty. pH is 7.18. We're okay from a respiratory point of view, but there is a really significant metabolic acidosis, and our lactate's making up most of that at 9.8. Hemoglobin's okay at the moment. Sodium, potassium okay, but our calcium is actually low. So you go ahead and actually reassess them after that first fluid bolus, and they haven't really improved. Cap refill still 6 seconds, still tachycardic, still hypotensive. So again, you push in another 2 10 ml per kilo fluid boluses. You decide to give the cefotaxime, but because the calcium's low, it allows you to give some calcium gluconate at the same time. After 40 mils per kilo of fluid, again, things really haven't improved. In fact, they're maybe a little bit worse with a cap refill of 7 seconds, heart rate's increased to 199, and blood pressure's 50/26. So what do we need to do now? And this is over to you guys again. What do you think?
Posed a few things, Chris. First, if we called for help earlier, I'm not sure exactly who we're called, but at this stage I'm going to be talking to ICU, intensivists and calling anaesthetics. I suppose other things you'd be wanting to think about would be use of products rather than fluids, and whether we're going to need any inotropic support. So I suppose that's a few of the things maybe we'd be thinking about at this stage.
Yeah, so all really good considerations. In terms of who you're going to want involved, you're definitely going to want consultant level support. If you're in the emergency department, the ED consultant, you're probably going to want the paediatric consultant as well to be involved. And like you say, somebody from either anaesthetics or intensive care. And when I find myself in this position, there's 40 mils per kilo of fluid in. You have to remember the child's circulating volume is 80 mils per kilo. So very rapidly, you've replaced half their circulating volume. So at this stage, you should have resuscitated them from a fluid point of view. And if that fluid hasn't worked, you've got fluid refractory shock. So for me in this stage, there's 3 things you need to do. You need to give them some more fluid. And this is the reason why you say, if you have products available, it makes sense to use sensible things. Probably at this stage, at 20 minutes in, they're still not available, so you might have to give crystalloid, but you're going to try and give the products when they come. You're going to want to start vasoactive drugs, and you're going to want to semi-electively intubate and ventilate the patient. So in terms of intubation and ventilation, why are we doing that? Our patients' oxygen levels are good. They're saturating nicely. They're a wee bit tachypneic. Why are we doing an airway and breathing intervention for a circulation problem?
So you're going to be giving significant amount of fluid to these children, which can lead to pulmonary edema as you go down the line. So you're going to be wanting to ventilate them to help protect their lungs a little bit. But you're also going to need to get central access and art lines in, which is a painful procedure, is much easier to do when the patient is intubated and paralyzed. And then you can give your inotropes and your fluids through that and products through that. And then makes it also more comfortable for the child, but it also reduces their metabolic demand. And I think that would, they're not moving, they're not stressed. It helps to manage them better, but also reduce their oxygen requirements and metabolic demand. Those are my key points.
They're absolutely perfect. And I think the third one is probably the big one, isn't it? Peter's showing that equation earlier on for oxygen delivery, and we'll come on to talk about it a wee bit later on. But the big issue is we're struggling to deliver oxygen to the tissues. That's what shock is. And what we can do is we'll try and optimize and we'll try and deliver oxygen as best we can to this patient. But the big thing that we can do is actually reduce this patient's demand for oxygen. So by putting them on the ventilator, we can, that cardiac output that was going to those muscles of respiration and the kids breathing away at 50, it's a reasonable amount of the cardiac output. We can use that to perfuse the vital organs. By going to sleep and putting sedation on, maybe trying to get that temperature down a little bit, all that demand for oxygen is going to go down, and hopefully then the patient will manage with a slightly reduced supply. So that's our goals. And in terms of how we're going to do that, we're going to have to resuscitate this kid before we intubate them. Because if we try and intubate them now in this shocked state, they're very highly likely to arrest. We're not going to ignore the airway. They're quite tachypneic, and we're going to want to pre-oxygenate them, so we can put them onto a breathing circuit, give them a little bit of PEEP, and take away a bit of that work of breathing, get them pre-oxygenated and prepared for intubation while plans are going on in the background. In terms of the drugs, we're going to use adrenaline as our first line vasoactive drug. Anybody want to cover how we're going to make that up?
For peripheral adrenaline, yeah. I suppose 1 milligram and 50 mils is sort of what I'm familiar with.
And do you know what rate you start that at, Stephen?
Well, we want to run it at 0.1 units per kilo to start with, I think, but I would need to double check rates.
And that's the thing, you've got all your resources there, you've got the apps, places have printouts, so you're right, it's easy to make up. It's 1 milligram and 50 mils, and you take the child's weight, which is 10 kilos in our case, multiply it by 0.3, and that's then going to give you your rate of administration. So for our child it would be 3 mils an hour, and that gives you 0.1 mics per kilo per minute. That dose of adrenaline is going to provide vasoconstriction and inotropy, and that's what we're going to want for our child, because we're going to want to support their heart. We haven't performed a point of care echo, and that may be something that's not going to be done in the DGH, so we assume there's going to be some myocardial dysfunction. We probably want to squeeze the afterload, so that dose is going to do both of those things, and that's why we pick that, and then we're going to titrate that to effect. There is a few important things you have to remember when starting that adrenaline infusion. Can you give me any of those?
I suppose, yeah, sorry, go.
Sorry, it's important to consider your dead space, and that's just in your cannula and also in your extension set. So roughly working out when the patient is going to be able to actually get that dose of adrenaline.
Yep. And it's quite scary, isn't it, how long it can take to administer adrenaline to patients. I think in the example that I've used, if we were to start this on a 3 kilo patient, so running at 0.9 mils an hour, To get through the standard dead space, 0.1 mils for cannula, 0.3 mils for connector, it would take 27 minutes. So one common mistake people make is they'll start this, it'll be running, the patient hasn't received it, and they go ahead and induce anesthesia, and then the patient arrests because there wasn't adrenaline in the circulation. So there's a few ways to combat that. One, you can take the little connector, flush it through with the adrenaline solution, so you're taking away the majority of the dead space. You've only got the dead space of the cannula to start. Other people will start at a slightly higher rate, wait for the adrenaline to hit the patient. You'll see that by the heart rate and blood pressure going up, and then maybe pulling that dose back. But you're definitely going to want to make sure your patient has adrenaline in the circulation before you induce anesthesia. So that's the little diagram of the cannula. If you don't know what they are, hopefully on the back of the packaging, it'll give you some information about the dead space. Or you can simply take a 1 ml syringe full of saline, flush it through and see how long it takes for it to come out at the end of the cannula, and then save that number away. What about push dose adrenaline? How do we make that up?
It would be 1 mil of 1 in 10,000 into 9 mils of saline.
Yep, so we're effectively taking our arrest dose of adrenaline and we're diluting it down by a factor of 10. And how much do we give in that in terms of mils?
Roughly 0.1 mil per kilogram, a maximum of about 2 mils.
Yeah, perfect. So you're given the same dose that you would give in a cardiac arrest in terms of mils, but because you've already reduced it by 10, it's going to be a tenth of that dose. So it's a little bit of adrenaline, tenth of what you give in a cardiac arrest, but it's still a pretty high dose compared to an infusion. If you had to pick between one of the two of them for our patient, which would you go for? So remember, our patient's hypotensive.
I would probably be greedy, Chris, and I would have both ready. I would certainly have the adrenaline infusion attached, but I might give a bit of push dose adrenaline that would work while I was waiting for the adrenaline to get through the dead space in my cannula.
Yeah, and I think that's exactly what I would do as well. The question I ask myself is, do I think my patient's at risk of arresting by the time I get my adrenaline infusion made up, connected through the dead space and reach the patient and titrated to effect? And if the answer is yes, I would give them some push dose adrenaline while that is happening. So I think for our patient, we know that hypotension is a peri-arrest sign, so we're very definitely going to want to start, I think, with that push dose adrenaline while we're getting our adrenaline infusion titrated to effect. So then we come on to intubating our patient. Is there anything in particular we need to take into account when we're intubating them? What would be our plan and what would be the risks?
I think just from an overall point of view, there's key communication that you need to give with your team here. This, as you've already said, is a peri-arrest patient, and you're just about to give them anesthetic agents that might, will in this circumstance, give further cardiovascular compromise. Even if you use drugs such as ketamine that is thought to be a bit more protective, their catecholamines are just all over the place at the minute and probably used up. So communication with the team that there's a high chance of arrest would be one of my priorities. I'm sure others will have other ideas as well, but you have to be ready for cardiac arrest. You have to have your fluid boluses ready. You have to have your adrenaline ready and running prior to starting this intubation.
Thanks, great points, Tudor. Anybody else have anything?
I would also say this is not the moment for your trainee to have their first go at putting a tube in. You need somebody, your best go needs to be your first go. And you need somebody experienced to be doing that.
Yep, definitely. Anything else? What about how are we going to detect that our patient is deteriorated, and what are we going to do about it?
You're going to have constant blood pressure monitoring, and then somebody else having their finger on the pulse, and then they're going to give push dose adrenaline if the pulse, if they note that it's decreasing, to be on top of it throughout.
Yeah, absolutely. The blood pressure, one, is too slow. Even if you have it cycling every minute, the problem is when that blood pressure drops, the cuff is going to try and find the blood pressure. It won't find it. So it'll try again and it'll try again, and then your patient will have arrested before you've realised. What we're going to do with our patient is we're going to resuscitate them to where we get them to a stable point. If somebody pops a finger on a pulse at that point and feels what the pulse feels like when we're happy with the patient, they get that sort of baseline. And then if that disappears, rather than waiting, they're just going to give that push dose adrenaline to bring the patient up, because pushing fluids in this situation is just going to be too slow. What about our drugs? What drugs are we going to use for intubation?
So we consider things like ketamine, just from a cardiovascular stability perspective, but bearing in mind that there's still a high risk of cardiac arrest, even with the drugs used at lower doses. Consider such things as muscle relaxants such as rocuronium, and I'd be avoiding propofol in this situation due to the potential for further hypotension leading to arrest.
Yeah, 100%. And what dose of ketamine?
So probably 0.5 milligrams per kilogram, but potentially even less, 0.25 milligrams per kilogram, just with how incredibly sick the patient is. Just kind of thinking I can give more if it's required.
Yeah, I've never in my life had to give one of these patients more. They go out like a light, and the moment they go out, their blood pressure just disappears. So yeah, you have to be ready for it. I tend to use a half per kilo, 1 per kilo of rock with it. But these patients will go out with that. They've never ever had to give them more.
Yeah,
so I'll just run. Sorry,
Chris. The only thing I was going to say about that is sometimes it takes them a little bit longer to go out because of their low cardiac output, and you have to be patient and not be tempted to give a second dose while you're waiting for that first dose to work.
Yep, exactly. So I'll run through the slides. I think we've probably covered most of this. So we've got finger on the pulse because the blood pressure is going to be too slow. No propofol, ketamine and rock. You might want to have some resuscitation drugs prepared as well, or you definitely will. Cuff tubes, but that's now standard practice. It wasn't when I was preparing this talk originally. And whatever you do, don't put that tube down the nose because they're coagulopathic and thrombocytopenic, and the last thing you need to do is create more problems. Okay, so let's look at what happens to our patients. So we go ahead and give them another 20 mils per kilo of fluid, so 60 mils in total. Where our peripheral adrenaline, we titrate up from that 0.1 to 0.3 mics per kilo per minute, so a really good pressor dose of adrenaline. With that, we do get a bit of stability, so heart rate comes down to 170, blood pressure comes up, and cap refill returns to 5 seconds. So we feel we've got a window to get this patient intubated. We do a modified RSI, half per kilo ketamine, 1 per kilo rock, but they do bottom out their blood pressure during this. They need 3 boluses of push dose adrenaline, and we're having to put the adrenaline infusion up to 0.5 mics per kilo per minute during the intubation. So we go ahead and reassess them after the intubation, and putting the tube down was straightforward, and that's quite often the bit that is straightforward. The intubation is normally easy. It's keeping the patient alive during the intubation. That's the hard bit. So we'll appropriately sized cuff tube in a good position on our chest x-ray. We go into standard settings on the ventilator, and we repeat our blood gas. So still acidotic, it's not respiratory, it's all metabolic, and our lactate is actually higher than what it was before. So we're not clearing our lactate. Our hemoglobin has dropped to 89. Not a big surprise, we've diluted things down with 60 mils per kilo of fluid. Salts are still okay, and despite 1 calcium top up, our calcium's dropped again. So why is our calcium so important? Why am I focusing a little bit on it?
It's because your inotropes work on myocardial contractility, and you need calcium to sort of facilitate that. So without adequate calcium, your inotropes aren't really going to do the job you're looking for them to do.
Exactly. They all increase intercellular calcium. If you've got no calcium, they can't increase it, so they're not going to work. We get our central line, north line in. We move our adrenaline over to the central line. Importantly, you're going to want to double pump it over. You can't just stop it. But we're still not winning. We're tachycardic again. Blood pressure's dropped. Cap refill's back to 7 seconds. We can't feel our peripheral pulses. Our CVP is low at 6. It's a neckline in a ventilated patient. It should be a little bit higher than that. And probably the most worrying sign is our venous sats are quite incredibly low at 34%. And our lactate's elevated as well. We go into standard sedation. Blood sugar remains a little bit high, but we're not going to do anything about that. And we get our bloods back, and not a big surprise looking at the bloods. Our hemoglobin matches what's happened on the gas. White cells are up, platelets are low. We're coagulopathic with a prolonged PT, APTT, and low fibrinogen. Renal function's not too bad. Calcium, albumin, and CRP is elevated as well. So our calcium's telling us what our gas has already done, and we're sort of looking into the past at this stage. We put our patient up on 2/3 maintenance fluids, and we get our bladder catheterized, NG tube in, and we've already given our antibiotics. So we want to take a look at, are we meeting all the goals that we want for our patients? So if we take a look, have we normalized the heart rate? No. Have we increased our CVP to an appropriate level? No. Have we got a normal blood pressure for age? No. Have we cleared our lactate? No, it's still increasing. And you can see we're normally aiming for mixed venous oxygen saturations greater than 70, so they're incredibly low. Cap refill hasn't improved. We don't have normal pulse volume. Our peripheries are freezing, and we're not sure about the urine outputs. The catheter's only just in, but there's not very much urine in the bladder. So we're not really doing a great job with this patient at the moment. So this is where Peter's already talked about this formula for delivery of oxygen to the tissues. Our patient has a problem with oxygen delivery. We have done our best to reduce the extraction of oxygen so we can get away with a minimal supply by taking over the work of the muscles of respiration and putting our patient to sleep. And certainly if we can try and get that temperature down a little bit, that's going to help as well. But we want to improve our delivery of oxygen to the tissues. And Peter's showing you the nice complex formula. What I tend to do with this formula, don't tell Peter, is put a line through it and just look at the variables. And the variables are hemoglobin, saturation, and cardiac output. And these are the variables that are going to determine whether you deliver oxygen to your tissues or not. So in terms of our hemoglobin, what do you guys think of the hemoglobin? I think it was in the 80s.
It could definitely be optimized. We could definitely give packed red cells and try and push that up to 100 or even above 100.
Yep, so that would be our target, above 100 when you're struggling to deliver oxygen. And the idea is if you've got more hemoglobin molecules going round, even though the pump's not moving them particularly well, you're going to have more molecules that the tissues can strip oxygen off. We're already saturated at 100%, so we can't do anything with that. But the other big potential problem is our cardiac output. So we're going to need to take a look at that and see what we need to do here. So I like to break this up into, there's the tank. You have to decide, do I need to put more fluid into the tank? There's a pump. Do I need to decide if I need to do anything with the pump? And there's the pipes. So we either sometimes need to squeeze the pipes, but other times we need to dilate them. Because you have to remember, the big thing you're interested in is not blood pressure, it's flow and flow to the major organs. So in terms of how we're going to decide if we need to do fluid, there's three major things I tend to look at. We've got our CVP, which is a little bit on the low side. If this is our patient's arterial line, what do you think of it? Does any signs that our patient needs fluid?
Yes, there's a swing in the outline. It's not coming, it's not all static.
Yeah, there's a very significant swing, isn't there? I tend to think if it's more than 10%, I would call it significant. And that's quite a big swing. So CVP being low tells us probably give fluid. Swing in the outline, probably give fluid. And when we do our point of care ultrasound, there's a bit of debate whether it's useful in trauma. It's very useful for our medical patients. This is our patient over the right-hand side. We're looking at the IVC. So what do you think of that IVC? We've got a normal one on the left-hand side.
Very collapsible.
It is. So with respirations, it's collapsing. So there's three things that are telling us we probably should give our patient more fluid. And why are we having to give them more fluid? Sure, we put 60 mils per kilo into a circulation that normally has 80 mils per kilo.
The vasodilatory condition, and there's capillary leak.
Yeah, they're the two big things. So they could be dilated, but the big one is that leak of the tissues out. And what you tend to have to do, sometimes you're giving these patients hundreds of mils per kilo over the first 24 hours. It's that the bolus helps for a wee while, it stays in the circulation, it leaks out, and then you have to give more. And you're just trying to buy yourself time for things to get better. But certainly looking at this, our patient probably would benefit from some more fluid. In terms of the function, we're going to put the echo probe on. What do we think? Do we need to do anything with this? We're on 0.5 of adrenaline. No, it looks fairly normal, doesn't it? It's not hyperdynamic, but there's certainly the cardiac function looks good. So the 0.5 of adrenaline is doing its job. And in terms of the afterload, you can do all sorts of fancy cardiac output monitoring, but I think the simplest thing to do in the DGH is look at the pulse pressure, your difference between your systolic and diastolic pressure. If there's a really big difference between the two, you probably want to squeeze things. If they're too close together, you might actually want to dilate things. So that would be how I would look at the afterload. I think it's helpful to put our patient into one of these groups, and it helps decide what drugs you're probably going to want to use. So our patient has low blood pressure, and do they have cold or warm shock?
A cold shock.
They're cold shock. So if we look here, we've already started with our adrenaline. The next thing to add would be noradrenaline. We're on a pressor dose of adrenaline. It's not working, so we probably want to think about some noradrenaline. So in terms of our progress for our patient, we go ahead, thankfully we've cross-matched those products right at the start. So we're able to optimize our oxygen delivery by giving some blood. And obviously this is going to work as a fluid bolus as well. We give some FFP, cryo and platelets. So we're able to resuscitate our patient with useful fluids. And a lot of these problems we've exacerbated by the amount of clear fluid we've had to give initially. We start some noradrenaline, titrated up from the normal starting dose of 0.1 to quite a big dose, 0.6 mics per kilo per minute. But this makes no improvement to our patient. So why aren't the vasoactive drugs working? What could the cause be?
Did we ever fix the calcium?
We did, but that's a very good point. So if the calcium had dropped again, we probably need to fix it. What else? It's a question you always sort of ask yourself, why are my drugs not working? What could be causing it?
I suppose we need to consider the lines they're going through. Are we happy that the lines and they're actually getting the drugs delivered to their body?
100%. So we check the line, it aspirates beautifully from another lumen. We've got a normal CVP trace, so we're happy with the lines. What else could be wrong with the drug? Sorry?
Well, an awful pH, so it doesn't work. The drugs are not working.
100% could be pH. Any other ones? I have a big list on the next page. See if you can get a couple more. What else? The DGH has made these drugs up.
Are they made up correctly? Are they the concentration that you're expecting?
So there's always a risk, isn't there, when somebody's making up a drug or a treatment that they don't normally use, has it been done correctly? And that's one of the things you're going to, well, first things we go out is what's in the syringe, what's it running at, and do the calculations ourselves. So I'll go on to the next page. So we got the line. Dead space should be sorted by this stage. Errors, pH, calcium. Have we picked the wrong choice? Steroids we haven't mentioned. And normally we come in to think about relative adrenal insufficiency when we're on 2 vasoactive drugs and they're not working. What do we mean by relative adrenal insufficiency? Is this patient, is their cortisol production low?
Their cortisol production is probably high, but it's the fact they're sort of consuming those catecholamines that they naturally produce. So they've got a relative deficiency, not an absolute.
That's it. So you've got to, normally as your stress goes up, your cortisol production goes up and they tend to match. In this overwhelming sepsis, your stress is here. The best your body can do with cortisol is here. So you've got a relative deficiency. So what you want to do is add some low dose hydrocortisone in to try and sort of bridge that gap. You don't want to do high dose where you're going to suppress the immune system because the studies have shown that increases mortality. And then you're going to want to think, have I got the right diagnosis? I'll not go through all this, but there's a list of other things on the side you might want to consider. I think it's very clear in our case that we have got meningococcal sepsis, but we might want to put the echo probe on and make sure we haven't developed a pericardial effusion, we haven't popped a pneumothorax, or we're not developing one of these other mechanical causes of shock. So we go ahead and give some more hydrocortisone, some calcium and some bicarb, and again be careful you're not giving the calcium and the bicarb straight after each other in the same line without a good flush, because they don't mix particularly well. And we reassess our patient. So A and B are pretty much unchanged. We're ventilating quite nicely on not a lot of oxygen. Our adrenaline's still running at 0.5. The NORAD sneaked up to 0.6. Heart rate's still up. Blood pressure now has been a bit of a change. It's up at 98/74. And our cap refill is 6 seconds. We're still shut down. CVP's increased up to 18 from 6. And our venous sats are still low at 36. Nothing's really changed with D. And in terms of our gas, we have fixed our calcium, we have fixed our hemoglobin, but our lactate is still high. So what now? I'll go back to this slide and you need to tell me what's happened.
Your blood pressure has improved a lot. The patient's still very tachycardic. Your venous sats are still low.
Yeah. What do you think of the blood pressure in terms of the pulse pressure?
It's a bit too good and it's a bit narrow. So I think you might be overdoing your vasopressors a bit.
Yeah, and what does the CVP? The CVP sort of telling us the same thing, isn't it?
Yeah, and they're well filled. You can sort of get an idea of that from the CVP now.
Yeah. So why have our drugs suddenly started working?
Could be any of the 3 things that you did on the last slide.
Yep, definitely. So and this is what happens to these patients. They flip from one type of shock to another. So at any 1 minute, the treatment that you're giving, which is correct, is completely wrong. So this is all telling us we're on too much pressure, we're squeezing too hard, and we're not getting flow out to our organs. So what do we need to do about it? Should we add in, if we look up at our graph, we're now in high blood pressure cold shock, and it's telling us to begin some milrinone.
I might get it made up, but I would probably start with trying to wean that adrenaline back a bit, because you're on a vasopressor dose of adrenaline and you might be able to get that down a bit and improve things just by doing that.
And that's the key bit here, isn't it?
Tachycardia as well.
There's 2 approaches to intensive care. When you create a problem with one of your treatments, you can add another treatment in to fix the problem. And when that creates a problem, then you add another treatment in to fix it, or you think, can I take away the treatment that's causing the problem? So we can dilate our patient by turning our pressors down rather than adding in another drug, because we're happy with our function. We don't need any more inotropy. And milrinone's it's a good drug to use where you need to, but it's slow to act. And once you've started it, it's a long half-life, so you're not going to be able to turn it off that easy. And just turning the drugs that are too high down is probably what we need to do for this patient. So we'll go ahead and wean our adrenaline down to 0.2, NORAD down to 0.3, and with that the heart rate falls, the blood pressure improves to a more normal level. CVP drops as we've widened our space, so the amount of fluid that there is appropriate for the space, and with that we're now starting to perfuse our organs. Our venous sats improve, they're not too far away from our target, and our lactate starts to fall. You'll probably notice an improvement in the venous sats before the lactate, and our patient is starting to warm up out to their knees and elbows. And at that stage, the paediatric retrieval team arrived to pick the patient up. So in summary, I think the key learning points are, before you intubate one of these kids, make sure you start your peripheral adrenaline and make sure to reach the patient before you induce anesthesia. If you don't, you'll be doing CPR. Remember, the goal is to restore cardiac function and afterload and filling to normal. So when your patient isn't improving, don't just keep turning the vasoactive drugs up, because as you see in our patient, that's the wrong strategy. Remember, don't forget about your calcium and your steroids. I think out of all the big list of problems, they're the two big ones. And the things that I like to monitor are particularly your lactate and your venous saturations as a marker of improvement. If they're not improving as you resuscitate your patient, you need to ask yourself why. And you should definitely be phoning the paediatric retrieval team when we can discuss this through with you and work through the case with you to see what we need to do with the patient. So that's everything that I want to say. I just wonder, do any of the panel have anything they want to add to what we've covered? Sort of the key learning points and pearls.
Thanks, Chris, because I know you've put that together sort of fairly last minute, and thanks to all the panel for contributing. There's a couple of questions I might just go if people are having to think about any additional comments. One was around the choices. So we talked about sedation with morphine, Midas, and whether you just use standard doses or whether, given that they're shocked and septic and probably reduced GCS with that, do you use slightly lower doses?
You definitely need lower doses. Again, this was an old talk that I did. Basically, Peter will be rolling his eyes at my sedation choice. We'll try and not get into that, but whatever you use, you need less. These kids don't need an awful lot to keep them asleep, and all these drugs are going to drop their blood pressure, so you'll get away with a minimum amount. So definitely less. And in terms of boluses, you're going to have to be careful about loading them up with boluses. You're not going to need to give very much.
Perfect, thanks. And the other question was around person who posted was interested in the 1 milligram per kilo induction dose of rocuronium, given low cardiac output and delayed time of onset. Is there a downside or conversely a benefit to using 1.5 to 2 milligrams per kilogram?
It's not something that's been ever part of my practice. I've heard other people do it. I've always found the 1 per kilo works well. What about others on the panel? Would you increase that up?
I'd draw them twice. I'd draw 2 lots of 1, and if it's taking forever because of a low cardiac output state, I bang in the second, and I'll do it with the other 2 drugs, Ket and Fent, as well, if I needed 1 per kilo of each. Fentanyl is in micrograms before someone gives a massive overdose. But yeah, rock can take slightly longer, so 1 per kilo is usually enough. But if it's a very low cardiac output state, I can use the second one pre-drawn.
Yeah, I take my time. I think if you rush it, you will inevitably make things worse. So just be patient if you can.
Thanks, guys. Well, listen, thanks again, Chris. Really appreciate that and enjoyed that. We're now going to move on to Peter Donnelly's talk. Peter Donnelly is a paediatric intensivist. You're still based in Glasgow, Peter, is that right? Yeah, from Glasgow, and he's going to talk about speak on the subject when your baby needs ICU, a personal reflection. So, Peter, over to you. Thank you.
Just let me know if you can see slides and things like that.
Yeah, it says it started to share. I'll just give it a minute and see if it comes up. That's it. Yeah.
Awesome. Okay, so a bit of a different talk for me, and thanks very much for entertaining the topic. I know that the PSU Glasgow emblem is there at the top, but this is just because that's where I work. It's not a reflection of anything that ever happened in Glasgow, but this is Eve's story. I am her dad, and as you can see, she is full of character. So the disclaimer to this talk is that she was never actually that sick, right? So, and I thought a little bit about whether I should even take the time to share my experiences being on the other side of the child in ICU, because she wasn't that sick, certainly in terms of where my benchmark is. But I still think there was lots of learning opportunities from my experience, and therefore I still think there's value in exploring that. But Evie began her journey quite a while ago. She is a surrogate baby, so she began her journey in 2022. And as all surrogate babies are, she was an IVF embryo creation, which is a bit different to what is the norm. And I'll use that word a couple of times potentially, but it's just recognizing that things were a little bit different for her. She was a surrogate baby born in Colombia for lots of different reasons. So she is currently Colombian, and as of yesterday has a UK passport and is also a UK citizen. And it took a long time for Evie to make an appearance. We had a lot of embryo transfers across 2024 that were unsuccessful. And so she was long awaited and loved before she arrived. The antenatal story was, let's see if I can minimize this actually a little bit, because this is probably on your screen as well. I don't know if it is. There we go. The antenatal story was unremarkable, or so they said. And what I mean by that is in the surrogacy program, we get regular monthly updates. And we were told, as we asked and as we communicated with the surrogate and with the clinic, that everything was fine. And we arrived in Bogota at about 36 weeks gestation, planned to be there early just in case, even made an early appearance. And part of that was us being able to go to the clinic appointments with our surrogate, and also anaesthetic appointments, planning appointments. And it was during the anaesthetic appointment, recognizing that all conversations were happening in Spanish, and Google Translate cannot keep up with conversational Spanish. What I did recognize were words such as metformin. And that just sent a little bit of alarm bells in terms of, okay, there's clearly gestational diabetes going on. Why didn't I know that? You know, I have asked, is everything fine? And I'm told everything's fine. So that was a little bit frustrating, and also made me question, is there anything else that's gone on that I don't know about? We went to a clinic appointment at 37+5, and whilst the surrogate was in at the appointment, normally she would go in first and then we would go in after to join her. She texted me and said, they're talking about my blood pressure being high. They want to send me from the clinic to the hospital. And then she said, oh, I think there's protein issue. And I said, right, this is going to be preeclampsia. So she came out with a letter and she said, yes, they want me to go to the hospital. Shall we go and get breakfast on the way? And I said, I don't think that's a good idea. I suspect you're going to get a section today. Let's arrive fasting and then see what happens. And I'm glad we did, because lo and behold, there was a plan for an emergency section. Avian was born in good condition. She spent 48 hours in neonatal ICU, not because she was in any way unwell, but because our surrogate was admitted to adult ICU for blood pressure monitoring, as that was their routine practice. She was fit and well, but she was there for monitoring. The practice in Colombia is that when a baby is leaving the hospital, the surrogate or the gestational carrier or the birth mum, depending who it is the person who carries the baby over the threshold. So from a surrogacy point of view, that means the surrogate carries the baby over the threshold and then hands the baby to you. But a very kind neonatologist on day 2 came to us and said, why on earth are you still here? Is that the only reason you're still in this hospital? That's ridiculous. Went and got a disclaimer signed, and we were able to leave and go home. So obviously it wasn't home, it was in Colombia, it was in an Airbnb, but we settled into family life, getting used to the feeding, the routine, the sleepless nights, the baths, all of those normal things, and everything was really, really lovely and as good as we expected it to be. I will say that the first bath was fairly traumatic for her, and now subsequently she loves the bath, but she was small. She was 2.7 kilos when she was born, and over the course of the first week dropped down to 2.5 kilos. So within the expected realms of weight loss, and she was doing well. Seen by a paediatrician routinely as part of our surrogacy plan at a week of age, and everybody was happy with how she progressed. However, shortly after that, she wasn't great. And you will sometimes see people or hear people talking about a baby that's unwell that just looks at you with sad eyes. And I know that's not scientific and people might be like, oh, that's nonsense. But sometimes when you're doing a ward round, you look at a kid and they're just looking at you in a way that you're like, I feel like you're asking me for some sort of help in some way. And that is very soft, but it is genuinely something that I think is real. And she was looking at me like that. And then if your volume's up high and you can see this video, you'll see what she was like. So I don't know if that's easy to appreciate, but she is at rest, sleeping, settled, but she is grunting. And she has got work of breathing in the form of a kale plug. She's got intercostal recession. So of course, being the first time dad, I'm like, oh my word, I need to bring her to hospital. But am I being ridiculous? I'm an intensivist. I'm immediately thinking this is crazy. I know the red flags in terms of work of breathing, but somebody else tell me I'm doing the right thing. luckily, I know a lot of paediatricians, sent them the video and said, I think she's grunting, I'm going to bring her to hospital. And they said, of course she's grunting, bring her to hospital. And that is good for me personally, to have somebody that can ground me and be like, you're not being ridiculous. But she displayed work of breathing. So we brought her up to the hospital in which she was born. They checked her saturations with an adult saturation probe, which was surprising, but the saturations in her were about 88%. And therefore we were told we were being admitted, and their policy was to admit to neonatal intensive care. So we were in a holding area for quite a while. She was relatively comfortable. Numbers were okay. Heart rate was in the sort of 140s to 150s, and saturations were easily maintained in the mid to high 90s on a very, very small amount of oxygen. So pretty okay with that. She was brought up to the ICU, and we were asked to sort of leave until they got bedded in and all the rest of it. And she was electively put into a cubicle and then electively stripped down and put into an incubator, which obviously was turned up from a temperature point of view to maintain her temperature, even though she was stripped, and she was kept on her nasal cannula oxygen. And from there was a number of disagreements and things that I personally struggled with. My concerns were feeding, the use of medications and skin breakdown. And the biggest one for me was her feeding. Now, from a feeding perspective, before she went into hospital, she was on 150 mils per kilo per day. So she was on full feed volumes, what you would expect a baby to be tolerating. And she was putting on weight again after dropping to 2.5 kilos. So we were happy she was going the right direction. She was tolerating 150 mils per kilo, and that equated to 60 mils 3 hourly of feeds. And whenever I had a history taken at the start, I was very clear on that. And then I heard them say to the team, she feeds 60 to 90 mils per feed. And I said, no, she feeds 60. And she's got bronchiolitis. She's RSV positive bronchiolitis. So therefore, she could probably be okay with about 45 mils of feed as long as she maintains her blood sugars. 45 is fine. Despite that, they kept trying to push her to take 90 mils of feed. And they pushed and pushed up to the point where they were almost aiming for 300 mils per kilo per day. And that concerned me. And every day I had a conversation with them and explained what my concerns were and asked them, could we just agree at least no more than 60? Every morning they agreed, and every night shift when I was around and they had to change of staff, they went back to trying to give her 90 mils. And what really upset me was whenever I was feeding her, or when I was allowed to feed her, and I gave her a bottle and she took 60 mils, they would shake their head and tisk at me for not giving her 90, even though I said I was happy with the 60, as if I was doing a bad job. And that was really hard. And that was really, really frustrating, because you felt you were being told you weren't doing a good enough job. And lo and behold, then they pushed, and I came in after leaving for a couple of hours, swapping, doing shift work, came back in to find that an orogastric tube had been put in, and they were tube feeding her, again pushing to get these volumes. And what frustrated me even more was that, as you can see from the picture on the left, they used gravity to tube feed, and quite often they would put the milk into the syringe, walk away, and the milk would just sit in the syringe. It didn't actually go anywhere. So she wasn't being fed, and at times she was crying and upset because she was hungry. And the one positive out of that is that one nurse came in and she just put a slight angle where the feeding syringe met the incubator, almost putting a kink into the actual NG tube, or the orogastric tube itself. And that made the milk flow in quite nicely, which was a trick I didn't know. But if you're going to think about silver linings of this experience, that was very useful. And then over the coming days, anytime she was fed and people would walk away leaving this milk in a syringe, I knew how to make sure that the milk ran in. Now, on one occasion, they insisted again on night shift to try and give her 90 plus mils, and she vomited. And then she vomited and she started working hard because she had just vomited. The medical team was asked to come in, who attended immediately, and told me that she needed salbutamol. I said she didn't need salbutamol. Her heart rate was 185 to 190, and that she was working hard because she'd just vomited. And actually, leave her alone. Or if you're worried about aspiration, then get her a chest X-ray and see what we're dealing with here. And you can have your own views on that, but I certainly felt salbutamol was the wrong thing to do. And they weren't happy that I declined the use of salbutamol, but I felt strongly about it that it wasn't necessary and it was wrong. And then the third thing was skin breakdown. Her skin was fine when we entered the hospital, and during the course of the admission, for whatever reason, and I don't know why, her skin breakdown around her nappy area was really quite significant, one of the worst I've seen, and it resolved whenever we got her home. There is no blame attributed there because I don't think anyone did anything wrong. It was just an observation and another element that I find stressful. It was hard being separated from her in terms of being able to hold her, being able to form a connection, recognizing that a surrogate is in a different country, trying to form a bond and an attachment. She hasn't heard our voices antenatally, that's for sure. It was really difficult to then be separated from her and to watch her struggling. And on occasion, 2 occasions over the course of a number of days, one of the staff very kindly let me hold her. And that was really important for attachment and for just having that human connection. And we greatly appreciated that. So my issues were, and I sat on one of the last days, towards the last day of our admission, and I finally, after requesting many times to speak to the medical team, one stuck their head in the sort of isolation room and said, thumbs up, and closed the door and walked away. And I had to come back, run out and be like, come back here. I've been waiting for days to speak to somebody. And I said, listen, from my point of view, the oxygen, she needs it. Yeah, her sats absolutely drop when we try and take it down. Not very much, but she definitely needs some. The intubator, I don't think she needs it, but I'm not arguing about it. It's fine, don't mind. Do you know, if you think that's your policy or that's the right thing, don't mind. Feeding volumes, I feel strongly about that. It's not necessary and it's made things worse. There are things that you might want to do that I don't mind. I don't necessarily think they're required, but I don't mind. But if you're going to do something that I think might cause harm, then I do feel strongly about that. And therefore, that is why I keep raising this concern about feeding volumes. And it has made her worse. The tube feeds were probably not needed. Salbutamol is absolutely not needed. And it was very clear in that conversation that their priority was optimizing calories and growth. And it was very much, in my opinion, this is bronchiolitis, this is a pediatric ICU bread and butter, this is my bread and butter, what I deal with all the time, versus their mentality of this is a neonate who needs to feed and grow. And she didn't need to feed and grow, she just needed to have the support that she required, but without over-egging it. And therefore I felt she was over-medicalized. So we agreed that there would be no new changes made without discussion and conversation. And I think we were respectful and towards each other, recognizing that we did have different opinions on things, but we were both trying to do the same thing. And my frustration was that I never wanted to be Avine's doctor. My role was her dad, and that was it. And I wanted to have that role and just have that role. And I felt really frustrated that I felt the need to advocate so strongly from a medical perspective, and I found that really upsetting. That's not what I had wanted for my relationship with the team. And then on one morning, we got a knock on our Airbnb door, and it was an insurance company with oxygen cylinders who told us, oh, by the way, the hospital, have they told you your baby's getting discharged today? No, nobody had told us that. So we had no idea she was coming home. And we obviously rocked up to the hospital and they said, yeah, you're going home, no medical discussion, bring her home and arrange your own follow-up, which we thought strange, very strange. So we brought her home. We did have an outlet in terms of a home monitoring system, which I mean, I'm a big advocate of, particularly now, but for a number of reasons, I'm a big advocate of that. It works for me, and she still wears it every nap and every nighttime. We contacted the pediatrician who had done her 1 week check. She agreed to see her in a couple of days' time. I started weaning her oxygen, accepting saturations on average of 92 and above. It did stimulate me to go and look at the literature. There is some really nice bronchiolitis literature in high altitude countries based out of Bogota and Colombia. So that was useful for me. And then lo and behold, we got a message from the surrogacy clinic to say that a pediatrician had been arranged and was coming out the next day. So within 24 hours, we had 2 pediatrician appointments. Both of them knew each other. And that was a bit unusual, but it was just not what we had been told we needed. Life with home oxygen is fairly restrictive, and big cylinders in terms of even just moving around to do nappy changes and baths and whatnot, it is quite difficult. but we were lucky actually to be in a relatively small B&B, so the mobility was less of an issue. She did well, and we weaned the auction off fairly quickly, I would say. And 2 days after that, we arranged to get her flown home. Getting home was challenging. It had its own issues not from a medical point of view, but from a certificate of an entitlement, which is different from a visa, but the same concept. But it was important for us to get her home and finally have family support and get her settled into her actual home. As you can see now, she is absolutely thriving. She is piling on the weight. She now loves her bath, and she is a very, very happy little girl who's had her own issues in terms of feed intolerances, cow's milk protein intolerance, whatever, but she is absolutely thriving, and she has jumped up to somewhere between the 75th and 91st centile. So what are my reflections from this experience? Firstly, I found it really difficult to even write this presentation, and I didn't expect to, but reliving those challenging conversations and that constant need to advocate and feel like you're fighting every day on something as simple as feed volumes was really quite difficult. Language barrier was difficult. We were never offered an interpreter, translator, whatever. We were using our phones, and that was hard. The medical team weren't particularly present for us despite us asking to meet with them, and that was hard as well because we did ask. And I did feel like I didn't want to tell people how to do their job or assume that I knew best, but I couldn't be afraid to advocate for what I thought was right. And the conversations that I had, they did stimulate me to challenge my own thought processes. You know, is there a role for salbutamol? Historically, you know, a lot of us have been taught babies don't have the appropriate receptors. Well, actually, more recent evidence says that they do. It's just that they don't work in bronchiolitis because of the pathophysiology. So obviously, I wanted to separate the roles of being an intensivist and being a dad, but I wasn't able to. And the loss of control over how my daughter was managed was really difficult. Challenging dogma I've mentioned, I think that was a really good thing for me, personally, professionally, making myself challenge myself in terms of what's the right thing to do. There were positives, you know, learning little tricks for orogastric tubes. The team were trying their best, and they did have Avine's best interests at heart. The community paediatrician who had performed her 1 week check, we did contact her through the process and tell her what our concerns were. And she phoned the neonatal unit and she advocated for us. And she said, you know, I've spoke to so-and-so, they're on tomorrow, they're going to come and speak to you. She tried her best, and having her as a point of contact was really useful, and we felt incredibly supported by her. And we're very grateful for that. And we're very grateful for the care in general that was provided. So that is my experience of Avine. We are going back for round 2. Baby boy is due in January, so we are going back to Bogota very, very soon. And yeah, if you have any questions about that, please do not hesitate to ask, and I'll finish there.
Thank you very much, Peter, for what's a very personal and reflection on your experience, and very different kind of talk and change of tack from what we've been doing today, but equally important because so much we do is not just the medical care, it's about how we interact with patients, parents, families, and in what is, particularly when any child's unwell, a very difficult time of high emotion. You've shared some of your reflections on it in terms of, have you noticed, I suppose one question I have would be, have you noticed any sort of tangible change in your own practice or how you deal with families in that scenario, or how have you sort of learned from that in the work environment?
Yeah, so
your thoughts on that?
The positive thing is that with surrogacy leave, I'm still on parental leave, because it's the same as maternity leave. I have 6 months off, and I will then go off on another 6 months. So, but I have thought about that and how does it influence how will it influence my practice? And I guess the one thing that stands out for me is the amount of times I do a ward round and family aren't present. And then you maybe get a phone call when you're in the middle of dealing with something else saying, so-and-so's mum and dad are here. And you try to go back and update them to the best of your ability, but if you get caught up, it might be hours later. And I think only now do I have a realistic, true understanding of how difficult that is to be sitting there with no information. And that doesn't need to be a consultant. Like, it's never needed to be a consultant. It just needs to be somebody. And sometimes the bedside nurse is the best person to give that update because they were there at the ward round and they know what the plan is. And sometimes that's all families need. And I think making sure that families understand what the structure of the day is in your unit. What time do ward rounds happen? How many times a day do they happen? What if you're not going to be there? Who can you leave a list of questions to? How will you make sure that they've been answered? How do you know that you've been listened to? And how easy is it to have an open conversation about differences in opinion? So I think we all do those things, but I think I have a different perspective on it potentially now that I've gone through that.
Yeah. And I think one of the things I found interesting, you're talking about the handover, and maybe in the mornings you'd agree that there was a plan for the day and we're going to reduce the fees by the time you came back. Then the next morning that had been changed. And again, I suppose sometimes we need to think about we're very good at handing over the medical stuff, the jobs that need done, the tasks that need finished, but maybe not so much passing on sort of parental or family wishes or desires, as part of our kind of routine handover. So there's probably some learning around that.
I think part of it is, you don't understand the processes of another unit. You can only sort of understand your own. And my take on that was that it felt like each day an instruction was given to how much Avion's bottles should be for every feed for the next 24 hours. And therefore, when a bottle arrived, the nurse would want to give the full volume within that bottle. And that's, because they were made up to 90 mils, therefore that's what she should get. Despite an agreement coming halfway through the day that wasn't appropriate. It was too late, the bottles were made up for that day. And then trying to get that to change was really, really difficult. But I don't think, I've listened to lots of nursing handovers in the unit that I work in, and they talk about feeding volumes. And I think in the vast majority of cases, things are handed over really efficiently and really well. But there is an element of risk if you have the approach where bottles are made up and you get what's in front of you and there's no conversation about that. It's maybe an assumption was made.
Yeah. And listen, thank you again, Peter, for sharing that personal story. I would really appreciate it, and it's been useful learning, useful reflection for all of us, I think. So thank you.
Yes, thanks.
We're maybe going to move on then to something again slightly different from what we've done so far. And we're going to have a quiz. It's going to be led by Dr. Stephen Montgomery, who's one of our paediatric trainees in Northern Ireland. And it's entitled Who Wants to Win a McGrath? Just before we do, I want to thank Healthcare 21 again for donating the prize, a McGrath Mac video laryngoscope, for the winner. I'm not entirely sure of the format and how this is going to run, so I'm going to hand over to Stephen, who'll lead us in that. I hope everyone enjoys this and play along yourselves. Thanks, Stephen.
Hi, folks. Thanks for that, Ben. So I'm just going to double check the technical things. Everybody can see the slides okay?
Yep. There we
can hear me okay? Good.
Yep.
So hi, folks. I'm Stephen. I'm a paediatric registrar currently working in the paediatric intensive care in Belfast. So we're going to do a bit of a quiz here. And it's going to be sort of who wants to win a McGrath. So we've got some contestants on the line on the call at the minute. And the way this is going to start is we're going to do a fastest finger first. So there's going to be a question, and guys, feel free to play along at home and online. And there's going to be sort of 4 options for the question, and you're going to have to rank them in the correct order. Whoever gets that correct and quickest will be the contestant for the game. And then we're going to go through sort of 15 MCQs. In those questions, there's going to be 4 possible answers for everyone. And you've got to pick the right one. You're going to have 3 lifelines that you can use throughout the 15 questions. You can only use each one once. So there's going to be a 50-50. You can ask the panel. And there's also going to be an ask the audience for one of the lifelines. So if you're playing at home, keep your ears peeled. We're probably going to need you at some point to help our contestants out to hopefully win the big prize at the end of the day. So our contestants today, we've got Lindsay on the call. We have got Shane on the call. and Hardeep, and I believe Heather as well. And I just see, Tudor, do you want to come in there?
Should I just say that when the question goes up for the audience, I'll put the poll on so you can vote. And then if Stephen wants to use your votes, he can bring them up then.
Fabulous. Thank you, Tudor. So if everybody's ready, do all our contestants have a pen and paper for the fastest finger first? And what I'll get you to do is just hit the raise hand on the call here so I can see who's first, and we'll go from there. So with all that, we'll start into it. So I want you to rank the following from containing the most amount of sodium to the least amount of sodium. So starting with the highest, finishing with the lowest. And if you just write down A, B, C, D, don't worry about writing out the full long form of the answers. So there's your options. So rank from the following containing the most to the least amount of sodium. So option A is plasmolite, option B is 10% dextrose, option C is 0.9% sodium chloride, and option D is hypertonic 2.7% saline. So we've got one hand up there, and a second, and a third, and a fourth. Brilliant. So I'm going to start with yourself, Hardeep. Do you want to tell us what the order you got there?
I've got D, C, A, B.
D, C, A, B. And that is correct. So congratulations, Hardeep. Commiserations to the rest of you. Thank you very much for taking part. We'll just go through the answers quickly. So your hypertonic obviously has the most amount of saline. It's about 462 millimoles per liter. Then you've got your 0.9% sodium chloride, which is about 154 millimoles per liter. Plasmolite is 140 millimoles per liter. And then obviously at the least amount of sodium is your 10% dextrose, which has no sodium in it. So we'll get into the questions. So you can see here our prize numbers on the top of what you can hopefully win today. And we'll start with the first question. So question number 1 is, according to the APLS guidelines, what is the recommended fluid bolus? And this is for each individual fluid bolus given for a child with a prolonged cap refill, tachycardia, and per perfusion. So your options are A, 0 to 5 mils per kilo, B, 10 to 20 mils per kilo, C, 20 to 30 mils per kilo, or D, 30 to 60 mils per kilo. So whenever you're ready, Hardeep, if you want to give me what you think might be the correct answer there.
Is it B, 10 to 20 mils per kilo?
And you're looking to go with B, is that your final answer?
Final answer.
Fabulous. So that is correct. So well done, you've won the first prize, and now we'll go on to the next question. So yeah, this is a very straightforward, just as per APLS guidelines, they recommend 10 to 20 mils per kilo for your boluses initially. Obviously, you can repeat those fluid boluses if the situation requires.
Can I just check I can drop out any point from now on?
No, you have to keep going. So question 2 then. So we're moving on to a 3-year-old child presents to ED with a generalized tonic-clonic seizure of all 4 limbs. After how long would you give the first dose of rescue medication? So your options are A, 2 minutes, B, 20 minutes, C, 5 minutes, or D, 10 minutes.
Go with C, 5 minutes.
Final answer?
Final answer, please.
And congratulations. So again, that's really just as per the APLS protocol that recommends after 5 minutes to give 0.1 milligram per kilo of lorazepam. And moving along now to question 3. So we're up to £5 now. So you've got a 3-year-old child with meningococcal sepsis. They present with cold extremities, prolonged capillary refill time. Their blood pressure is 45/30. Heart rate is 190 and lactate of 8. After 60 mils per kilo of crystalloid solution has been given, the perfusion remains really poor. What would be your next immediate step? Would it be A, give another 20 mil per kilo fluid bolus? Would it be B, you would start some noradrenaline centrally? Would it be C, you would start some dopamine? Or is it D, you would go ahead and give a push dose of adrenaline peripherally And obviously we talked a little bit about push dose in the sepsis talk with Dr. Flannigan, with what that is.
Yes. Can I ask any follow-up questions, or this is all the information I have?
You go for a follow-up question. We'll allow that.
What's it? Intensive care, have we got a central line, or if not?
So no, at the minute you've just got 2 peripheral lines.
So we can't use the noradrenaline. I think push dose adrenaline is reserved for extremist situations. So I think it is between that and given 20 mils per kilo.
So you've got your lifelines if you would like to use them. So your options are 50-50. We can ask the audience, or we can ask the panel if you would like. Sorry, you broke up slightly there.
I'd like to ask the panel.
Okay, brilliant. So we'll bring in the panel at this point. If anybody wants to give any opinions, I'll let them jump in at this stage.
I would go for push dose adrenaline here. It's the blood pressure is your key bit, I think, here. Heart deep, your peri-arrest, and I think all the others would take a little bit too long to make up.
Yes.
So the rest of the panel agrees with that.
Absolutely.
Yeah, definitely agree.
Well, there you go.
So
the push dose adrenaline.
Going to go with push dose adrenaline. Brilliant. And that is the correct answer. And yeah, just as Dr. Flannigan was saying there, it's very reasonable to consider more fluid, but just given with how low the blood pressure is there, it looks like this child is probably going to arrest very soon if something isn't done quickly. So it's about trying to restore that blood pressure quickly, and that's why sort of push dose. With your noradrenaline infusion, you correctly identified you would have to get a central line in. That's going to take time. You're probably going to have to give some sort of analgesia when you're doing that as well. And obviously just dopamine isn't sort of routinely first step sort of medications. So we're moving on to question 4. So question 4 is a 5-year-old child with meningococcal sepsis develops rapidly progressive purpura, thrombocytopenia. They have a prolonged PT, a prolonged APTT, and they have low fibrinogen. So what is going to be your best management option? So you've got option A, do you want to give some IV vitamin K? B, do you want to give some unfractionated heparin? C, do you want to give a platelet transfusion? Or D, do you want to give some cryoprecipitate and FFP?
I'll go with the...
Sorry, you're breaking up slightly there. I didn't quite hear the answer.
Sorry, I'll go with D, which is cryo and FFP.
Fabulous. So D, and that is the correct answer. And yes, with the prolonged PT, APTT, and low fibrinogen, your IV vitamin K would maybe help with an isolated prolonged PT, but it's not going to do much for your fibrinogen or your APTT. Your unfractionated heparin is going to make things much worse. And your platelet transfusion, again, is not going to help a whole lot with that low fibrinogen. So your cryoprecipitate and your FFP is the best option there. So moving on to question 5, and this one is about shock. So it's which one of the following is the most common type of shock leading to cardiac arrest in the pediatric population? So you've got option A, cardiogenic shock, option B, hypovolemic shock, option C, obstructive shock, or option D, distributive shock.
Common type of shock leading to cardiac arrest without distributive shock.
Could you repeat that just once more for me? Sorry.
D, distributive shock.
Option D, is that your final answer?
Yes, it is my final answer.
You do have 2 lifelines left there if you would like to use a lifeline.
Okay, just thinking my options here. So I think we know that the cardiogenic shock can lead to cardiac arrest, whether it's the most common cause of cardiac arrest in children. And also very specific situation. So it's either between A and D. Well, I'll use 50-50 if you're insisting.
So we'll go for 50-50 here.
And
so options you've got left is B, hypovolemia, or C, obstructive.
Interesting. Okay, I would choose for hypovolemic shock in this case.
Hypovolemia. Okay, so we're going to go with hypovolemic shock. Congratulations, that's the correct answer.
Interesting. I would have thought it's more distributive, but I don't know.
Yeah, so hypovolemia, generally speaking, I suppose in your severe sepsises, you would get distributive shock.
Yes.
But there's a lot of other trauma and other things that can cause hypovolemia. Do any of the panel want to jump in on that or mention anything about it? No? Right, we'll move on. So question 6 is, which of the following in the context of traumatic brain injury will cause the most significant vasoconstrictive effect on the brain? So you've got option A, hypoxia, option B, hypercapnia, option C, hyperoxemia, or option D, hypocapnia.
Right, it's D, hypocapnia.
Final answer?
Yes, please.
And that is correct. Congratulations. And we're next on to question 7. So we're up to £50 now. So which of the following is not caused as a result of group A streptococcus? So you've got option A, glomerular nephritis, option B, scalded skin syndrome, option C, scarlet fever, and option D, rheumatic fever.
I'd go with B, scarlet skin syndrome. Final answer.
And that is correct. So scalded skin syndrome is, generally speaking, staphylococcal scalded skin syndrome. So it's more staphylococcus as opposed to your streptococcus. And then the other answers there, your glomerular nephritis, scarlet fever, and rheumatic fever are all complications of group A streptococcus infections. So moving on to question 8. We've got, which of the following is the most worrying sign in a 6-year-old child with presumed sepsis? So your options are A, hypotension, option B, irritability, option C, tachycardia going at 140 beats per minute, and option D, a fever of 39.8 degrees Celsius. Sorry, I didn't quite pick up on the microphone there, Hardeep.
Tension.
Hypotension, yeah. Final answer? And that is correct. So again, when it comes to cardiac arrest, we think of hypotension being as a sort of sign before somebody goes into cardiac arrest. Tachycardias, generally speaking, in sepsis are quite an early sign of illness, and children, generally speaking, have a lot of reserve that they can become tachycardic and actually keep their blood pressure for a significant amount of time before running into difficulties. And obviously the irritability and the fever, whilst they're signs of infection and possibly even meningitis, they wouldn't be the most worrying signs. So we're on to question 9, and this is about which of the following is not a feature of life-threatening asthma in a child. So your options are A, silent chest, B, peak flow, 60 to 80% of their predicted, C, cyanosis, or D, their SpO2 less than 92% on room air. And again, this is which is not a feature.
With B, peak expiratory flow in 60 and 80%. Final answer.
And that is correct. Well done. So yes, the life-threatening peak flow in asthma is less than 50% predicted. So 60 to 80% is a bit better than that, so it wouldn't quite meet the categorization for life-threatening asthma as per the BTS. And all the other signs there, your silent chest, your cyanosis, and your SATs less than 92 on air, all fall within that sort of life-threatening classification. So we're up to question 10, so you're doing really well. So this one is going to be sort of picking the most appropriate management of a radiological finding. So I'm going to give you a couple of a minute or so with the next slide, just to have a look at the x-ray and just see what you think it is, and then we'll chat about management options. So hopefully you can see that x-ray there on the screen. And let me know when you're happy and we'll move on to the question.
Yeah, we can.
Okay. And hopefully everybody at home's managed to get a good look at that. So what is the most appropriate management next step? Would you go for option A, observe them at home and repeat the chest x-ray in 24 hours if asymptomatic? Would you go for B, immediate endoscopic removal? Would you go for C, giving some honey and sending them home as it will pass spontaneously? Or would you go with D, giving activated charcoal to prevent absorption?
Would B, immediate endoscopic removal.
Brilliant. And that is correct. So in this case, we're looking at an x-ray here that shows you a classic sign of a button battery ingestion. If you look closely at the x-ray there, you can see the sort of double silhouette. You've got the circle and then an inner circle, which is very classical of your button batteries. This is going to be very caustic and it's going to be burning as the walls complete the circuit of the battery. And it needs to be removed as soon as possible, which is why B, immediate endoscopic removal, is the correct answer. There is mention of administering honey if you're a long way away from somewhere that can do this endoscopic removal. I suppose there's always the balance when you're doing something like that, is this kid's going to need sedated to remove this, and the risks between giving something and being fasted for anesthesia. So that needs to be weighed up if you're thinking about it that way. Then we will move on to the next question. So we're up to question 11. So this is a 3-day-old infant. They present with poor feeding, vomiting, and increasing lethargy. On examination, the baby's tachypnic, but has no hepatomegalia. Their capillary glucose is 4.8. Their plasma ammonia is 950. Their lactate is 1.5. And you've done a urinalysis, which is negative for ketones, and a blood gas, which shows there's no significant metabolic acidosis. So your option is, what is the most likely underlying diagnosis? So you've got A, do you think it's a urea cycle disorder? B, do you think it's a medium chain acetyl-CoA deficiency? Do you think it's C, maple syrup urine disease, or D, congenital adrenal hyperplasia?
So significantly raised ammonia with absence of metabolic acidosis and normal for glucose and lactate. I think that fits into A, urea cycle disorder.
Final answer? So we're going with urea cycle disorder, and that is correct. So the key thing that you identified in this question is your plasma ammonia is significantly elevated, and your glucose is relatively normal. So with your MCAD, I suppose you would probably see a less markedly elevated ammonia, and your capillary glucose would probably be lower, and you'd probably be hypoglycemic, which is why that's probably not the most likely thing.
Yeah.
With your maple syrup urine disease, you would expect there to be a degree of metabolic acidosis. And with your congenital adrenal hyperplasia, again, it doesn't really fit with the glucose being normal and the plasma ammonia being raised, which is why your urea cycle fits the best with that very raised ammonia, glucose being normal or it can be low normal, and the negative or a mild degree of ketones in the urine. So congratulations. Moving on to question 12. So this is about a 3-day-old child presents collapsed. So they have absent femoral pulses. You're concerned that they have a duct-dependent lesion and their duct is closing. What dose of Prostin would be most appropriately initially? And all these doses are in your nanograms per kilo per minute. So your options are A, would you start at 2? B, would you start at 2000? C, would you start at 200? Or D, would you start at 20?
So we need a higher dose because the duct is closing and the child is symptomatic. So we need a higher dose compared to just the maintenance dose. My recollection is somewhere like 50 to 100. So I just need to choose the best option which fits into that. It's either, should I go for D or C? I don't think I've heard initial starting dose of 2. So
Gonna go with D there for 20. And that is correct. So yes, because you picked up on the key thing there is you're worried the duct is closing. So you're right, you do want to start on a higher dose than sort of the 5 that is recommended by some guidelines. And probably, as you were saying, probably would go up on this dose quite quickly, which is why it was sort of initial dose, where would you start? And definitely you could go with a higher number. It's why I put the other number sort of at extremes, because if I had them very close together, I'm sure there's lots of people who disagree with me on what exactly is the best dose. But yes, you want to either reopen that duct or keep that duct open. So you want to start with a higher dose to try and maintain that. And then moving on to question 13. So this is a question about cerebral herniation. And this is going to be, what is the most common type of cerebral herniation? So you've got option A, descending transtentorial, B, tonsillar, C, subfalcine, or D, lateral transtentorial. And remember, you've still got one lifeline left if you would like to use it. And that is the ask the audience if you would like that as an option.
Yes, I think the key here is the most common. So I sure.
Sorry, you broke up slightly there.
Saying I haven't got an inkling of an answer, but I'm not very sure. So I'll go ahead and use the lifeline.
So we'll open that up to ask the audience.
Sorry, guys. The audience have been voting B, but we're having a bit of a technical issue here.
Okay.
B is the most common one, according to the audience.
Yes, and then that's what I was thinking as well. I just do we have numbers like how strongly they feel B?
No, just that most of the votes have been B.
Well, I'll go with the audience.
So we're going to go with option B, tonsillar, as our final answer. Okay. So sorry, that was incorrect.
I was thinking of transtentorial, probably, but you tell me.
So this was a bit of a trickier. Am I also having technological difficulties? So this was a bit of a trickier question. So the most common type is your subfalcine, and I'm hopefully, if my PowerPoint works here, going to bring up a diagram. So your subfalcine is the most common type, and that's when you get this mid-shift over across. Generally speaking, it doesn't cause the most debilitating type of injuries, but it is the most sort of common. Then you've got your descending, your tonsillar herniation that we're all very well aware of. We've got our descending transtentorial, which is this one going down this way. And then we've got our lateral, which is your uncle herniation. So that was a bit of a trickier one. So if you give me just 2 seconds here, I'm just going to stop sharing for 1 minute. Sorry, let me just get this working. Unfortunate with that one. I can see we've still got a few minutes left. So if it's okay with the rest of the panel, I might just quickly go through the last couple of questions. Do you think that would be a good use of time?
I think so, yeah.
Yeah, so I'll just share this back up again. And hopefully you can see my screen again. So question 14 is about which of the following is not a risk factor for developing cerebral edema during DKA treatment. So our options are option A, younger age, less than 5 years. Option B, high blood urea presentation. Option C, gradual rehydration over 48 hours. Or option D, a rapid fall in plasma osmolality. So I'll leave that going for a second here and let the people online have a vote. And if anybody on the call, Hardeep or anybody else wants to jump in with what they're thinking on this, be my guest.
I mean, it's the gradual rehydration is a good thing, so I think it would be a C.
So we're going with C. And that is...
Online agrees.
Oh, online agrees as well. Brilliant.
Mm-hmm.
And we'll move on here to the last question. So the last question is, you've got an 8-year-old who's 20 minutes post-cardiac arrest. You've got ROSC. During the resus, they had 40 mils per kilo of IV fluids, and they had 5 doses of adrenaline given at the cardiac arrest dose every other cycle. Your 20 minutes post-cardiac arrest, their heart rate's 135, their blood pressure is 100/70, and they've got cool peripheries. So it's, what would you do next? So the options we've got is option A, would you start some milrinone running at 0.3 micrograms per kilo per minute? Option B, would you start some adrenaline running at 0.1 micrograms per kilo per minute? Option C, would you start noradrenaline running at 0.1 milligrams per kilo per minute? Or option D, do they not require any vasoactives at present? So again, I'm going to leave that open for the guys online. We'll give you a minute or two here just to have a think. And we'll open it back up to the room here and see if anybody's got any strong opinions of what they think might be the correct answer.
So obviously you need much more information, but from the information is there, I think it would be appropriate to just wait and see if the cool peripheries recover. We've got decent numbers, but if you do more assessment and see there's significant myocardial dysfunction, or if that was the cause of right information given. So.
Yes, I got some of that. Sorry, Hardy, just your microphone's cutting in and out. So yeah, no, you're okay. Is there any response back from the room yet? What the feeling is there, Tudor? Sorry.
There was a mixed bag, B and D being the highest, some C's, but I think D probably came in at the top.
So for this one, we were going for B with start your adrenaline infusion. So I suppose the thought process behind it is this child has had 5 doses of arrest dose adrenaline, and has been getting, 0.1 mils per kilo of 1 in 10,000 adrenaline every other cycle, and has got 5 doses of this. So they've got a massive, massive amount of adrenaline in their system to achieve those numbers that you've got there. And I suppose the worry is once that resus adrenaline wears off, they're going to need adrenaline being given to them to maintain the numbers the way they are. So it's trying to get on top of that before they get themselves back into, or like arrest again, because that arrest dose of adrenaline has worn off effectively. Does anybody else in the panel want to jump in on that?
Yeah, so this is from my talk from last year on vasoactive drugs. And the key thing is that it's the dose of adrenaline that you're given in a cardiac arrest. So we're giving 1 dose every 4 minutes, and each dose is 10 mics per kilo. So for the last 20 minutes, this child has been on the equivalent of 2.5 mics per kilo per minute of adrenaline, and you've just got ROSC. So that's 25 times the dose that you would give for starting a septic shock. You've just got ROSC, so that adrenaline doesn't go anywhere. So at the moment, they're on an absolute whopping dose of adrenaline when you're doing that assessment. And the worry is over the next maybe 15, 20 minutes or so, that's going to trickle away to nothing. And for a patient after a long arrest, you would expect them to have some myocardial stunning. So letting that adrenaline trickle away to nothing wouldn't be the best approach for me, and I would put them on a little bit of adrenaline. The 0.1 is a 25th of what they've been on, and I would only take that away once they've got to the ICU, or you've got that resus adrenaline out and they're showing you that they don't need it.
So yes, folks, thanks very much, everybody. Thank you very much, Hardeep, for taking part in that, and we'll be in touch with you about your prize shortly after. If everybody just remembers to scan the QR code there, and remember to fill out the feedback to get your certificates. And I think that's everything, folks. Thank you very much.
I was just going to say a wee bit there, Stephen, if that's okay.
Go on ahead.
Yeah, so I just want to say a big thank you to Healthcare 21 for donating a McGrath. They're giving us a McGrath to give away, so we should give it away. So we'll give Hardeep the choice of whether he wants to keep the money or the McGrath. So you can have a think about that and let me know. What do you think?
Well, I would take the McGrath. I don't think I'm gonna buy McGrath any other way. So
yeah, I think it'll be, as a budding paediatric intensivist, I think this is going to be a great tool. Like I say, they upgraded this a few years ago, and the image quality and it's really good. We use it all the time in the unit, and I've done a review of the new McGrath video laryngoscope, so it is currently on the course page. The course page is currently down at the moment, but it will be going back up from tomorrow. Isn't that right, Tudor?
Yes.
Yeah, so you can go ahead and take a look at it. I'll leave the video review up there. So it's an absolutely brilliant device, as Hardeep will be finding out. So take a look at the review, and if you're not using one, I'm sure the reps will be happy to give you a trial of one. And a big thank you to Healthcare 21.
Yeah, agree. Thanks to Healthcare 21. Thanks, Stephen, for organising that, and Hardeep, hard lines, very, very close. Just 2 questions off getting the 15. That takes us to the afternoon coffee break. We are due to meet again at 3:30. There's 3 talks this afternoon. There's acute management of deteriorating child with large mediastinal mass, the deteriorating paediatric patient with complex needs, and questions from the District General. So still lots of good stuff to come. Hopefully you can join us back at 3:30, and we'll see you then. Thanks. Hello and welcome back to the final session of Paediatric Emergencies 2025. We hope you've enjoyed your day so far. We've really enjoyed some of the discussions, some of the presentations, and we've still got three great sessions to come. Just sort of by way of housekeeping before we move on, just to let you know that we are using a slightly different YouTube polling system for the remainder of the afternoon. Hopefully that'll be obvious as we progress through, but just keep an eye on that. And otherwise, we'll move on with the first talk of the afternoon. I'm happy to hand over to Costas, who's going to talk around the management of a deteriorating child with an anterior mediastinal mass. So Costas, thanks for preparing this, and over to you.
Hi, thanks for Thanks for having me. My name's Kanaris. I'm a paediatric critical care consultant in Cambridge and Manchester, and today we are going to talk about acute management of the deteriorating child with an anterior mediastinal mass. So the way this is going to work is going to be based on a case that we've written up. It will be interactive. Is based on a real case, but the name and age has been changed and consent has been obtained by the family. Okay, so let's begin. So this is Bennett. Bennett is a 4-year-old boy. He was brought in by ambulance into his local district general hospital with a wheeze and chest pain that lasted for the last 24 hours. He's had a 3-month history of shortness of breath and has been treated as asthma with a blue inhaler by his GP. He's also known to have had hay fever and cow's milk protein intolerance growing up. And in triage, whilst he sat on his mother's knee, his initial observations are the ones on your screen. So he sat on 95% in air, his respirate is 16, his heart rate is 180, his capillary refill time is 3 seconds, his blood pressure is 92/45, his afebrile at 37 degrees, and his GCS is described is 11, and he's described as sleepy by the triage nurse. Now, the nurse had a good look at him, and she felt that his face was swollen, and she could hear an audible wheeze without even needing a stethoscope. So she was quite worried that this might be anaphylaxis, and she moved Bennett into resus to be reviewed by a doctor. So as he's moved into resus, you've had a quick eyeball by the end of the bed without fully examining him, and then you tend to agree with the nurse, so you decide your first line of management. So what would you do as your first line of management if you agree with the nurse that this could be anaphylaxis given how the child looks? If the organising team at base can have a look at the polling and tell me what people are voting, that would be most useful.
So currently we're sitting on 84% prescribed adrenaline so the nurses can get it, and 15% salbutamol, neb, steroids, and adrenaline and Piriton. Lovely. Okie dokie. So it sounds like most of you are going for B, prescribe some IM adrenaline so that the nurses can get it ready, and that's absolutely the correct answer. So this is based on the recent, well, I say recent, it's 4 years old now, the most recent APLS anaphylaxis update that recommends that the mainstay of management for anaphylaxis should be IM adrenaline. So steroids are no longer routinely used or indicated, and the significance of using antihistamines has been also downgraded, ideally to be given following initial stabilization, especially in patients with persisting skin symptoms such as urticaria or angioedema. Now, so then you have to decide your next investigation or the next step in your management plan. So what would you like to do? Would you like to arrange an X-ray and then approach for a quick physical examination, or would you like to hold off your X-ray for now? So we've got currently 80% saying hold off X-ray for now and 25% saying X-ray and quick exam. Okay, very good. I've got a good bunch of people watching, so that is absolutely the right answer. So usually people say, let's do an X-ray, what's the harm in that? So if that was the case, then you'd get a quite a questioning call from your radiologist to say whether that's really needed in a child with a wheeze. Now, the role of X-rays in children with wheeze or asthma exacerbation is very controversial, and there have been a couple of studies over the last few years, one by Cohen and colleagues published in JAMA, and one by Ali et al. Published in the American Journal of Emergency Medicine. Tudor will put the two references in the chat
if people want to read about it, that say that essentially chest X-rays in otherwise well wheezy children or those with asthma exacerbation are very infrequently associated with any change of management and should therefore not be used routinely unless we're worried about pneumothoraces or another pathologies such as inhalation of a foreign body or aspiration. Okay, so at the moment, if we're treating this child for a wheeze, we should not do an X-ray. Now, as you lie Bennett down to examine him, his saturations drop down to 84% in air. And as he gets more agitated, you realize that the swelling and the facial congestion gets worse, especially when he lifts his arms up to cuddle his mummy. There's quite a lot of subcostal recession. There's bilateral dullness when he percuss, and he looks very warm and very flushed, especially in the peripheries. So you think to yourself, this is quite strange. It doesn't really fit the asthma criteria, and I've never seen an asthmatic like that, or an anaphylaxis like that for that matter. So then it dawns on you that the clinical sign that you've actually seen is an eponymous syndrome you've heard of. So which clinical sign is it?
So we're currently sitting on 93% Pembertons and 7% Ospitz.
Very good. Okay. So excellent. So he's exhibiting Pemberton sign, which is named after Hugh Pemberton, which is a Liverpudlian physician born in the late 1800s. So the Pemberton maneuver is a physical examination tool used to demonstrate the presence of latent pressure in the thoracic inlets. Essentially, this is achieved by having the patient raise both arms like this, usually about 180 degrees anterior flexion at the shoulder until the forearms touch your ears or the patient's ears or the sides of their face. A positive Pemberton sign is usually when we see the facial congestion and cyanosis get worse, as well as respiratory distress after about 1 minute. So this is what this boy is exhibiting. So essentially suggests a significant SVC obstruction. So this sort of pushes the counter into needing an X-ray because you decide something's not quite right, and you decide to ignore what your radiologist says about not needing an X-ray. You do one, and this is what comes up. Okay, have a quick look at the X-ray. And I think the title of the presentation is giving the next question away, but who would you like to call next, given this X-ray? There we go. Would you like to call cardiology for an echo and your PICU team first, or would you like to call hematology, oncology, and PICU first?
So this vote is currently a bit closer. We've got around 63% on call hematology and oncology and PICU, and 42% call cardiology and PICU.
Okay, so it is likely that you will need both, but in the context of someone who has facial swelling, upper limb swelling, periorbital edema, conjunctival suffusion, such as the image I showed you earlier, headache and dizziness, the most likely diagnosis is superior vena cava obstruction due to mediastinal mass. So the correct answer in this case would be called hem-oncology and PICU first. So B is the right answer. Now, in inexperienced hands, as per the nurse in our story, these features of SVC obstruction can be mislabeled as anaphylaxis. Now, I've seen experienced clinicians do this, so it doesn't need to be, any particular, healthcare worker, because when we're used to looking at horses, we miss the occasional zebra, and this is very much a zebra sort of diagnosis. So if we're used to seeing anaphylaxis and asthma and wheeze, we tend to have a degree of cognitive bias, and we will diagnose what we're comfortable with rather than think this is something else. But this child very much has signs of SVC obstruction, so we call hem-oncology. So when you think about this, you also recall with some dread that respiratory symptoms in children with large mediastinal masses usually only manifest when there's more than 50% narrowing or compression of the airway. Now, think about this again. So you need 50% or more compression until wheeze manifests in children with mediastinal masses. So that is significant. Okay, so Bennett is already showing clinical signs in keeping with airway obstruction, such as dyspnea, wheezing, and sort of orthopnea. So you get the hem-oncology on board straight away, as well as PICU. Now, I don't know if you've ever worked with pediatric hematologists, but they're a very, very helpful bunch, and they're very keen to teach you a bit of pathology and a bit of physiology. In this case, we call the hem-oncologists, and they shared some very useful nuggets that are easily transferable sets of knowledge that I'm now going to impart on you. So they said that 3/4 of mediastinal masses are anterior, as is a likely case with Bennett because of the symptoms he's exhibiting. And that's in keeping with his respiratory symptoms. Now, so they decided to also go one further and tell you what the most common causes of anterior mediastinal masses are. So if they're anterior, they tend to be hematological, such as leukemias, your Hodgkin's, your not Hodgkin's, but you also have some rarer types, such as thymic tumors, germ cell tumors, and thyroid tumors. Then the rest of the 25% is made from mid-thoracic sort of tumor, midline tumors. So they tend to be your parathyroid adenomas, your tracheal tumors, your pericardial cysts, and even rarer than that in children, your esophageal tumors. And finally, at the back, it will come as no surprise to you that where the spine arises, you tend to get neurogenic tumors and neuroendocrine tumors. But generally, if we're playing the odds game in an undifferentiated large mediastinal mass, which we see as the first port of call and diagnosis, they tend to be anterior, and generally speaking, most of them will be hematological. Okay, so PICU, on the other hand, are less patient than your typical pediatric oncologist, and all they want to know is the observations and the gas. So you do a quick cap gas, and that comes up. And with dread, you think to yourself, Bennett did not look this bad to me. How come his gas is so terrible? So you gingerly read the gas out to the PICU team and think to yourself, should we intubate? And you think from your time or you spend on PICU that the commonest indications of intubating children with respiratory pathology is a drop on GCS of less than 8, a persistent hypoxia of less than 88%, recurrent apneas, persistent hypercapnia, which Bennett has, or cardiovascular instability, or any of the above. And you realize that this kid's CO2 is high and it's uncompensated. So you ask the PICU team, should we be intubating Bennett? What would you like to do?
So I had run that poll while you were talking there, and I got 55% absolutely yes and 45% absolutely no.
Okay. So if you take a single thing out of my presentation today, is that we should absolutely not be intubating these children unless they absolutely earn it, and Bennett has not earned it yet. Then I will go into the whys shortly. So intubation should be postponed unless absolutely necessary. So because this is a situation whereby we must think outside the box. We already know there's a degree of airway compression, and most of the situations the compression is distal, so further away to where the tip of the ET tube ends. So your ET tube will be lying there, and your tumor will be starting further down. Okay, so even if you intubate the child, you will not be taking that compressive effect, which is causing most of the symptoms, away. Okay, so we need to consider other approaches in this situation, such as non-invasive ventilation, such as shrinking the tumor, and generally a hemoncologist would advise giving some steroids with chemo and radiotherapy. And if we opt for the latter, we need to cater for the possibility of a tumor lysis syndrome. So to cater for that, you will be advised to give hyperhydration, so 2.5 to 3 liters per meter square of fluid, usually a balanced solution ideally and not saline, and also allopurinol or rasburicase, almost never both together. Okay, so whilst we're on the subject of tumor lysis, and any child with a large mediastinal mass, especially of hematological origin, is a very high risk of tumor lysis when you start treating the tumor. What are the 4 main electrolyte abnormalities that can be life-threatening in children with tumor lysis syndrome? So, because if you're going to be giving steroids to this child in ED to try and shrink the tumor, you need to be aware of what badness can happen as a result. So what, if you just put in the text and Tudor can read out to me, that would be useful. So what, we're looking for 4 different electrolyte abnormalities that can be caused as part of tumor lysis.
I'm getting hyperkalemia.
Excellent. So that's the most life-threatening.
Hyperphosphatemia.
Very good. Hyperkalemia, hyperphosphatemia. Yeah, 2 more.
Hypocalcemia.
Great. Hypocalcemia. So I've seen a hyper, that's wrong.
And hyper as well now as well.
Yeah, we only get hypo, so low calcium, not hyper.
And hyperphosphatemia.
We've said that. There's one more.
Hypoglycemia is...
No, sugars are not affected. They will be affected with the steroids, and they'll be hyperglycemia, but that's not...
Hyperuremia is coming in as well.
Yes, very good. So hyperuricemia. So you get 4 things, 2 of which can be acutely life-threatening. One is hyperkalemia is the most dangerous. Hypocalcemia is the second most dangerous. And then you can get hyperphosphatemia and hyperuricemia. And the way to mitigate for the risk of that is to give a lot of fluid. So 2.5 to 3 liters per meter square to mitigate that. Okay. So try not to intubate, shrink the tumor if you can, put them on non-invasive ventilation if you can. Okay. Right, on to the next. So you agree with the advice given by the oncologist and PICU, and you decide to call anesthesia to help you to transfer them into CT and intubate. And doing an upright CT or semi-upright CT can be a lifesaver because it will allow you to ascertain the anatomy of the tumor. Is it wrapping around any major structures? Is there any direct cardiac involvement? How much is the compression of the airway? And it would also help you differentiate whether these patients are eligible for ECMO should they become that unwell, because a lot of the times these patients are not ECMO eligible because of the way in which the tumor is compressing major vessels. So you decide to be helpful and try and cannulate this patient in preparation for a trip to CT. So where do we try and cannulate, or does it not matter? If my slide starts to work. There we go. Do we go for the arms or do we go for the legs?
You've got about 40 plus votes now, 82% in the legs and 18% in the arms.
Okay, very good, excellent. That's great answering. So you remember that there's clear clinical evidence of SVC obstruction, and SVC obstruction, that means your venous flow will be slowed down and will be impeded and compressed. So the consistency of drug delivery is going to be inconsistent and poor. So you decide that on balance, cannulated, the lower extremities is superior and better. And that is also evidence-based. So always go for lower limbs if you are considering SVC obstruction as a diagnosis. Otherwise, your drug delivery will be hit and miss. Okay, so whilst you're cannulating, your anaesthetist arrives and to prepare the drugs and the airway trolley to take to CT. And you recall your time during anesthetic training many moons ago, and you try to be helpful. So you recommend some choices of drugs to help him draw up or her draw up. And these are your drug choices. Hedge your bets.
Okay, we're hitting 40 votes here now as well. 49% ketamine, fentanyl, and no paralytic. 43% ketamine, fentanyl, and rocuronium at 1 milligram per kilogram, and then 9% of ketamine at 1 milligram per kilogram, fentanyl at 1 microgram per kilogram, and sucks.
Okay, so pretty even split between ket, fenton, rock, and ket, fenton, no paralysis. Well done to those who said no paralysis and absolutely no succinylcholine. That is massive, massive contraindication on 2 counts. So whilst you impress your anesthetic colleague with your intricate knowledge of intubating drugs, he explains that paralysis is contraindicated with mediastinal masses, especially not sucks. The reasons are, A, if we decrease the chest wall tone, then by paralyzing this patient, we then increase our severe airways compression even more. Furthermore, succinylcholine causes a hyperkalemic surge. So in a child with a high risk of tumor lysis syndrome, which we've just gone through, it can cause hyperkalemia. We are very likely to push the child into a hyperkalemic VF arrest if we gave succinylcholine. So to not give any paralysis, and if you are forced to give paralysis, absolutely go for rock and not succinylcholine. Okay, so in this situation, we would need to plan for failure. So we would need to draw up a rhesus dose of adrenaline diluted tenfold, get 2 lots of 10 mL per kilo fluid boluses to take into CT with us, take an array of intubating plates, including video laryngoscope if we can. And very importantly, if you remember to get a Krupp tube or an Armour tube, if you still stock them in your hospital, they can be life-saving because these are longer, these are reinforced, so they're not compressible. So if this tumor carries on collapsing and the airway even more, this can be used as a stent to ventilate this child if they need a tube, if things go wrong in scan. Okay. So those are the tips that they gave you. Okay, so you get everything prepped and you start wheeling Bennett into CT for an upright CT if possible. And during the trip to scan, you hear the SATS monitor going slower and duller. So his SATS dropped to 80, then 60, then 40. And then his heart rate drops to 100, then 80, then 54, and his blood pressure is awful, as you can see on your screen. Okay, so you start your CPR, and the anesthetic registrar intubates straight away using ketamine and fentanyl that you'd already drawn up. And you see your end-tidal CO2 come on, and then goes off again, and comes on, and goes off again. And bagging this child is very stiff and very difficult. But you do have cardiac output back, and your heart rate is static at about 90, 80 to 90, and your SATs are fixed at around 50% after you get ROSC back. This is whilst bagging on 100% oxygen. What do you want to do next? Do you want to start adrenaline? Do you want to do an X-ray? Or do you want to prone the patient?
Okay, so we have got 69% prone the patient, 13% do a chest X-ray, and 18% start adrenaline infusion.
Very good. So excellent. That is the right answer. So you remember that you, as a child, you used to have a blue Peter badge. So you decided to do some educated improvisation, and you remember that based on the teachings you had in the Paediatric Emergency online course, that most mediastinal masses tend to be anterior. So there's a big mass in the thorax, and this deterioration is likely to have been caused by hypoxia on a child that's already wheezy, suggesting that the airway is compressed. So whilst we are likely to need an adrenaline infusion and an X-ray sooner rather than later, the thing that will help this mass decompress the airway is flipping the patient and letting gravity do the job. Okay, so you give 1 ml of your dilute adrenaline that you drew up to give this child a bit more cardiovascular reserve, and then you prone the patient in hope that gravity will do its job and take the pressure away from the airway to help you oxygenate better. And much to your surprise, no one seems to have any objections to your thinking out the box, and you do this, and within a minute you're able to ventilate the child a lot easier. His SATs stay at above 90%, and his heart rate goes back to over 100 consistently on a bit of adrenaline. And then PICU thankfully arrive within 5 minutes to take this patient off your hands. Okay, so this is based on a real case with lots of learning points and little nuggets that will make managing them a lot more, I wouldn't say easy, but less challenging for sure. So tricks of the trade. So most of these children would ideally, if they're stable enough, get a semi-upright CT in advance. Like we said, we need to make sure there's no sort of invasive tumor into the heart or any of the major vessels. We need to see how much the airway is compressed. This will help prognostication, ascertain ECMO eligibility, and ascertain how urgently this child needs to be started on chemo. Recommended anesthetic techniques for these children include inhalation induction with maintenance of spontaneous respiration. This is generally only available in the older children, which are more compliant, so your teenagers. And using of sort of non-invasive ventilation may help to maintain functional residual capacity that's otherwise reduced under anesthesia. If you are forced to intubate them, try and do so in a sitting position. Okay, so A, the compression of the tumor will be a lot less on the airway, and B, if you think of the effect that of the abdominal context will have on compressing on sort of a thoracic volume, once you lie them flat, it will make things a lot worse. So your diaphragm will be pushed up, so your functional residual capacity will be even less, making things a lot more difficult, not least making gravity push the airway further down based on the anatomy of the tumor. So if you can do them in a sitting or semi-upright position, if they need a tube, then do it that way. If you need to get access, make sure you go on the legs. And if you have the capacity for ECMO, if you work in a big tertiary center, then it might be useful. What I would say is that ECMO is not a panacea because if you have significant vessel obstruction, the flows you get through the big vessels are not enough to sustain life on ECMO a lot of the time, which is why you need a CT in advance. Don't forget to ask for a Krupp tube. Your ODPs, so your theatre assistants, will know whether you stock Krupp tubes. These are armored and very useful for stenting the airway that is very compressible, and try and avoid paralyzing these patients because it makes life a lot more difficult. And absolutely do not use sucks. And don't forget, if you are forced to intubate them, to prone them if it's difficult to ventilate them. What I would say, this is managing children this sick with such complex pathology when they come in through the A&E doors with an undifferentiated mediastinal mass is a proper team sport. You need a very switched on emergency department team, pediatrics, hem-oncology, anesthesia, PICU retrieval, ECMO, and ear, nose, and throat specialists. So that's at least 8 I can think of. And it's key that we are all civil to each other and respect each other's expertise whilst being kind and polite to each other. And most importantly, what I always say is make sure you make time for the family. Have an experienced member of staff touch base with them every 10 minutes or so to keep them in the loop, to tell them what's going on, because this might be a bad day at the office for you, but I can guarantee you that it's the worst day of their lives. I welcome any questions you might have. Thank you.
Thanks, Costas. Really good, engaging talk. So some really useful tricks of the trade, and we haven't actually had that many questions coming through in the chat. I think that's because everyone's been so engaged and actually contributing to the polls the whole way through. So I suppose one comment from our point of view, our pediatric oncologists love to simulate this scenario. They do it on a regular basis. And one of their big learning points is around the risk of tumor lysis syndrome, because a lot of these patients either receive steroids because they're presenting acutely with respiratory distress, or else steroids because we've identified a mediastinal mass. But you do need to think about tumor lysis and take steps to so try and protect against that with hyperhydration, etc. And I suppose if you don't think about it, then you can run into difficulties later down the line. I still don't think there's any other questions in chat, so we'll maybe move on to our next talk. But thanks again, Costas. Next talk is the deteriorating pediatric patient with complex needs. Dr. Damien Gates, the pediatric intensivist in the Royal Belfast Hospital for Sick Children, and he's going to share with us on that topic. So, Damien, I'm happy to hand over to you. Thank you.
Hi, thanks, Ben. Can you hear me okay?
Can hear you, yeah.
And I'm sharing the screen. Hopefully you can see that.
Yeah, we can see that. You've flipped sideways, but we can hear you and we can see the screen. So
I flipped sideways. I don't know why that is. Hang on, I'll maybe adjust the camera.
That's all right. Your slides are the right way up and we can hear you. So
is that better?
You're upside down now.
Upside down, other way. That better?
Perfect. That's you.
Okay, right. So thanks very much, Ben. Thanks for Paediatric Emergencies organisers for asking me to speak about this. I'm hoping I haven't bitten off more than I can chew by trying to cover this subject, but we'll soon find out. So I'm going to talk about the deteriorating child with complex needs. The reason why I've selected this subject to talk about, I don't believe it's been covered in Paediatric Emergencies previously, but it is a very frequent referral to paediatric intensive care. And the children that I'm going to talk about are sort of an overrepresented population within acute pediatrics and in high dependency and critical care settings as a proportion of the total population of children. We'll go through a number of things, but we're going to focus really on respiratory deterioration, as again, it's probably the most common thing that we're contacted about in PICU regarding this kind of patient population. So the medically complex pediatric patient, or the various terminology that's used about these patients, some often where we work, these patients are summarized as complex neurodisability. And really what we're trying to describe is children that have very complex medical needs and require sort of significant assistance with multiple aspects of their daily living. So, and usually due to a chronic, often progressive underlying condition. And the underlying condition itself might be of genetic etiology, maybe metabolic, maybe chromosomal, maybe neuromuscular, or maybe due to an acquired brain injury, i.e. cerebral palsy, a traumatic brain injury, or issues related to prematurity or previous infection. And in some cases, we have a child who has some very complex medical conditions, but doesn't actually have a diagnosis because our genetic tests perhaps haven't been able to pinpoint the precise abnormality that underlies what's going on with them. As such, as part of sort of daily life for these patients, they may have significant limitations to mobility, to feeding, to communication. They may have complex epilepsy, may have complex tone abnormalities such as reduced or increased tone. They may have kyphoscoliosis and other skeletal problems. They may have various degrees of intellectual impairment. They may have an impaired swallow and feeding difficulties with associated severe nutritional challenges. Talk about technology-dependent children now. So some of these children may require non-invasive ventilation. They may require tracheostomy and ventilation. They may require feeding devices beyond your nasogastric tube. Multiple systems might be involved in their underlying condition. So you may have cardiac and renal abnormalities, as well as sort of the neurological and functional limitations that these children present with. And as such, they may also have things like VP shunts and VNS stimulators in situ. And the patients often require multi-specialist care and have a long list of medications for symptom management and for therapeutic management of their conditions. So often a very, very difficult patient to get to grips with it. I'm sure when I'm talking about this, everyone will know patient or patients like this that they've encountered in everyday work. And indeed, they may encounter frequently the same patients in everyday life or everyday work when covering acute pediatrics, either in the emergency department or in the pediatric setting. In terms of talked about, I said I'm going to focus on respiratory deterioration in these children. Now, obviously, these children can have issues that any other kids will get, i.e. septic shock. They can be involved in car accidents. They can get kidney infections. Other things that may be more specific to these children might be things like refractory epilepsy and dystonic crises, usually managed with specialist input as well as sort of APLS algorithms. So I'm going to focus more on the condition that really probably limits these children's lives in most circumstances and presents in the most common presentation to our setting, and that would be sort of respiratory failure. These children tend to be vulnerable to chronic progressive respiratory failure for a number of reasons. You've got the aspiration risk, which can be chronic, so there could be chronic small aspirations and then acute larger aspirations that result in sort of a more acute deterioration. They may have increased oropharyngeal secretions alongside an impaired cough and impaired airway clearance, which again may be exacerbated by poor posture, by kyphoscoliosis, and then the kyphoscoliosis in itself can result in restriction to the ability of the lungs to inflate and reduced lung volumes. Additionally, they may be colonized with sort of atypical organisms and hospital-acquired organisms and things like Pseudomonas and resistant organisms that they've picked up through various kind of admissions to the hospital. And again, going along with this, there may be chronic atelectasis and consolidation, resulting in a kind of a reduced respiratory reserve. And this can, again, be part of all of these factors I've talked about, the kyphoscoliosis, the poor tone. And then in addition to this, again, must acknowledge there's potential for nutritional deficiency, which increases the risk of infection and reduces the ability to recover from infection. And then there may be respiratory muscle weakness, alongside the low tones. It means there's a limited capacity to cope when there's an acute reduction in that reduced baseline respiratory reserve. So if you get a sick patient or a sick patient with complex needs, thinking about how to assess them, because we talked about how complicated this is, how many distracting features there is, how many things you have to consider. So how would you approach assessing and investigating these children when they come to your attention? So use your standard ABCD assessment. You can't go wrong with it, and it applies to all children. And use your objective and subjective kind of measures of how sick you think the child looks. I would make special attention to note stridor and stutter in these children. So stridor may hint that potentially if these children have been, say, had a long course in the neonatal unit as infants or had many presentations to PICU requiring recurrent invasive ventilation, there may be subglottic stenosis in the background that hasn't necessarily been diagnosed yet. Stutter may indicate low airway tone and floppy oropharyngeal kind of tissues that might be making things worse. For me, I would consider pallor and reduced consciousness an indication that this child probably has a decompensated respiratory acidemia. Not necessarily, but that would make me suspicious of that. And one thing to bear in mind with the reduced consciousness is to review recent medication changes and explore the history for any recent seizures or changes in seizure patterns. what you may be kind of seeing as a respiratory deterioration may actually be secondary to the reduction in consciousness level, as opposed to the consciousness level being reduced in response to a respiratory deterioration. So again, kind of summarizing the signs of ongoing deterioration would be an increasing heart rate, increase in respiratory rate, reduced GCS, and an increased requirement for respiratory support. So depending on what your child's on, if they may need more oxygen, they may need more pressure on their, say, on their emergency settings, on their home ventilator. Just one caveat, just to bear in mind, is with the child with sort of neuromuscular conditions, such as muscular dystrophy, they may not mount an increased work of breathing response, and a more ominous sign actually may be that their breathing becomes more shallow, starts to slow down as they can't kind of keep up, they become tired more quickly. In terms of investigations, get a chest x-ray, get secretions for virology and ONS, and check a blood gas. And I think it's very important here to acknowledge the role of the parents and the carers with these patients. So as we know, all parents know their children best, but the parents of these children usually have been through a lot of previous encounters with healthcare, both in outpatients, in inpatients, maybe in the intensive care setting, whether it's neonatal intensive care, whether it's pediatric intensive care, and they generally have more medical knowledge than the general population, and will actually usually have a lot of clinical insight into their child's specific challenges and their child's specific needs. They may know that their child is colonized with Pseudomonas. They may know that their child responds well to PEEP. They may know that their child doesn't tolerate, a high CO2, and they may know what their child's normal gas looks like. So it's worth speaking to them and finding out what their specific concerns are, what things they look out for when their child's sick, and what things work to make them better. I think it's very important to look at previous investigations and previous admissions. So look at the chest X-ray just to see, is this the changes that you're seeing, are they chronic or are they new? Look to see, is there a progressive loss of lung volume that indicates this is either a progressive change or is there something more acute, like a new consolidation or a pneumonia? And look at the previous sensitivities for any organisms that this child may have grown. So rather than starting your bog standard kind of community acquired pneumonia antibiotics that you do in your unit, I would probably go with starting an antibiotic that would give coverage for those common organisms, but also cover the organisms that this child has previously grown. And I would do that in conjunction probably with speaking to the respiratory team and the infectious diseases team, just to guide management. So how to manage an acute respiratory deterioration, or how I would approach this. So I think communication is absolutely key to this. And that's communication with the specialists that are involved in this patient's care and know them well, and also the parents and the carers of the child, as stated. You should, and we'll go, leaving aside the kind of the respiratory function, if you do have refractory seizures of dystonia, that's very much a specialist issue and to seek specialist advice for it. But focusing on the respiratory deterioration for now, one thing to acknowledge is that these children are often receiving sort of what amounts to de facto kind of high dependency care at home from their parents and their carers. They may have long-term respiratory support. Their parents may be doing very frequent physio at home, very frequent repositioning. And so it's worthwhile checking with these parents, what things they've been doing and what things you need to continue doing that they feel work for their child. Some of the things that they're doing, actually some of our pediatric wards kind of are almost, hesitant to replicate because it meets sort of high dependency standards for care, but that might be what you have to do to kind of keep these children on an even keel. As I said, it's important to review the previous culture results to guide your antibiotic therapy to make sure that you're getting appropriate cover. But I think the major focus with these children when they're having acute respiratory problems is to really assist with airway clearance. So I think this has to be proactive management. I think if you get a child in who has very complex needs, the sort of child we're talking about, the sort of child that we all know, if we kind of do the first things, i.e. give oxygen, give fluids, give antibiotics, and then we just let them lie in bed and kind of work away, I think we're setting them up to fail. So I would advocate that we make sure that they have good posture in the bed, and that means frequently changing their posture if they start to slide down and they start to lie down on their back. I would advocate getting their own equipment in from home if possible. So the seats and chairs and things that they use at home are fitted for them and ideal kind of to improve their posture. And I often would say to parents, bring these things in so we can set the child up and make sure that we're maximizing the lung volumes. I think chest physio is important. Now, sometimes people are hesitant if a child looks like they're tiring and they're worried about chest physio making things worse. I think you really have to kind of balance that up with letting them kind of struggle on and potentially de-recruiting, plugging off a major airway and becoming very sick very quickly. So I would see chest physio and good kind of coordination between the medical team and the physio team as vital in managing these patients. I feel I'm very lucky where I work. We have an excellent physio team, and I think that relationship we have in managing these patients is really, really important. So the other things sort of in terms of airway clearance would be, you think about mucolytics, things like hypertonic saline, things like DNAs, even just normal saline nebulized to try and loosen up thicker secretions. I would look at kind of any anticholinergic drugs that the patient might be on, such as hyoscine patches or glycopyrrodium. Often these are started to reduce oropharyngeal secretions, but in some cases, if the child has an acute infection, these can make lower airway secretions harder to shift, harder to cough out, harder to get out for the patient. So balance up the use of those medications for upper airway secretions versus the clearance of lower airway secretions. And I think it's important to kind of discuss that with the physios. I would consider early anaesthetic review for these patients if you're worried about them. The reason being so that the anaesthetic team can plan accordingly for a potentially difficult airway and be able to see the patient, have time to review previous intubation episodes and look at previous issues there might have been when respiratory support was escalated previously. I would tend to advocate in the early period until they're kind of stabilizing out, holding feeds, but I would continue to give critical enteral medications such as anti-epileptic drugs, antidystonic medications where you don't have another route to give these or you don't want to change things too much. Other things I would consider, if there's strong evidence of reduced upper airway tone, I think using a nasopharyngeal airway might help things. It gives an avenue to suction, and also if the patient's drowsier than normal, it might overcome some kind of reduced airway tone. And I would also I would suggest that you should address any other issues with the patient that might impact their respiratory status. So treat any pain that they might have and treat constipation. Constipation is a major thing with these patients when they become less mobile, when they're more kind of in bed and when they're just generally unwell, their gut might slow down. So that can really impact on things. They might make them vomit more, make them more uncomfortable. So address that. And also I think treating fever can be important because when children have fever, they often look a lot worse. They can often feel a lot worse. It can knock them off a bit. So I would suggest that treating fever in these children is an important thing to do too, and weigh that up. Often you'll have a patient who the call that we'll get will be, you have a patient who comes in, is a bit unwell, stabilizes out, they're being managed on the ward, and then they have a very sudden, very acute deterioration. Usually I would say that's a mechanical issue, generally mucus plugging of a main bronchus that's happened just if they haven't been clearing their airways very well, and it's just taken out a big part of their already reduced lung reserve very quickly. And my advice again would be the same: is try your airway clearance measures, try your chest physio, update the X-ray, be prepared to escalate the respiratory support substantially. And often this can be kind of turned around, quite even if it looks quite hopeless. Your head looks like you're heading for intubation. You can turn this around with good physio, using nebulized mucolytics, repositioning, and sometimes even bagging for a short period with high PEEP through an anesthetic circuit. So just refer to quickly to a couple of cases that we've managed recently, just to highlight the X-rays and the things that you can turn some of these situations around. This is a patient who presented recently who has a chromosomal abnormality that results in global developmental delay, poor tone, aspiration, impaired swallow aspiration risk. They're peg fed. They came to our attention. They had basically a history of a recent viral upper respiratory tract infection. that progressed to increased work of breathing. They were on home non-invasive ventilator, and they were requiring more oxygen through that, and unfortunately had no emergency settings set up on the ventilator, so they came into hospital kind of looking in a bad way. So SATs in the 70s, working very hard, lots of sounds in the chest, and looking very much like they were heading for intubation. You can see, looking at that spine, looking at those low lung volumes, it's not an inspiring chest x-ray to look at, and the associated risks with intubation were substantial. So we admitted this child, we got good chest physio, increased their NIV settings, giving them a fairly high PEEP of 10 and putting their pressure support up to 8, so they're getting peak pressure of 18. Got them into their own chair at home that they use for sitting out, and a day later would really maximize the lung volumes, and this child stabilized out in this management and was able to go back to the ward and wean their respiratory support slowly. Again, this is another child who presented more acutely with, this is a child with a muscular dystrophy condition, again, severe scoliosis, reduced lung volumes, presented with a very abrupt aspiration. Completely, you can see they completely lost the volume in that right side, a whiteout of the right lung. Very, very precarious child, requiring lots and lots of oxygen when they came in, very close to being intubated. The parents were very knowledgeable and knew that the risks of intubation for their child, knew the risks of prolonged mechanical ventilation, so wanted us to try and turn this child around without doing any of those things. I agreed, I wanted to try the same thing. So we tried physio, we escalated NIV settings again, used a high PEEP, used a higher pressure support, did some bagging, and at one point I thought things weren't going to turn around, and I went to the parents and I said, look, I think we're going to have to intubate. The blood gas showed a decompensated sort of hypercapnic respiratory failure in addition to the hypoxemia. And the parents said, would you just give it one more go with physio and see how we go, because they really wanted to try and stay off a ventilator. We did that. One of our excellent physios in PICU really worked with the child. We got a lot of stuff up, and you can see the repeat x-ray sort of a few hours later. The child turned around completely, woke up, started shouting at us, wanted to take the NIV mask off, and really a startling for me, it was really startling demonstration of what you can do just by maybe giving the child a chance, not jumping in too soon with mechanical ventilation and doing the airway clearance. And the thing is, even if you have to proceed to intubation, all those measures will make things easier for you after you've intubated the child. Things to consider if you have to intubate these children. Sometimes these decisions are easy. So if they've stopped breathing, if they're in terrible shape and needing lots of oxygen and really things are very precarious, you just have to go ahead and intubate. But if it's less clear, if they're struggling, but they might be coping periodically, your threshold to intervene may be higher than sort of other children. You should, I would advocate discussing with your regional PICU and respiratory service fairly sharpish if you think this child might be heading for intubation. And I think it's important to counsel the parents on the risks. And you might be able to contextualize these risks for the parents by speaking to those specialist teams. So mechanical ventilation is injurious to the lungs, and particularly if you have to use high pressures required. I would counsel parents on this all the time if I think one of these patients is heading for intubation. And I would say with these patients in this setting with an acute deterioration, they'll have both obstructive and restrictive lung disease due to the kyphoscoliosis and sort of the mucus plugging. So you potentially will require very high mechanical invasive ventilation pressures to try and open these lungs up. In addition to that, it's very uncomfortable to be invasively ventilated, so we'll have to sedate them. We may have to muscle relax them, and that can lead to deconditioning these children and a loss of muscle strength, and then it becomes very difficult to liberalize from the ventilator, and that is a consideration, and that's why maybe you have a higher threshold. You maybe tolerate higher oxygen requirement, higher non-invasive pressures than you normally would, and sit on a blood gas, accept slightly lower SATs, just because you want to give them time to see if you can recover. If you know you're heading for intubation and you think it's a strong possibility, plan for a challenging airway. So look at if there's any dysmorphia. Consider the anatomical distortion due to any kyphoscoliosis that might mean that the trachea is in an unusual position. And think about the reduced FRC, the reduced functional residual capacity for these patients. It'll be chronic, but there'll also be an acute element to the chest infection. So they won't give you a lot of time, and you are starting from a difficult circumstance, usually with a high oxygen requirement at baseline. And then also consider any congenital cardiac disease if it's present and what that does to your kind of hemodynamics. Anticipate that when you intubate and ventilate, you're going to have a lot of difficulty oxygenating and ventilating in the early stages. As I say, you'll have restrictive and obstructive lung disease. There'll be very, very challenging pathophysiology to deal with. Be prepared for more chest physio, for more repositioning, for lots of suctioning. Make sure your endotracheal tube is in the right place as soon as possible. So get the chest x-ray done. Be prepared to ventilate with high PEEP. So, and that sometimes be as high as your patient will tolerate hemodynamically. So you could be talking about a PEEP of 10 centimeters of water, 12 centimeters of water, 14 centimeters of water if you're having to open up a very plugged off small lung. Tolerate, a permissive hypoxemia. So tolerate SATs over 88% and tolerate permissive hypercapnia. Being satisfied with a pH over 7.2. So in some way trying to spare those kind of high invasive mechanical ventilator pressures to avoid damaging the lungs unnecessarily, and also avoid trying to minimize or reduce the risk of evolving ARDS, which is a real problem in this patient population also. This subject could be, obviously, I'm going to deal with this very quickly, like I've dealt with this whole subject very quickly, this whole massive subject. This one could be the subject of a whole day's worth of talks on its own, and it's a massive, massive challenge in pediatric intensive care and acute pediatrics. We'll talk just a little bit about decisions and ethics and escalation of care. I think it's important to try and have these discussions outside in an emergency if possible. It's very difficult to have a discussion about the risks and benefits of intubation in a patient who's about to have a respiratory arrest or who's really, really unstable. And in which case, if you're in an emergency and there's an absence of an agreed ACP with the parents, you just go ahead and save their life. And even if there is an agreed ACP, if the parents tell you they just want you just to keep their child alive, that's what you just go ahead and do. And you do that thing in that circumstance. It is still important in those circumstances to counsel on the risks of intubation as we've talked about. What I would counsel with parents, and I think it's important to be sensitive, but it's also important to be honest. I would be honest with parents, and I would say that my concern with intubation here would be that we're starting with very low lung reserves. This process may, in all seriousness, may kill your child. We may not be able to intubate them very quickly. We may struggle to ventilate them. When we lose their negative pressure respiratory drive, we may not be able to replicate their ability to breathe with positive pressure, either via mask or via tube. And things may get worse when we do this. I would talk about the difficulties of being sedated, being muscle relaxed, trying to liberate from the ventilator. And that's not to put the parents off or scare them or anything like that, but it's to be honest with the risks. It's to be honest with what we're trying to achieve. And it's to have an honest conversation if we all make sure we all agree that this is the right thing to do. In circumstances, sort of in PICU, or where there's a child who's sort of recurrently presenting the PICU and having lots of episodes where we think that the situation's become futile, you need a team agreement on that, where you're talking about futility. You need to talk to the specialist teams involved, the people that know the child. And that just can't happen kind of in an emergency scenario. So it is good to address these things. If the child comes to hospital with a deterioration, I think it is good practice to address these things before they deteriorate, hoping that you can avoid the deterioration with all the things we've talked about, but acknowledging that sometimes it's out of our hands and it will get worse no matter what we do. Again, I take an honest approach with families. If I believe that intubation and ventilation won't work, if I think it's the wrong thing to do for the child, I will say so. I will try to reduce the burden. The parents do essentially have the final say in what happens outside of kind of legal confrontations and things we don't want to get into. But if there's a kind of a consensus in the MDT and specialist teams that invasive mechanical ventilation isn't in this child's interest, I will say that to the parents. I will say that I would regret intubating a child, potentially them dying during the process, potentially dying during on a mechanical ventilator, when the other option is to prioritize their comfort, prioritize their time with families and relatives, and given their care back to the people who've looked after them in everyday life. I don't personally talk about quality of life in these cases. We see these children at their absolute worst. Often they're feeling terrible, they're not very interactive, they look sick. We make assumptions about their life that maybe aren't correct. when they're well and they're at home, a lot of work goes into keeping these children well. They have families who are devoted to them, who love them. They're often the center of a huge family circle that are all kind of there to support them. They get lots of lovely experiences like going to school, going on holidays, being around their brothers and sisters and their friends. So I avoid the quality of life kind of conversation. What I say is, the way I would put it is, I'm not sure our interventions are going to get your child back to where they were before, or I don't think our interventions will work. And I think it's more appropriate to make sure that the time they have is quality time rather than time spent with painful, unnecessary interventions. And it's to try and, I think we have to try and deburden the parents from the feeling of them being responsible for ending the child's life in these circumstances. It would be great to go into these things more, but I'm sort of, I feel like I've raced through and covered a sort of a broad topic very quickly. So I'm gonna stop it there, and if there's any questions or any discussion points that anybody wants to talk about, it'd be very welcome.
Thanks very much, Damien. Really important topic, and I'm maybe just a bit biased because I do pediatric respiratory as my day job, but we're seeing, I suppose, as medicine advances and as home ventilation and long-term ventilation advances, we're seeing more and more of these children and young people surviving a lot longer, and it's becoming a much bigger part of what we do. And we know that whether you're on general pediatric ward in the middle of winter or an ICU, that they do represent a large portion of the children we've seen. I suppose just 3 comments. One, can't emphasize the importance, as you mentioned, of physio in these kids. We can do the antibiotics, we can do the ventilation, so, but physio is playing a massive role. I think the other thing, and kind of you were touching on it towards the end, is around escalation of care, and sometimes escalating care isn't necessarily in their best interests, and it's a very difficult conversation to have for the first time with the parents at the time that the child is acutely unwell. And this is something we need to be thinking about early on. So children with complex medical needs or with life-limiting conditions, we really need to be having conversations early on around what the natural course of the sort of illness is likely to be, what we expect the future to hold, and have those conversations at an early stage so that we can try and, I suppose, manage expectations, and it makes those conversations much easier at the time. And whether that's enhanced care planning, early involvement of the palliative teams, I think we're getting better at it, but there's still a long way to go. I suppose the other thing that we've found useful, and this has been more recently, we've been working quite closely with one of the local trusts in particular, have some really keen, motivated physiotherapists in community, and they've been working on respiratory care plans for some of these patients in community. So a lot of our enhanced care plans deal with the sort of the end of life issues. Do you want cardiac compressions? Do you want drugs? Do you want intubation, ventilation? But actually, a lot of these kids, when they present the district generals, and again, you touched on this, Damien, they don't necessarily fall neatly into the standard APLS algorithms, and they do need sort of specialized or specific care. And actually the parents are already doing a lot of that at home. And by having a care plan which starts at home, so in the event of this sort of respiratory complications, so whether it's increased secretions or temperatures felt to be in the second setting of a respiratory illness, it's a sort of a step-by-step guide of what the parents can do, empowering the parents at home, empowering the community physiotherapy team, and then also for the DGH's help. That document kind of goes with that patient and gives them an individualized care plan. There's a bit of work in that, but it's really, really important and really helpful in this cohort of patients. So, sorry, that's just a few comments, I suppose, I had that I think all really important things that you touched on. There's a question chat just about hyacinth patches, glycoperonium. When do you stop? When do you restart? Use of hypertonic versus DNAs versus normal saline nebulizers in these patients in ICU. Have any thoughts? I mean, mine is a lot of that we're guided by our physios.
Yeah, I suppose we talk about this a lot, Ben, when we have a patient like this in PICU. It's almost like an art rather than a kind of science. So it's hard to say to someone here, this is what you do. You stop it for 2 days and then restart it, because I often say about these patients, and I'll say it to the parents, it's like the nursery rhyme, the little old lady that swallowed a fly, so she swallowed a spider to get the fly, and then she swallowed a bird to get the spider. You do one thing with medications to deal with an issue, and you create an issue somewhere else. So I would be guided really by the physiotherapists. So if they're telling me the secretions are far too thick for the patient to cough up from the lower airway, I would say, well, look, should we back off in the glyco? Should we back off in the hyoscine? And they, that would be what would indicate to me. And then they might turn around then and say, look, they're really struggling with their upper airway secretions. We maybe need to go back on at a lower dose of hyoscine or a lower dose of glyco. The families usually know this as well. And they'd be like, often they'll say, when they're like that, we've stopped the glyco already, at home, that they'll tell you. In terms of using hypertonic versus normal versus DNAs, it would usually start with normal saline, I think, in the first instance. If it's very, very thick secretions or very apparent mucus plugging and loss of volume on an X-ray, I think that you're struggling to pop open with increased escalating non-invasive support with physio. Then I would kind of step in with hypertonic and DNAs if it's kind of resistant. One thing to bear in mind about the hypertonic is that you might get bronchospasm with it, you might get wheeze, but the irritating factor to the airways means it's a good thing. It's good for stimulating cough, and I think that's kind of a byproduct of it. You get the patients cough quite a lot with hypertonic saline, so you get maybe additional benefits from that, quite apart from the kind of the mucolytic effect. So I think it's, again, as I say, it's never one size fits all. It's all about frequent assessment of the patient, trying to decide in that scenario what you need, and talking to your specialist teams, talking to your respiratory team who know this patient and who maybe know how to manage this situation, have managed it in the past, speaking to the parents about what has worked before, and speaking to your physios about the status of your respiratory secretions and what they think might be needed to help them get them cleared.
Thanks, Damien. Costas, I can see your hands up.
Yeah, I mean, I think there's a cost element to DNA as well if you work in the NHS. So like everything else. So for us, it's a stepwise approach. So we'd go, depends if the secretions are thick or not and where they're coming from. Because often these kids will be on glycopyrrolate or patches, hyoscine patches, because of high salivary secretion load. And they often have copious loose secretions, in which case giving nebs is not going to help. If they're thick secretions, then you go saline, then hypertonic, then we would go in acetylcysteine, which is cheaper, and then Dornase we would leave as a last option unless they've got CF or something like that. What I would also say is, like, I love the example that Damien gave about the old lady song that swallowed a fly. Is essentially, like I said, those drugs targeting high salivary secretions, we increasingly rely on Botox of the salivary glands, even in the acute setting, to try and work something that stops those salivary glands working. So it's worth considering if they're drowning their own secretions and they've got very thick secretions lower down, not arising from the salivary glands, then Botox, if you have a good ENT team that can do them, is worth considering.
Thanks, Costas. I think it's 20 to 5, so we'll maybe move on to the next talk. Thanks again, Damien, for that. And our last talk today is questions from the District General Hospitals. Phil Ross is going to lead on that one. So, Phil, if you're happy, I'll hand over to you now. Thanks.
Yep. Hi, everyone. Thanks for staying on for the last session of the day. I really appreciate it. And also just want to say a quick thank you to people who sent in the questions as well. There were some great questions, and I've picked some of the few that I think will be most relevant to people on today with us. And just thank you as well to the panel for having me and for agreeing to take on these questions. And hopefully we'll all pick up some tips and some useful pearls that we'll be able to take with us for our future practice. So without further ado, start with the first question. So the first question is put to the panel. Are there any diagnoses, blood results, or presentation that should prompt early discussion with PICU even before the child becomes critically unwell? Anyone wants to take that on?
the tricky bit is before they become critically unwell, because there's plenty of diagnoses that we would worry about, like Costas's mediastinal mass, an asthmatic, you're about to intubate; a septic patient, you're about to intubate; a myocarditis. But the trick is they've all become unwell by the stage we would be seeing them in ICU. I can't think of any that are well that you would.
I suppose partly what should be helpful is, I think as times in the District General, as a trainee in particular, like, oh, is this something PICU would want to know about or not? Is there any things in your head that sort of trigger, a quick referral? Yes, actually, this is a patient we would want to know a bit about sooner.
So I think they're all the ones I've said. If you think you're heading towards intubation with an asthmatic, we'd want to know about it. Any baby that has a myocarditis, congenital heart disease in particular, mediastinal masses, anything that can go wrong if you don't manage it right, or any ways that we could save you from intubating it, they would be the ones that I would think of.
You're hyperammonemic as well, especially neonates. If you have a hint of a slightly high ammonia, so 100, 120, that's often put down as sick baby ammonia. I'd like to know about it there and then to move them out, rather than sit and wait for it to be 500, in which case the neurological outcomes are far, far worse because they're so neurotoxic. So often these babies with an ammonia of 100 might look not that unwell, but if there's a history of consanguinity and stuff like that, that would push the threshold into me thinking this is an evolving severe hyperammonemia. I need to take them on the unit and be ready to filter them as soon as I can and start scavenging therapy as soon as I possibly can, before waiting for them to get, ammonias in the 500-600s, often in the thousands if we wait too long.
Okay, yeah, I think I've had a couple recently as well, particularly cardiomyopathies, who have been really tricky and really challenging, and they've came through from the transport team and been referred, and yeah, they're definitely ones to know about early, and as you've mentioned, so absolutely. The next question, which I think everyone, particularly working in district generals and working as trainees, we all come across over the winter, is the bronchiolitis patients, and the bronchiolitis patients who are on high flow. And from seeing it from both sides, of being in the district generals and from working in the PICU side, you get quite a few referrals of these patients on high flow, and it's trying to decide which ones of these patients are going to need escalated. So the question I put to the panel is, what helps you decide when a child with bronchiolitis on high flow needs escalation to intubation?
I suppose the answer is when they're failing on high flow. The one thing I think get quite frustrated about in an ICU with referrals is they are at risk of tearing. I think that triggers all of us. We're worried about them tearing because that's something you say about anybody. And I suppose from our point of view, we worry about DGHs intubating patients that don't need intubated, and all the morbidity and potential mortality that goes with that. So we wouldn't intubate a child because we're worried they would tear. They actually have to be failing on the high flow. Before we come on to that, the other thing is you don't want to leave it too late either. That's another big frustration. I get quite concerned when people are happily sitting on 80-90% oxygen on high flow, because you have absolutely no reserve and you've missed the window to allow a safe intubation. So I think it depends. You want to get the child when you try to turn them around and you're not turning them around before they're in extremis. So for me, round about that 60% oxygen figure would be a figure in terms of oxygen that I would worry about. Have they exhausted all the other options in terms of, have they got the physio in? If it's an older child, have they tried nebulizers if they're particularly wheezing? Not looking at the typical under 6 months. But have they done suctioning? We're told that nasal suctioning is bad with our nice guidelines, but if it's going to save you putting the tube in, it's a good idea potentially to try it, and that often sorts a lot of kids out. So I think it's, have you exhausted all your options, and are they actually failing in terms of either hypoxia or hypercapnia? And a slightly elevated CO2 wouldn't necessarily worry us, and we're quite happy to relax our oxygen. A kid who's saturated 88% is fine.
I think the other thing this time of the year, just is always to be, we see so many, well, with vaccines and so on, this might change, but so much of what we do in general pediatrics this time of the year is bronchiolitis, and it's trying not to miss the kid who's not responding to treatment that is maybe something different. So yes, they might have a chrysal illness and a cough, but they may also be a presentation of a cardiac issue, for example, which would be kind of one of the common things. So I suppose it's always being open mind. So if you've got a kid who's not responding and you're worried, always think about other diagnoses as well. It's not necessarily just the bronchiolitis. So don't be afraid to think outside the box and make sure you're not missing something else.
Sorry, just to add, I tend, when people phone me about bronchiolitis, I find the increased work of breathing a subjective thing that they're telling me, and that's really difficult for me to kind of interpret, because different people will be worried about different things in terms of subjective measures of work of breathing. So I kind of want objective things that they're telling me. So if they've got them on high flow, as Chris says, is their oxygen requirement climbing and climbing and climbing? That tells you that high flow is failing. On the other hand, if you've turned their oxygen up to 100% on high flow and they're saturated at 100%, I would say, could you try turning it down and seeing what happens? I would say tolerate SATs, of 88 to 90. If this baby's otherwise coping. Other thing that's objective measures that are really important thing in bronchiolitis are heart rate and respiratory rate. So if the patient's working really hard on high flow, but since you've put them on high flow, their heart rates come from 180 to 140, I would be less worried. And similarly, if the respiratory rate's gone from 80 to 40 on high flow, that would make me less worried. Conversely, the other way would be true. If the heart rate continued to escalate, the respiratory rate continued to escalate, that would be concerning. In terms of blood gases, I would say, yes, okay, you've done a blood gas and it's okay on high flow. Please don't keep doing them, because I find that people get really worried about these babies and then keep poking them and they never get them a chance to settle. And actually their numbers have all gone off because nobody will leave them alone. So I'd always give them a period of hands off when they're established on high flow, just to see where they are. And then consider putting them on their front as well, nursing them prone, because that, that's a good thing to do. Sometimes babies prefer it.
Yeah, some really helpful advice there. I think Damien, just add to that, maybe if there was a video referral available to see the work of breathing, that might be helpful. Just side note for something I'm working on. So the next question I'll bring you to, which again hopefully get some of your input on, is are there any common avoidable issues you see when children are referred from the district general hospitals?
Well, I can think of a few. The biggest one is the right main bronchus intubation, I think, which occurs quite frequently. And we did a wee project to try and help avoid that. And I think the big thing is when you've got adult people intubating small babies, the natural tendency is to put the tube in further than what it needs to go. When the tube's been taped, it tends to get pushed in a little bit further. And people don't tend to take the time. They're just so happy to see a glimpse of cords, the tube goes in and they come out, and they're happy to wait for the first x-ray. So I always encourage people to go back and have another look. Go get the intubation done, bag the child up, but go back and have a look and reposition the tube with the black marks at the cords. Save that number away straight away, because it will move when you're trying to tape it in. And just before that tape goes round that tube, make sure it's still sitting at that number. And that's probably the best way to avoid that complication. I'll do one more with others are thinking. The other big one is the overdoing the lines. I think we were talking, Damien and myself were talking about this recently. Your typical seizure when they come to ICU, if they even need to come to ICU, we have them extubated within the hour and ready to go back to the ward within a couple of hours. So they don't need central lines, they don't need arterial lines, they don't need nasal tubes. And for the large majority of them, they don't even need to come to ICU. So it's overdoing the certain patients.
Anyone else?
The only other one I would add. Oh, sorry, go ahead, Costas.
Wrong tube size. They often, I find it frustrating when they either use an uncuffed tube and there's high leak and you can't mitigate by inflating the cuff a bit more, or using too smaller tube, using a 3.5 on a 2-year-old, for example, which is not uncommon, in which case you either need to risk intubating them, which is, if they're critically unwell, obviously it's a high risk process, or, or you needing very high pressures, in which case you're risking all sorts of barotrauma and badness en route to get them to PICU. Just get cuff tubes if you can, and do the right calculations to get the right tube right the first time, because re-intubating these children is significantly risky process, and also makes more work for yourselves and everyone else, which is not something we want.
Laura?
Yeah, the other point I was just going to make was after you've intubated a child for a chest infection, whether it be bronchiolitis or pneumonia, not doing suction. These kids always have a secretion burden, and they often get worse after you intubate them, and you can often relieve that by just doing suction. You might need physio, and that might not be available in the DGH, but you can at the very least clear what's there.
I'll add another one in. It's time critical transfers and delaying them for unnecessary interventions. And I think the big thing, the tip I was always given as a trainee, and it sticks with me as one of the best pearls, is once you realise that you've got a time critical transfer, phone the ambulance and have them come and stand at the bottom of the bed, and that just stops you doing anything unnecessary. It stands as a reminder that you need to leave, and you don't need to put all these lines in, you don't need to fine tune your ventilator. There's a reason they're here, and that's because you need to get the child to a neurosurgeon, for example. So call an ambulance when you've got a time critical transfer without any delay, even if you're not ready to leave.
Okay, I think that leads quite nicely on, just in case there's any other points on the another question that came through, which was about balancing stabilization versus a rapid transfer. So with regards to transfer and stabilization, when is good enough, and how to manage that balance? Sometimes I think it can be tricky. And any other points to add on that one?
I think it depends why you're transferring the child. If it's time critical, it's obvious you do the bare minimum, because what I think you're doing in intensive care is weighing up risk of doing versus risk of not doing. So you stay too long and keep the child away from the intervention that's going to save their brain, save their limbs, save their life. That's not in their best interest. If we leave time critical stuff to the side, which is the majority of our work with the retrieval teams coming out, I don't see us as a transport team. I see us as a mobile intensive care unit. So there is no hurry whatsoever for us to leave, and we should be staying until we're happy the children are stable to move. Because what really are you moving them for then? We should be coming out with everything that we need to stabilize them. We've got a team. We can take our time and not take any risks. So that's the way I see it.
I think it's geography dependent also, Chris. There's a number of retrieval teams in the UK. Scotstow, for example, covers the entirety of Scotland, and has lots of tiny islands up in the Highlands. You need to stabilize the patient properly before you move them over a long distance, or even by air into the PICU. Whereas if you're in London, which has 2 retrieval teams, their nearest PICU is a 15-minute hop and skip down the road, even if you're in what's classed as a remote London DGH, because there's so many PICUs. So you can scoop and run even with a wobbly patient. And this is reflected in data as to how senior the most senior retrievalist is on each of those retrieval teams in general. The London teams have mostly senior nurse trainee-led transfers, whereas if you come to my retrieval team at Newt or Scottstar, you have, you know, very, very senior trainees and consultants running most of them because of the distances. So it's not just pathology dependent, it's largely to do with geography, I think. I don't know your setup in Ireland, but I would have thought you have quite big distances to cover, so you need quite senior people. And
I'd have to agree with you there, Costas. As again, I'm seeing it from my own eyes, and we would never have a trainee doing the transfer. It's all consultant delivered. So for me to actually scoop and run with a child when I'm bringing them to somebody at the same level as me doesn't make sense. And you know, we've got our transport team staffed. You know, we go out with ultrasounds, video laryngoscopes. We've got all our stuff for our lines, drugs. There's no reason for us to scoop and run those patients because they're going to somebody of a similar level. So most of the time we'll take our time and we'll stabilize. And like I say, I see us as a mobile ICU, but I agree in other settings, like you say, you're actually going to that senior experienced help. So it makes perfect sense what you say.
Okay, thanks very much. We'll maybe end with just one more question, and then that'll bring us up to 5 o'clock and hopefully time to close. So just, I know inotropes has been mentioned a couple of times and with the sepsis talking things, but again, just looking for some advice about giving district generals about when to start inotropes and which inotropes would be deemed appropriate before the transport team arrive.
So I've already given my thoughts on that in the sepsis talk, so I'll leave this to somebody else.
Anyone else? Any thoughts?
I mean, there's no one size fits all. You know, we've moved away from dopamine over the last 5 years, so that used to be first line and no longer is. In fact, it doesn't make it onto any sort of sepsis protocols anymore, nationally or internationally. So, you know, your fail-safe is most people use adrenaline as first line. And NORAD as second line, and after that, you know, you would hope you have an intensivist to decide whether you need vasopressin or plus or minus milrinone. I wouldn't be touching vaso or milrinone without an intensivist present. So, general rule of thumb: if you're unsure, adrenaline is first safe choice for most cases, and NORAD as a second if you're struggling. And if you're hitting the 2 inotrope mark, use your steroid, because then you're into your catecholamine resistant shock. So once you hit 2 inotrope requirements, always use steroid. And you will have a heads up from a patient if they're really sick and their sugars are low normal or low, you know you're heading into that direction that they're going to need that steroid anyway. So be vigilant. Don't be reassured by a normal glucose if it's low normal and the child is dog sick.
Okay, thank you very much. Hope everyone's picked up some useful pearls. It's great to have such an experienced panel and be able to put some of these questions too. So I just want to say again, thank you very much for the panel for taking some of the questions and for people who sent their questions in. So thank you very much again, everybody, and I'll pass you back to Ben.
Thanks, Phil, and yeah, thanks to everyone involved in that session. And the conclusion of that session brings our conference this year to a close. I hope you've enjoyed it and found it educational and informative. I know certainly as a panel we have, and I'd like to say thank you to everybody who joined us in the YouTube chat for attending today. Thank you for your engagement, which always makes it much more interactive and enjoyable for everybody. Special thanks to everybody involved in coordinating today, for those who gave talks, those who are involved in setting it up. There's an awful lot of planning and work goes into making this happen every year, and we're grateful to everybody who sort of put any sort of effort in, whether behind the scenes or giving talks today. So thank you, and in particular special thanks to Chris Flannigan, who I suppose leads on the whole operation in terms of getting the courses organised, getting the talks or the speakers and the lineup all organised, and the IT side of things along with Tudor. So thank you, Chris. Just a final word of thanks to our sponsors, particularly Healthcare 21 for donating the prize for our quiz today, the McGrath Mac Video Laryngoscope. And I suppose just another reminder that if you have enjoyed today and you want to give something back, please do consider a small donation to our charity, the Little Heroes, which is the Royal Belfast Hospital for Sick Children charity. And they've been very supportive of us over the years, allow us to do what we do. So please do consider supporting them. And I suppose if you enjoyed it and you want more from the Paediatric Emergencies team, please do consider coming to our courses next year. Our intubation course on the 30th of April 2026 and our practical workshop the next day on the 1st of May. They're run together, so you can come, do them both, enjoy them. They're always great days, great learning, and we learn as much from those attending as they hopefully do from us as faculty. So it'd be great to see you there. Sign up details are on the website. And other than that, just thanks again for joining, thanks for engaging, and we will see you next year. Take care.